a welcome change. So, on behalf of the organizers, I extend a warm and hearty welcome to all our guests, delegates, and faculty to this third comprehensive update on genito-urinary malignancies. This edition is special as Mumbai Oncocare Centre, which is emerging as the largest chain of cancer daycare centers in India, is sharing their immense experience and knowledge by joining hands and heads with the Urologic Cancer Foundation to bring to you the most comprehensive and latest scientific update on GU malignancies. Coming together is a beginning, keeping together is progress, and working together is success. And I'm sure you'll find yourself participating in the most stimulating academic discussions in the next 2 days. I request Dr. Santosh Menon to please come up here on stage and set the sessions in motion by a brief welcome to our guests and delegates.
A very good morning to all dear friends, colleagues. It's good to meet physically after a couple of years of break of wisdom. So Wisdom of Waves had in mission to update all urologists, uro-oncologists, specifically dealing with urological malignancies, based on abstracts of different conferences. It is difficult for us to keep ourselves abreast with the changes and attend all the conferences, especially the conference which are held abroad. And the Wisdom of Waves was an attempt to briefly hit upon these abstracts and discuss. So on behalf of UCF and also on behalf of MOC, I would like to welcome everyone. We will have a good academic session. The idea is to thrash out the abstracts and see whether they can be put up into our practice, how useful they are, what are the shortcomings of those. So once again, I welcome everyone and hope to have good academic sections. Thank you.
Thank you, Dr. Santosh Menon. Before we begin with the scientific sessions, may I request you all to please put your mobile phones in silent mode or airplane mode. And I request the chairpersons and speakers to please honor the time slot allotted to them in interest of the timely conduction of the meeting. I will have to intervene if the time is exceeded. Our first session is on prostatic cancer, and to chair this session, I would like to call upon as chairpersons Dr. Amit Ghosh, who is a consultant uro-onco robotic transplant surgeon at Apollo Multispeciality Hospital, Kolkata. Sir, you would be requested to please be seated where the chairpersons are to be seated over there. Dr. Ɂagship, senior urologist from AIIMS, Delhi. Dr. Santosh Menon, who is a professor in pathology at Tata Memorial Hospital, Mumbai. Presenters of the abstract, please note you have only 3 minutes per abstract, so please finish on time. I invite the first speaker for the first session, and Dr. Aparna Katdare will be presenting the first abstract. Dr. Katdare is Assistant Professor, Department of Radiology, Tata Memorial Hospital, Mumbai. Over to you.
Yeah, good morning, everybody. Thank you to the organizers for giving me this opportunity. So the abstract that I'll be presenting is a unique comparison of prostate cancer detection rates between transrectal versus transperineal MRI truss fusion prostate biopsy among 794 cases by Genito et al. So currently the transperineal biopsy is preferred over transrectal biopsy because of the lower risk of infectious complications in a transperineal approach. The prostate cancer detection rates without MRI fusion are comparable between the two approaches. So the aim of this study was to compare these detection rates between transperineal and transrectal approaches when MRI truss fusion biopsy was performed. So among the methods, this was a prospective inclusion of biopsy-naive men, men with prior negative biopsy, and also men on active surveillance with suspicious lesion on MRI. The biopsy was conducted between April 2013 to October 2021. So before 2019, it was the transrectal biopsies, and thereafter the transperineal biopsies were considered, both under local anesthesia. The detection rates of clinically significant prostate cancer, which is grade group 2 or above, between the two approaches were compared. And for active surveillance, the endpoint was defined as reclassification into a higher grade group. So these are the results. Basically, there were total of 794 patients, of which transrectal biopsy was done in 575 and transperineal was done in 219 patients. So where there was a suspicion of a prostate CA, and then there was an active surveillance group. So in the ones where there was a suspicion of prostate CA in biopsy naive population, at that time the biopsy naive and the previous negative factors were corrected, while in the active surveillance group, these were corrected for the number of previous biopsy procedures. Further, there were corrections on other factors which I'll elaborate here. So multivariable logistic regression analysis was done, and the results were that in patients with suspicion of prostate cancer, the detection rate for clinically significant prostate cancer for transperineal and transrectal biopsies was 59% and 58% respectively, so not significantly different. While for those on active surveillance, the reclassification into the higher grade group was 44% for transperineal and 38% for transrectal. So that also did not differ significantly. Further, the corrections, apart from the number of previous biopsy procedures for active surveillance and for the indication in case of biopsy naive and previous negative, there were also corrections for age, PSA density, digital rectal examination, PIRADS category, and the number of cores per lesion. So the conclusions drawn were that the clinically significant prostate cancer detection rates as well as reclassification rates in men on active surveillance were comparable between the transrectal and transperineal approaches with MRI truss fusion biopsy. So the take home here could be that transperineal is also a safe technique both in terms of infectious complications as well as cancer detection when MRI truss fusion is used. Thank you.
Hello. Thank you. It was a good presentation, very crisp, but in transrectal ultrasound guided...
Sir, may I...
Okay. So no questions. So we'll pass on to the next...
May I request Dr. Mrinal Malaya, who is a consultant histopathologist at Hinduja Hospital, Mumbai, to have the next presentation, please?
Good morning. I thank the organizers for this opportunity. I'm going to present an abstract on risk of adverse pathology after deferred prostatectomies for grade group 1 and grade group 2 prostate cancers being managed by active surveillance. This was presented by Cheyenne Williams. So the introduction and objectives. There are similar pathologic and oncologic outcomes between low-risk patients on active surveillance and patients who receive immediate radical prostatectomy. However, active surveillance for grade group 2 disease remains controversial. This study described pathologic outcomes among patients with grade group 1 and grade group 2 prostate cancers initially managed with active surveillance who underwent radical prostatectomy later and compared these with risk-matched patients who went immediate prostatectomy. So methods used were the patients who received radical prostatectomy more than 1 year after being more than 1 year on active surveillance, and patients who underwent immediate radical prostatectomy were identified. The criteria included for active surveillance included grade group 2 prostate cancers without evidence of adverse features on MP-MRI. All patients who received combined MRI targeted and systematic biopsies at active surveillance enrollment and every surveillance biopsy. The final radical prostatectomy pathology was then compared between NCC and risk-matched patients from each group, and multivariable logistic regression was identified. to identify the adverse pathology upon radical prostatectomy. Results: 468 patients with grade group 1 and grade group 2 prostate cancers were enrolled in active surveillance, and 83% patients underwent radical prostatectomy after discontinuing active surveillance. Of these, 26 patients, which was 32.5%, were on active surveillance with grade group 2 disease, and 56 patients, which was 67.9%, were on active surveillance with grade group 1 disease. The median time to radical prostatectomy among active surveillance patients from the date of diagnosis was 39 months. So when compared with 387 risk-matched patients who underwent immediate radical prostatectomy, with a median of 4 months after diagnosis, there was no difference in the rates of adverse pathology. Adverse pathology seen were primary Gleason's pattern more than 4, positive margins, extraprostatic extension, and seminal vesicle invasion. So there was no difference in the rates for any type of adverse pathology, nor the presence of any adverse pathology between the cohorts as a whole, and when compared with NCCN risk-matched groups. So on multivariable regression, independent predictors of adverse pathology were preoperative PSA density with an odds ratio of 1:1.2, and NCCN risk group of intermediate, unfavorable, or high. These were independent predictors of adverse pathology. Time to radical prostatectomy did not predict the adverse pathology. So to conclude, in this active surveillance cohort that included grade group 2 patients, patients who received deferred radical prostatectomy after active surveillance had similar rates of adverse pathology compared to patients with matched risk who underwent immediate radical prostatectomy. And further research with longer follow-up will evaluate the oncologic and mortality outcomes in grade group 2 disease. Thank you.
Thank you, Dr. Mrinal. I invite the next speaker, Dr. Vivek Venkat, who is consultant uro-oncologist and robotic surgeon from Mumbai.
Kiran, I can't see that. Where's the mouse?
Dr. Vivek will be presenting 2 abstracts back-to-back. So, Dr. Vivek, please keep your time. Thank you very much.
Good morning, everyone. Thanks for this opportunity. So our first abstract is a discussion on surgery versus radiation therapy for ductal carcinoma of the prostate, which was presented at the AUA as a moderated poster by Chiarego et al. So the introduction and the objective of this paper was to compare cancer-specific mortality rates between RP and external beam radiotherapy in patients with ductal carcinoma variant of prostate cancer. So this was a SEER database study from 2004 to 2016, and they could include about 369 patients who they identified with ductal carcinoma. They used 2 cohorts for analysis. One was an unmatched cohort, and then they did propensity score matching and inverse probability of treatment weight. So these are 2 specific statistical methods to try and equalize both the cohorts. So RT patients were generally older. They had a higher PSA, higher clinical T stage, and higher Gleason grade group. And the 5-year cancer-specific mortality rates in the overall cohort, which was unmatched, was 4.2% for radical prostatectomy and 10% for RT. So a very significant benefit for surgery in an unmatched cohort. But when you do a multivariate regression, there was no difference. This mortality benefit disappeared. And similarly, for the propensity score matching and the IPTW cohorts, there was again no significant difference between RP and RT. So in an unmatched cohort, they concluded that the cancer-specific mortality in radical prostatectomy patients is lower, but this disappears after adjustment for population differences. So quick comments on this paper. It's a very rare kind of prostate cancer, which are generally aggressive at the time of presentation. And we need to take all database or registry studies, with a pinch of salt. Always be careful of conclusions from such papers. Of course, when you're doing a pathologic study, it would be ideal to have a path review and to make sure, people are grading it in the same way. And of course, variants of prostate cancer do need further study to identify the best treatment option. Our second paper was on the impact of MRI and the risk of positive margins based on the location of the index lesion at the time of radical prostatectomy. And this again was presented at the AUA as a moderated poster by Barletta et al. So MP-MRI, they felt, might reduce the risk of positive margins in men with non-palpable prostate cancer who are undergoing nerve-sparing radical prostatectomy. And they believe that the positive margins may correlate with the location of the index lesion, which is seen on the MRI. So they thought that the index lesion and the positive margin should be in the same place. So this was a study of 307 consecutive patients in a single center from 2018 to 2021 who were diagnosed by MP-MRI targeted biopsy and treated with nerve-sparing prostatectomy. So 283 had all the relevant information and they were analyzed. So they used chi-square logistic regression to find out if the index lesion site and the positive margin site correlated. So most of these patients were grade group 1 and 2. Very few, about 1/3 were grade group 4 and 5, and still they were undergoing nerve-sparing procedures. The base had 19% of index lesions, lateral side 52%, and apex 29%. Total of 14% positive margins, n equals 40. And when you saw the concordance rate, it was only 37%. That means 2/3 of the time the index lesion did not correlate with the site of the positive margin. And it correlated most commonly when the index lesion was at the base of the prostate as compared to the lateral side or the apex. So they concluded that men with lesions located at the base have a higher risk of positive margin at the same site. Conversely, individuals with a lesion at the lateral margin or apex, they harbor positive margins elsewhere. So they believe these findings could help surgeons in guiding the optimal extent of dissection during nerve-sparing prostatectomy. So in my opinion, this study really does not have much clinical value. We need to be aware of the limitations of MRI. It may not predict where margins can come positive. What is more important is the tumor biology. And if you are in any doubt, you can use NeuroSafe, frozen sections, or go wider. And similarly, in an Indian scenario where we get mostly locally advanced high-grade disease, probably this paper is not that relevant. Thank you.
Thank you, Dr. Vivek Venkat, and double thank you for keeping the time, or rather saving me a minute. Dr. Ɂagship will be presenting the next two abstracts. He's a consultant in urologic oncology at Kokilaben Ambani Hospital, Mumbai.
ये मूव नहीं हो रहा यार. नहीं रहा. Please go back, go back. हाँ ये ओपन नहीं हो रहा. क्लोज करो, क्लोज करो. Is it come? Yeah, good morning. I'm talking about the use and outcomes of men with NCC and favorable intermediate risk prostate cancer managed with active surveillance. And it was an abstract number MP 4311. We know that active surveillance is a standard of care in low and low risk. It's a proven oncological safety and maintains the quality of life. There has been an increased interest to expand these indications to intermediate risk cohort, and it is well supported by PROTECT trial, where they found that when they included intermediate risk prostate cancer patients, the outcomes were similar to RP and RT. But we needed, in fact, there is a study which looked at more than 50% Asian men with incidental prostate cancer. Autopsy harbored evidence of Gleason's grade 2 disease or worse. Now, the aim of this study was to describe the use, the factors associated with, and the time on active surveillance for men with NCC and favorable intermediate risk prostate cancer. They took men from 2016 to 2020, and the selection of active surveillance defined as when the patient who received primary management strategy or the absence of treatment for the least 12 months post-diagnosis. The idea was to estimate the treatment-free probability of patients on active surveillance, either in entire cohort or stratified by patients without or with use of tests such as genomics, MRI, and repeated TRUS or targeted biopsy. They also wanted to assess the association of clinical, demographic, and oncological factors, and that's how the study was designed. So 2473 men were included, out of which 40% chose active surveillance, and these are the three broad parameters under which they clubbed their results. One is the use. They found that the use of active surveillance increased from 33% in 2016 to 48% in 2020. But there was a notable variation in the choosing of active surveillance in each practice. You can see the variability from 17% to as much as 56%. When you looked at associated factors in a multivariable model, they looked like increasing age and these tests, confirmatory tests, were associated with increased odds of selection of active surveillance. But presence of Gleason grade 2 was associated with decreased odds of selecting active surveillance. As far as time is concerned, estimated 24-month treatment-free probability, 83% of patients without a confirmatory test versus 87% for patients with a confirmatory test, and 78% of patients with non-confirmatory, which is where they have not used genetic tests and other tests. So the conclusions are the use of active surveillance for men in this category has increased. There has been a notable variation in selecting active surveillance by contributing practices. Confirmatory tests may prove valuable in helping select men, and also the intensity of follow-up in these patients. As far as this paper is concerned, I believe that active surveillance is something which is not much practiced in our part of the world, where the patient doesn't select much in favor of active surveillance, and also the use of genetic tests. How applicable it is to our part of the world is something which we need to think about. Can you help me a second? Can you help me second presentation? Yeah, okay. The second presentation is about comparing a target versus target plus standard biopsy for prostate cancer diagnosis in biopsy-naive patients. It's a randomized controlled trial. So what is the gap in knowledge? We know that biopsy-naive patient with a suspicion of prostate cancer performing MP MRI guided target biopsy associated to or in place of standard biopsy is something which is still discussed. What is the aim of the study? It's a randomized controlled trial. We looked at the evaluation of the detection rate of overall prostate cancer and clinically significant prostate cancer in patients with positive MP MRI who either underwent a targeted biopsy or targeted plus standard biopsy. So it was a single center study where they included patients less than 75 years of age who are biopsy naive. The PSA was less than 15 nanograms per ml, and it was positive on MP MRI with pyrites more than 3. Group A underwent targeted biopsy either by transrectal or transperineal fusion biopsy, and Group B underwent targeted plus standard biopsy by standard transrectal biopsy. Two important parts are cores. In targeted biopsy, 4 to 6 cores were included for lesions less than 8 and more than 8 mm respectively. In standard biopsy, more than 12 cores were included. And the definition of clinically significant prostate cancer for target biopsy was ISUP more than 2 for target biopsy, and for standard biopsy was the updated Epstein criteria. They looked at the overall cancer detection rate and also the detection of clinically significant prostate cancer. If we look at group A and group B, we'll find that it's almost similar with not much significant. But if I focus on group B only, which is standard biopsy, we'll find that they were able to find a lesion contralateral to the index lesion. Also, there was upgradation, though these findings are not that significant. So what does that mean? I am here to conclude that in patients who are biopsy naive, suspected CAP, on a positive MRI, standard biopsy and targeted biopsy, there was no significant increase in the overall detection of clinically significant prostate cancer. And even if a non-negligible rate of clinically significant prostate cancer were diagnosed by standard biopsy alone. Thank you so much.
Thank you, Dr. Santosh. We now have a panel discussion on prostate cancer. And I invite as moderator Dr. Ɂagship, who is a urologic cancer surgeon from Pune. I also invite all the panelists, Dr. H.S. Pava, Senior Consultant Uro-Oncosurgeon and Urologist at King George's Medical University, Lucknow, Dr. Sanjay Sureka, who is Associate Professor, Department of Urology, SGPGI, Lucknow, Dr. Vivek Anand, who is a Consultant Radiation Oncologist from Hinduja Hospital, Mumbai, Dr. Vinod Joshi, who is Professor and Head, Urology, PD, Hinduja Hospital, Mumbai, Dr. Karthik Ganeshan, who is Clinical Director, CTMR Department of Radiology, Sir H.N. Reliance Foundation Hospital, Mumbai, Dr. Asavari Ambekar, who is a histopathologist and lab director, ACE Diagnostics, and a visiting senior consultant at Apollo Hospitals, Navi Mumbai, Dr. Manish Chandra, who is senior consultant radiation oncologist, Jupiter Hospital, Thane. I think he's not there. Dr. Satyakam S., who is a consultant histopathologist at PD Hinduja Hospital, Mumbai. Dr. Mahendra Pal, who is Professor Uro-Oncology at Tata Memorial Hospital, Mumbai. I hand over the session to you, sir.
Thank you very much. So good morning, everyone, and thank you for the first physical conference after the COVID, and thank you, Dr. 韆 sir, Urologic Cancer Foundation, and Mumbai Oncocare Centre for giving me this opportunity. There are six abstracts which were presented. I have grouped them into 3 different groups. The first 2 abstracts were on cancer detection rates on the biopsy technique, so these questions are related to that. Let's begin with Dr. Vinod Joshi. So how often do you encounter, Vinod, can you see the slides? Yeah. So how often do you encounter the infectious complications after a transrectal biopsy?
Hello, yeah. We see about 5 to 7% of the cases who undergo transrectal biopsy to have a 5 to 7%? 5 to 7%, which is very high in my opinion.
Okay.
And out of these systematic, they usually present with burning sensation and low-grade fever. Which doesn't
How many are serious complications? Which
serious complications are less than 1%, very, very rare. And mortality I have not seen in last 5 years.
Dr. Pava, what's your protocol for prevention of such complications? Do you have any standard protocol?
So routinely, like first of all, the case selection, this is important. Like if patient is already having, if there is any evidence, patient is having dysuria or acute prostatitis,
no, that is
those
understood.
Cases we avoid.
That
Otherwise we are...
For a routine, what's your standard protocol?
In the morning, cleansing enema and antibiotic, quinolone.
Do you give enema to everyone?
Yeah. Routinely, clear bowel I want, like during procedure.
What about the antibiotic prophylaxis?
And like levofloxacin, before and 2 to 3 doses.
No injectable antibiotic. You don't give any injectable like amikacin or an...
No. Usually preference is levofloxacin single dose or 2.
Mahendra, there has been talk about doing a rectal swab cultures preoperatively. Do you do that?
No, sir. We don't do rectal swab culture. Only the patient is symptomatic or maybe having some diarrhea. We don't do in that cases also. But normally we don't routinely perform rectal swab culture for the
Dr. Sanjay, do you have ever had the occasion to employ these rectal swab cultures, which so much talked about the infectious complications? Do you do it as a routine in your institute, Sanjay?
Yeah, we have started doing a pilot project on this. So we included.
So do you do it in your practice routinely?
Yeah, now we are not doing, but we have done for 50 patients and we found it's not useful in ours.
Okay.
So, stop doing it.
There is so much talk about the infectious complications. Dr. Sanjay, have you migrated entirely to transperineal biopsy?
No, still not.
You are still not, okay. I learn, Dr. Vivek, you have an experience of doing transperineal biopsies. Could you briefly mention us the advantages and disadvantages?
Yeah, the biggest advantage is I can, because of my brachytherapy experience, I can target any corner of the prostate, and systematically we can do along with the targeted biopsies. So target is actually, we have the cognitive along with the MRI. So Dr. Santoshi is in the crowd. He can tell us more. He was the one who, taught me.
What's your experience, number of cases?
Number of cases, we have done about 25 to 30 cases the last 3 to 4 years. And we have found...
Santoshi, could you give us a little brief?
Patients who were prostate biopsy naive, as well as the patients who have had rebiopsy. So the strike rate was definitely high. Of course, it was a cognitive biopsy, that was our limitation.
Okay, fine.
But I think
Anand,
that's
you have an experience on transperineal biopsies.
So we've been doing transperineal for the last 3 years now, across more than 200 cases. Our case detection rate for the first 50 cases was about 82%.
Yeah. Okay, go ahead. We can hear you. Cognition based. Always a cognition, not fine. Okay. So, okay, thank you, Anand. So, Sanjay or Mahendra, could you tell us, do you feel there would be a wider adoption of transperineal biopsies in India? Do you foresee any difficulties? Maybe Mahendra first, then Sanjay.
At present, the transperineal is the most commonly done. Transperineal definitely need expertise to perform and need a good training.
You will need a template also.
Yeah. So this is a little bit complicated than the transrectal. So definitely at present, we are not doing so frequently in India also. Maybe in future.
Now it's accepted, the infectious complications are less, but I feel there would be still time before it will be a widespread adoption. Maybe people like Anant and Santoshi would teach more to wider general urologists and uro-oncologists. Okay.
Comment,
yes.
Dr. Kashyap. The ASTRO, American Society of Radiation Oncology, and ABS, American Brachytherapy Society, has started a course. Those who have the brachytherapy facility for stepper and stabilizer, they are teaching everyone to do transperineal biopsy.
So again, the penetration of a brachytherapy is still limited in India. So that also. Santosh, you want to say something?
Yeah. Just wanted to add that in transperineal, the chances of picking up an anterior prostate tumor is a little high. And these are the tumors which may repeatedly present with higher PSA levels, but you are not able to detect on undivided. That's the possible advantage.
Unless you direct the biopsies there.
Yeah.
Okay, fine. So coming to the second, so how many of you have an access to an MRI truss fusion biopsies amongst the panelists?
No, only cognitive. We do not have. But
you don't have
we are buying a system close to January, February. We should be getting.
So Anand, you have been doing cognition biopsies. Do you feel is there really a difference between a cognition versus you need to have that fusion software and all that?
To be honest, no. If you know how to read the MRIs, then you're pretty much okay to do it cognitively.
Okay. So similarly, Mahendra, how many times do you feel no? I should have had an MRI truss fusion biopsy. I'm not able to pick up.
Only thing is that when the clinical scenario serum PSA is rising and all the biopsies are negative and it's still raised, only that thing, I feel there's we can prove that it is a need of
there are two scenarios. One is a biopsy naive and one is post-surgery.
Rebiopsies.
So, rebiopsy and active surveillance. So, in biopsy naive, I think 1 out of 20, this is a 5% patient, we think we're missing something, we need a fusion biopsy.
Very briefly, do you think this discussion will be in the background with the advancement of better imaging and radiomics in the future? Particularly with the advent of PET CTs and radiomics, I think this discussion may go into the background.
It may not be useful, but we'll have to wait for that. Radiomics is still going to come up. So coming to, suppose...
I think we have a radiologist also, maybe Karthik can
Karthik, you have the...
Yeah, so what I really feel is...
are you into radiomics?
Yeah, we are into radiomics. We are into first order as well as second order radiomics, texture analysis, and so on and so forth. But the real challenge where I realize when you're looking for transperineal, where the real thing which we have realized in our experience over the last 9 years of using the updated classification is an anterior lesion. So I completely agree with Santosh that when you're looking at AFMZ lesions or lesions in the anterior horn of the prostate, even if you're using MR-guided fusion biopsy, we have the software, we had some glitches, we're re-getting it again. The anterior horn is where you can actually miss the observations, and you do an undersampling of the observation very often. So that's one place where it really works. And also, radiomics plays another role is MR objectively shows you one dominant observation. But you can have clinically significant cancers which are smaller, which are not obvious to the eye. So that
radiomics may pick up.
Multicentrality will become another big thing with this.
I just want to add something that we are doing PSMA PET-guided transgluteal biopsy.
Okay, we'll come to that a little later. Okay. So, Mahendra, suppose there is a scenario in a non-palpable, so this is about the targeted only or the target plus standard. Suppose this was the scenario, 55 years male with a PSA 4.8 and a single index lesion in the left base. Are you still comfortable doing only a targeted, or you do both targeted plus standard biopsies?
Sir, I would like to do targeted plus standard biopsy.
You are not comfortable doing only a targeted?
As the abstract has been presented, so the criteria was serum PSA was less than 15 and size was less.
So are you comfortable or no? Not yet.
No, I will do with the standard biopsy with targeted biopsy.
Suppose there was an additional lesion again in the same patient.
Definitely, I would like to include in the biopsy that.
No.
Targeted plus
again, only biopsy. Targeted or both targeted?
No, both.
Fine, okay. The second scenario for Dr. Pava. Elderly man, 81-year-old, 8.7, just a Pirates 3 in the right apex, picked up on a routine health checkup. Again, the question same, targeted. Are you comfortable?
So, definitely I'm comfortable with targeted plus systemic biopsy in the
No, both or only targeted?
Both.
So none of the panelists is still comfortable sticking only to targeted.
Although reports are saying like we can detect with targeted only more clinically significant lesion. That is favoring.
So now this is coming up again, but I still feel majority of us, maybe perhaps for the fear of missing out on a cancer, but it's very well brought out that you may not really miss clinically significant cancers.
And one more thing that all the protocols, all the guidelines is based on that 12-core biopsy. So only targeted biopsy will you feel like left out something.
So here comes your question of Sanjay, what you were saying, you sometimes do a PSMA-directed biopsies.
Yeah, so...
Again, the need is again very low.
Yeah, need is low, but in patient where we are missing, because we don't have a MR fusion biopsy, and we adopted, and we found this is a good, safe technique, and we are not going transrectal. So we are just...
that is transperineal PSMA direct.
No, it's transperineal. We are doing transgluteal.
Transgluteal, okay.
Yeah.
Okay.
So,
Karthik, you want to say something?
So again, there's something which you need to understand about PSMA PETs. You can get false positives,
false
also.
Yes.
And very often you'll see MR showing 1, PSMA showing 1, 2 or 3 observations on the PSMA, but they are all negative. There's only one disease, and histopathologically proven. We'll have only one disease. So I feel there can
PSMA
be
is still not very reliable.
You've got to be careful. Imaging per se is not absolutely a gold standard, but you have to have a high index of suspicion before you go into a...
No, we are not using it as only imaging. We are using this image guide to have a biopsy in a patient where we are missing with a conventional biopsy.
Let's move on to that. That need in practice is very minimal. So many times that need is maybe less than 1% of the patients when the suspicion is high, but still you are not getting it. So those cases we are not discussing today. So the next two abstracts were on the use of surveillance, the active surveillance in prostate cancer patients. So let's go on to that. So Dr. Joshi, do you get any patient whom you feel comfortable offering active surveillance?
Yes, we do. We do get patients whom we are putting on active surveillance.
Okay.
Especially low risk, very low risk and low risk patients.
Fine. Mahendra, what are your criteria for offering an active surveillance?
So the very low risk and favor intermediate risk are these criteria where we can offer the patient. But only thing they should understand the strategy. To compliance patient.
Compliant patient.
Yeah, compliant.
Anything different in your practice, Dr. Pava?
Like expanded, like in
favorable intermediate risk, definitely in only selected cases, like
So in India, the situation is different. Sometimes the patients demand us, what if I don't do anything?
Yeah.
When you want to treat them, but they demand, do you fall for such patients?
So in those cases, definitely we should be more vigilant, more follow-up and multiparametric MRI and those things.
So in general, most of you would follow the standard criteria.
I think it is more reverse in our UP and Uttar Pradesh, because patients, when you say that you have to come so many times, so many things, so many MRI, biopsy and whatever, they are not ready for...
That is true everywhere.
They are very rarely they are ready for active surveillance.
See, it will also depend upon how well you counsel them and how well actively you offer them and how well you reassure them. So there are various expanded criteria.
Dr. Aszchip,
yes.
here. Can I just add one more point on this? Because the main reason why these patients have had a biopsy is high PSA. And if on the biopsy we find evidence of chronic prostatitis, then at least we have an explanation for the high PSA. Then in that situation...
So you mean to say chronic prostatitis plus a cancer?
Plus, yes. So in that situation, with a low risk, we are definitely more comfortable offering active surveillance to the patient.
So are you saying, sir, in your practice, you would offer active surveillance with more reassurance if also there is an evidence of chronic prostatitis? Chronic prostatitis?
Yes.
So you would not offer if there is no evidence of chronic prostatitis?
No, not that. But I'm saying that I'll be more comfortable.
You will be more comfortable.
If in addition, I find that.
Okay, fine. So there have been expanded criteria, but majority of the people that we offer, the question is the approach comes is how do we reassure that this approach is not harmful? How do you counsel, Sanjay, those patients?
So whenever you counsel, you have to counsel the patient that we are not...
and do you get enough time to counsel in your busy practice? That is the second question.
It's difficult, but if you want to do active surveillance, then you have to counsel. There is no other option. So counsel, you tell them about data that the cancer-specific mortality is less than 5% over 10 to 15 years in the whatever data we have worldwide. And in our data also,
So Mahendra, do you do anything differently?
So just counseling of the patient.
Vivek, do you refuse any patients for radiation who come to you because you feel they are suitable for active surveillance?
Yeah, I do. I have lost quite a few patients. Actually, from the past 10, 15 years, I've been doing
they have
this.
lost because you counsel them for active surveillance?
I counsel and I seriously take about 30 minutes to talk to the patient. And we have not come to a consensus of the core positivity and the length of the core.
Because I think there are a lot of... yes, Santosh, you want to say something?
Sir, you put up the table on PSA density. How often the clinicians use PSA density as a model? I am not very aware of... We do talk about it, but actual practice, how much is it used?
So there are different guidelines have given different criteria. There have been tests to reassure them patients. So anybody of you uses these so-called genomic tests for reassuring them?
No, we do
either the Prolaris or the Decipher. Let's move on to the next abstract was on the use of nerve sparing during radical prostatectomy. So, Mahendra, how often have you encountered a positive margin after you offered a nerve sparing?
So it is less than 5%. Only when the MRI has any doubt of EPE, only then we don't perform it. But even intraoperative, we find there is a good plane inside that. We try to attempt it, at least one side in nerve sparing RP lane.
Anant, what's your experience?
So to be honest, the amount
do you offer routinely a nerve sparing?
Nerve sparing that we do comes to around less than 30% of our cases. So we don't get enough patients to do nerve sparing. And even then, it's not a full nerve sparing. If I say nerve sparing, it's an incremental nerve sparing depending upon which side the tumor is and so on. If suppose
Santosh, do you offer routinely nerve sparing? Santosh or Vivek, anybody can.
So I agree with what sir mentioned just now. It depends on what we get. So we don't offer routinely, and if we do, then it won't be a complete nerve sparing. At least unilateral or, as you mentioned, incremental.
Have the pathologists looked at the concordance between and the radiologists and the pathologists? What you report as the margin positivity, Satyakam, if you could tell me, and the radiological reporting?
It's difficult to...
Yeah, concordance is there. Concordance is there most of the time. Sometimes I think it will be less than 5% that we have called positive.
Okay, let me put it the other way. I think what Karthik reports, possibility of extra cord, do you get the same or do you get a little more?
Extra prostatic extension you want to see.
EP or the margin positivity, he would report it as
positivity is less, extra prostatic extension.
The concordance is generally there. The MRI techniques are generally superior and standardized most of the time. Okay. So I think we should have an interdisciplinary meeting with them. Dr. Pava, any extended indications? So 4+4, would you offer a nerve sparing? Maybe Mahendra, you can also take that.
Like
young patients 4+4 or a 4+5 adenocarcinoma, conventional. Would you offer a nerve sparing, or because it's a 4+4 or 4+5, you would not offer?
Usually not. Like
you would not offer.
Yeah.
Would you
Again,
extend?
sir, the proper patient counseling is very important. If the grade is for 5+5 or 4+5, but a confined disease, again we have to counsel the patient about can be done surgery when sparing, but again he may need adjuvant therapy based on HPR.
Ganesh, do you offer for extended criteria? Would you 4+4 or 4+5? Would you offer a nerve sparing if demanded? Raghu, I'll come to you. Raghu, thank you.
3+4, Ganesh, I think you did, na? 3+4, nerve sparing.
No, I'm asking 4+4 or 4+5. Raghu, yes.
It depends on many factors. One is Gleason score, whether the tumor is away from the neurovascular bundle or not, whether the patient is potent or not, what kind of nerve sparing he wants, and what kind of nerve sparing we can do. If NeuroSafe is available, if we can do NeuroSafe, certainly we can do that, where we are not going to compromise on the oncological outcomes. At the same time, we can give functional outcomes.
Okay, Raghu, thank you. Let's move on to the last abstract of this session. This was on the uncommon tumor of ductal adenocarcinoma of the prostate. So, Dr. Asabri, do you get a pure ductal adenocarcinoma, or it's more commonly in association with the acinar?
It is more common with an association with an acinar carcinoma.
Do you mention the percentage? How do you do it? In a radical prostatectomy specimen, or?
Yes. So in a radical prostatectomy, we would mention if there's a pure ductal carcinoma, that would be mentioned, and acinar carcinoma. Grading would be done as per the Gleason's grading 4+4.
Is the diagnosis easier on a radical? Obviously, it will be radical, but can you put it up? Can you also pick it up on the biopsies
yes,
as a ductal?
Yes, as a ductal carcinoma. The morphology from a typical acinar carcinoma is different. Ductal being
Could you
ductal,
briefly tell us what are the differences?
So a ductal carcinoma, because it affects the large ducts, it is more columnar in morphology with amphiphilic cytoplasm and high malignant features. Sometimes it can look like a benign lesion, but compared to an acinar, which are cuboidal cells, these are tall columnar cells with papillary projections.
What are the main differential diagnosis? Ductal, you need to differentiate it from?
Differentiate from. In high grade, you may sometimes feel it's a neuroendocrine, but generally neuroendocrine are more round cells, and these cells are more columnar and show more nucleoli.
So as you said, most of the time it is in association with the conventional acinar. Perhaps the most important differential is 4+4. Whether it's
yes,
Santosh,
a ductal 4+4 and an acinar 4+4.
Santosh, you want to have anything on this?
One differential would be intraductal carcinoma of prostate. So IDCP, sometimes with a papillary IDCP kind of a pattern would look like a ductal carcinoma.
The columnar morphology sometimes
and very importantly, we should not mistake a rectal adenocarcinoma infiltrating prostate.
So colonic adenocarcinomas, sometimes a urothelial carcinoma.
There is some confusion. Intraductal carcinoma of the prostate is very different from ductal carcinoma of the prostate.
Yeah, that's
why we have to keep it in mind. It's totally different. That's why we need to keep it in mind.
That is what Santosh mentioned. Okay. So coming to radiology. Karthik, do you have any clues? Can you pick up preoperatively these ductal adenocarcinomas?
So I think there's a normal consensus that cancers are dark on the T2-weighted images and so on. But we are seeing with advancement in the MPMR, we are seeing a lot of cancers which are no longer T2 dark. And a lot of them...
intermediate.
Yeah, they're intermediate or they're even brightish. So when they're brightish, the first thing which we actually think of are mucinous tumors. And they're very similar to colonic or rectal cancers, which are mucin-producing, signet, non-signet. So that's one thing. And also what happens is the higher the ADCs, because neuroendocrine differentiation tumors have very high pleomorphism, and the radiomic features are completely different from
maybe in future, the radiomics might also help in picking up this.
And they're more biologically aggressive.
Okay. So, Mahendra, do you feel the clinical presentation is different, ductal adenocarcinomas?
Definitely, sir. They are less Gleason grade. Disease burden is more PSA is less. So it is definitely different than the conventional carcinoma of the prostate.
Sanjay, do you treat them anything differently?
No, we don't treat them anything differently. The treatment protocol is same, but patient should be counseled better that they may have a higher risk of recurrence and multi-modal treatment in the future.
So one point I'd like to make is ductal, the PSA levels may not be very high.
Yeah.
Yes.
So as a clinician, when you're treating, PSA does not help you in
The
sort of
lower PSA
tailoring
levels,
your
but a more
management.
advanced stage at presentation, perhaps you should be suspecting. Somebody with a
Nodal mets are probably a little more common.
more common with these. So there was a good review article, though it said that they have a lower PSA, higher T stage, and higher ISUP grading than conventional, more common lymphatic spread. What is unusual is they have unusual sites of lymphatic, of metastasis. Sometimes peritoneal metastasis. And one of the theories they say there is a disruption of ducts during the radical prostatectomy at the bladder neck.
Robotic radical prostate there.
Any radical prostate. So in fact, one of the radical suggestions is maybe you should be considering cystoprostatectomy in these patients to prevent the spread. I don't know, I think more longer. And in fact, some people have gone on to say that radiation doesn't break the plane, so maybe radiation may be better. But I think as these are rare cases, we'll need to have more information about that. So I thank you all the panelists for this discussion. I want to end with a quote which Mahendra has given me. Yeah, sure.
So ductal carcinoma of prostate is an invasive cancer. Intraductal is generally not an invasive. It is within the duct. Origin means it's all arising. See, all cancers are stem cell arising from stem cells.
Same ducts. Is he asking the large ducts?
Yes, large ducts. So ductal cancer is a large ductal cancer. The large pattern is a large ductal, but it's an invasive cancer.
No, intraductal is a form of spread. So the cancer spreading along the ducts will be an intraductal carcinoma. And if the duct gets ruptured and comes in the stroma, then it will be known as a ductal cancer. So that is enough.
Yes.
Yes.
Okay, thank you very much. We'll end this. Thank you all the panelists.
Thank you.
Yeah, Mahendra, I think I'll ask Mahendra to... Mahendra has a good quote on this. Please go ahead, Mahendra. Come.
Sorry, I just wrote this for the wisdom of wave like that. एक ज़माने के बाद wisdom of wave आया है. ज़रूर कुछ ना कुछ नया और खास तो होगा. देखना बस ये है कि आप सबके बीच अगर आगाज ये है तो अंजाम क्या होगा. Thank you.
Thank you, Dr. Bhalchandra Kashyapi and the panelists. I request the chairpersons to continue for the next session, which is dedicated to locally advanced prostate cancer and biochemical recurrences. And for the next round of abstract presentations, I call upon Dr. Syed Mohammad Kaus, who is a consultant urologist and robotic surgeon at Asian Institute of Nephrology and Urology, Hyderabad. Dr. Syed Mohammad will be presenting the first two abstracts of this session. I request you to please stick to the time allotted to you. Thank you.
Good morning, all the respected delegates. I'll be very brief in this because I've got a very small abstract to present. The first one is about a randomized, double-blind, placebo-controlled phase 3 trial with apalutamide with ADT versus placebo with ADT for a localized and a locally advanced CA prostate, which are candidates for radical prostatectomy. So basically to introduce this, basically for a high-risk prostate cancer, which accounts 15% of all the newly diagnosed CA prostates. And in patients with localized high-risk prostate cancer, the disease recurrence rate is approximately 50%. So half of the people have to have some disease recurrence when they have a high-risk features. So the systemic therapy that eradicates this micrometastasis is needed to improve the survival of these high-risk patients undergoing radical prostatectomy. So the study examines at 12 months of perioperative, 6 months of pre and post 6 months of ADT with apalutamide versus placebo and ADT. The inclusion criteria that they have seen is a biopsy-proven CA prostate with high-risk features according to the EAU risk group, patients undergoing radical prostatectomy with PLND with a good performance score and able to receive a ADT for at least 13 months. They excluded metastatic patients at diagnosis with a prior ADT or with a local therapy. This is an ongoing study actually. They are enrolling almost 2,500 participants, and it's a quadruple randomized study wherein participants, care provider, investigator and outcome assessor all are blinded. And the primary outcomes are the percentage of participants with a pathologically complete response or a metastatic free survival, and this time from the randomization to the first occurrence of a radiological distant metastasis or pathological finding of a metastasis or death or any of them. And secondary outcomes are many, which are seen over a period of 8 years. The actual study has started in June of 2019, and estimated completion is April 2024. And the secondary outcomes are being assessed till 2027. So basically, it's an ongoing study and still in the recruitment phase, mainly in the US and few of the Eastern countries. This was the primary abstract. The other one, if the moderator suggests, I will go for the other one. This is again a similar study wherein neoadjuvant ADT, whether it is beneficial for highly aggressive prostate cancer candidates who are undergoing radical prostatectomy, and its implication for multimodality tailored approaches and for inclusion into trial sessions. With the introduction of novel androgen receptor targeting agents, in the presence of highly aggressive CA prostates for radical prostatectomy, identifying men who might benefit from a neoadjuvant hormonal manipulation for both tailored approaches and for inclusion into trials with this neoadjuvant targeted therapies. So 411 patients with post-radical prostatectomy or with EPLND between 1995 and 2021 with a Gleason's grade of 5 CA prostate were included. Neoadjuvant ADT or adjuvant ADT with RT was given depending on the investigator, and biochemical recurrence was defined as more than 0.2 nanograms PSA. Clinical recurrence was any met on an imaging, conventional imaging, and impact of this neoadjuvant ADT on biochemical recurrence or a clinical recurrence was compared to patients with radical prostatectomy alone. Observed versus predicted clinical recurrence-free survival was plotted for neoadjuvant ADT versus no neoadjuvant ADT. They have given results of 23% patients receiving neoadjuvant ADT plus radical prostatectomy, 40% with radical prostatectomy and adjuvant radiotherapy, 53 underwent radical prostatectomy, adjuvant RT plus or minus ADT, and 34% were given only radical prostatectomy as a treatment of choice. 44% patient had positive surgical margins, and neoadjuvant ADT was associated with a lower risk of this positive surgical margins. Median follow-up of 61 months was done, which showed 1/3 of the patients experiencing clinical recurrence. So to conclude, the impact of neoadjuvant ADT on clinical recurrence-free survival varied according to the risk score, which again depended on the clinical staging, staging, PSA and the node positivity. Men with risk of clinical recurrence higher than 40% at 8 years, according to the risk score, are those who benefit from an upfront or a neoadjuvant ADT. So neoadjuvant ADT might be a highly beneficial in patients with a biopsy of a higher Gleason grade of 5 with an aggressive disease characteristics, and this would guide the selection of a trial population in this setting.
Thank you, Dr. Syed Mohammad Ghaus. I invite the next speaker, Dr. N. Srivatsa, who will present the next two abstracts. Dr. Srivatsa is a consultant and head Department of Urologic Oncology at Sri Shankara Cancer Hospital and Research Centre, Bangalore.
Very good morning to all. At the outset, I would like to thank the organizers for this opportunity. So this is my first abstract. Yeah. This was presented in AUA. It is about immediate radiotherapy versus observation in patients with node-positive prostate cancer after radical prostatectomy. It was presented as a moderated poster, and the optimal management of node-positive prostate cancer following radical prostatectomy remains uncertain, though the RCTs have very clearly shown that adjuvant radiotherapy in these subset of patients are beneficial. The utilization of adjuvant radiotherapy is poor. Recently, 2 trials have shown that early salvage radiotherapy can be as good as adjuvant radiation therapy, but both these trials had poor recruitment of the node-positive subgroup of patients. So this trial was designed as a hypothetical pragmatic trial of immediate, that is adjuvant radiotherapy versus observation in men with node-positive prostate cancer after prostatectomy. Using the radical SART design, a hypothetical target trial including 3,510 patients was set up from the National Cancer Database Registry of men aged 50 to 69 years with any T stage, with any resection pathological outcomes, that is positive surgical margin or otherwise, in patients who had node positivity without any evidence of systemic metastasis. The pre-treatment PSA cutoff was at 50 or below, and these patients received anywhere between 60 to 72 grays of adjuvant RT with or without ADT within 26 weeks, that is for 6.5 months after RP, or were randomized to observation. So they utilized what is known as a stabilized inverse probability of treatment reweighting to analyze the outcomes. So the results are a total of 3,510 patients were included, of whom 17% received adjuvant RT. Close to 50% of those who received adjuvant RT had also received concurrent ADT. The median follow-up was roughly about 3.5 years, during which time 333 deaths occurred. The adjusted OS was 94% versus 89% for both the arms, which was not statistically significant. In patients who benefited from adjuvant RT, I'm sorry, I don't think you can see this. Those patients who had a Gleason score of 4+4 or more, those patients who had, I'll just come to the next slide, I think that's better. So the conclusion was that patients had an improved OS only when they had Gleason 8 or more disease, 2 positive lymph nodes or more. The statistical significance was even better when there were 3 or more nodes which were positive, and in those patients who had negative surgical margins. The quick comments are that the adjuvant radiation was not commenced on a uniform basis. The disease-specific mortality was not mentioned, so within a short follow-up period of 3.5 years, almost 333 deaths is quite high. This is the second abstract. Which is about efficacy and safety of darolutamide in non-metastatic CRPC patients with and without prior local therapy with either radical prostatectomy or radiotherapy, again presented as a moderated poster in AUA 2022. Darolutamide is a structurally distinct and a very potent androgen receptor inhibitor. It has significantly reduced the risk of metastasis by approximately 2 years, and the risk of deaths by 31% when compared to the placebo in the Aramis trial. The favorable safety profile in patients with non-metastatic CRPC patients has also been confirmed in the Aramis trial. This is a post hoc analysis of the Aramis trial to look at the effect of local treatment and subsequent darolutamide therapy. So patients with non-metastatic CRPC were randomized in a 2:1 ratio to either darolutamide or placebo while continuing ADT. Daro patients who received prior RP or RT were compared with those who received neither therapy for overall survival and time to PSA progression using the adjusted Cox regression analysis. The PSA response was defined as a decline of 50% or more from the baseline, and they also looked at the adverse events. Coming to the results, in Aramis, 43.6% of darolutamide patients had a local therapy either with prostatectomy or radiotherapy. The treatment benefit of Daro on OS was consistent for patients in both arms. The median time to PSA progression in Daro-treated patients with prior local therapy was similar to those without prior local therapy, that is 29.5 months to 26 months. The PSA response rates were similar in both arms, and the adverse event rates were also similar, including the drug discontinuation rates, which was comparable between 7.7 and 9.9%. To conclude, the treatment benefit of Daro on overall survival and PSA outcomes was consistent for patients who either had local treatment prior or who started on darolutamide directly. Quick comment is close to 50% of patients included in Aramis trial actually had a local therapy, so the outcomes may not really be a surprise in comparison to the OS from Aramis. Thank you very much.
Thank you, Dr. Srivatsa. Ladies and gentlemen, I would like to inform you that the next abstract we'll have to skip that because Dr. Wasim Poflankar has not been able to come, but we are going to cover it in the panel discussion. And I invite Dr. Shrikant Atluri to present the last abstract of this session. He's a consultant uro-oncologist at Sir H.N. Reliance Foundation Hospital, Mumbai.
Good morning, everyone. I'd like to thanks for the opportunity. So I'd like to, I'll be speaking today on the abstract presented at AUA by the Italian group on oncological outcomes in patients with recurrent prostate cancer staged with PSMA PET-CT, results from the 3 European tertiary centers. So the objective of this study was to evaluate the oncological outcomes in recurrent prostate cancer patients according to PSMA PET-CT results and further salvage treatments guided by the PSMA PET. So it was a retrospective study. 240 recurrent prostate cancer patients were recruited from the 3 European tertiary centers, and they were stratified into 2 groups. The first group was included around 143 patients, which were the patients who were having a first biochemical recurrence. And the second group included a biochemical recurrence after having a previous salvage treatments, and the number was 97. Each patient underwent PSMA PET-CT for restaging proposal, and the PET results were divided again into negative and positive. The positive results were further classified into oligometastatic, which will be lesions less than or equal to 3, and they underwent different type of PSMA-targeted salvage therapy, while the polymetastatic, which included the lesions more than 3, underwent a systemic therapy. Those who had a negative PET-CT were treated with non-imaging guided salvage therapy according to the risk of local or systemic recurrence. The outcome of the interest were further BCR and radiologic progression in group 1, and BCR, radiologic progression and occurrence of CRPC in group 2. And they were estimated using Kaplan-Meier curve. So the results in the group 1, 47.6% of men had a positive PSMA PET scan. Median PSA was around 0.39. Patients with positive PSMA PET-CT had a higher median PSA at failure after salvage treatment and shorter time to BCR. And with a median follow-up of 60 months, the BCR-free survival and radiologic progression-free survival at 3 years were not statistically significant because the p-value was more than 0.05. And coming to the group 2, 64% of the men had a positive PSMA PET scan, and the median PSA was slightly higher, 0.7. And men with positive PSMA PET-CT had again higher median PSA at PSMA PET-CT. And with a median follow-up of 92 months, the BCR-free survival, radiographic progressions-free survival, and CRPC-free survival at 3 years was 55 versus 43, 80% versus 56, and 100 versus 88 in patients with negative and positive PET-CT respectively. So they concluded that patients with positive PSMA PET-CT had comparable oncological outcomes compared to men with negative PSMA PET-CT at the time of first BCR, and worst oncological outcomes despite increasing adoption of PSMA-guided treatment in patients with previous salvage therapy. So coming to the comments, it's a retrospective study. The population group is a heterogeneous group because we need more details on the T-stage, PSA, and the Gleason score and PSA doubling time, those information was lacking. The PET positive, regarding their classification into oligomets and polymetastasis, we need more data on that, whether the oligomets were nodal only or nodal plus retroperitoneal or with bone mets. Similarly, in group 1, this makes a more relevant point in case of PSMA positivity. We need more details on how many were oligomets and how many were polymets. So we need a definitive prospective randomized control trial for further recommending any recommendations. Thank you.
Thank you, Dr. Shrikant Tatluri. We now have a panel discussion on locally advanced prostate cancer and biochemical recurrences. And I invite as moderator Dr. Santosh Vaigankar, who is a consultant urologic oncology at Kokilaben Ambani Hospital, Mumbai. I invite the panelists, Dr. Sudhil Rawar, who is a medical director, head of uro-oncology at RGCIRC, Delhi. Dr. Santosh Nagaonkar, who is a director of urology, uro-oncology and robotic surgery at Sir H.N. Reliance Foundation Hospital, Mumbai. Dr. Sujoy Gupta, who is a senior consultant uro-oncology at Tata Medical Center, Kolkata. Dr. Anil Bradu, who is a chief consultant urologist and director, Excel Urology Center and Zen Specialty Hospital, Mumbai. Dr. Shrikant Badwe, who is a senior urologist, Max Nanavati Hospital, Mumbai. Dr. Palak Popat, who is an associate professor radiology, breast, gynec and uro-onco imaging, Tata Memorial Hospital, Mumbai. Dr. Vedang Murthy, who is a professor radiation oncology at Tata Memorial Hospital, Mumbai. Dr. Sangeeta Desai, who is professor and HOD pathology at Tata Memorial Hospital, Mumbai. Dr. Sumit Basu, who is head department of radiation oncology at Kokilaben Ambani Hospital, Mumbai. I hand over the session to the moderator.
Can I have a medical oncologist also here, since we have one? Anybody can come. Please, sir. So thank you for this opportunity. I think we are here and the panelists don't require introduction at all. I feel myself dwarfed to actually moderate this session among such an elite panelist, but I have been given the job. And the objective is very, very clear. And we are going to just look at the previous abstract, probably dissect it and try to understand the applicability and of those particular findings to our practice in the subcontinent. And we will be sending a very subtle message in our discussion. I request the panelists to keep their comments very short and sweet, because that's the whole idea of it. So we start, I've divided the abstracts into 3 parts. One is abstract which looked at the pre-RRP neoadjuvant settings, abstract which looked at NMCRPC setting, and abstract which looked at recurrence. So we first focus on the abstract which we looked at pre-RRP neoadjuvant treatment. And this is the small case which I put up. So it's a 69-year-old PSA 1, performance status 1, PSA 25, Gleason score 4+4, 4+3 on the left, and T3B, PSMA clear. Now, with the evidence that is coming up, I'd like to put first question to Dr. Nagaonkar. With the evidence coming up, and we know that if we talk about RP in this setting, there are few data that is coming up. It's encouraging, but we need randomized trials for that. But what has been put up, what the abstract has been discussed, do you feel encouraged to consider RP for this patient? If so, why?
Yeah, I think, Santosh, here counseling is going to be extremely important with this patient. It's a high-risk disease. He's 69, and he will need a multimodality therapy. So definitely I will keep the radical prostatectomy on cards, just to keep it short.
So what are the things you look for when you're counseling the patient?
So, of course, his biological age, besides his chronological age, if he's going to live on for more than 10 years, and his continence, his sexual function, that is important. What are his expectations out of this? His family background, that is important. And whether he can also go ahead with the multimodality therapy, whether he has got the compliance to go through that.
Yeah. I think I asked Dr. Brado as well. I think most of the answers have been given, but I want to know his perspective as to what factors influence the decision of RP as first choice as a part of multimodal therapy in this case, if you were to offer that.
I think the quality of life issues, what the 69 could be looking like a 59 and a 69 could be looking like a 79 in terms of his lifestyle and his fitness and his attitude. Of course, I think if the idea of not having cancer and to be able to treat the aftermaths of the cancer is easily in the mind of a patient rather than not treating a tumor which can be removed. So I think surgical removal is something which helps the patient. It's easy to convince the patient that he'll be able to fight it better.
Thank you. So I just want to ask the audience, just a show of hands as to who would go ahead and give a neoadjuvant hormone therapy in this setting. Just a show of hands, please. Okay, how many surgeons are there in the audience? Right. Okay, so I'd say around 20-25% agree to that. Dr. Badwe, do you agree to giving hormone therapy neoadjuvant? Have you been practicing that?
I would certainly give neoadjuvant hormonal.
So if that would be, what sort of drug would you use and what would be the duration?
LHRH agonist only, and for 6 months, 2 doses, and then, if at all, reevaluate and consider.
Okay, so you're not worried about the patient going away if you're going for 6 months.
Right. In case you have counseled him.
Okay. So, Dr. Nagaonkar, can you put your inputs in as to what sort of direction you would keep the patient on if you are giving neoadjuvant?
The new data is coming out with neoadjuvant hormone therapy. Till then, I had reservations for using neoadjuvant for few reasons. Number one was, anyways, about 10 to 15% of these tumors, they will get downgraded. So it may come back to Gleason 7. Secondly, you are going to lose out on the correct histopathological correlation. And thirdly, the PSA.
Yes.
Anyway, it is going to be undetectable.
Yes.
So all those prognostic factors we are losing out if we are giving neoadjuvant hormone therapy. So that is the biggest reservation I have.
Exactly.
But now the new data is suggesting that neoadjuvant has got long-term.
So I personally always believe that if you're going to give neoadjuvant therapy, we don't have protocols where how are we going to follow up these patients based on PSA, because PSA is definitely going to be influenced. And as you said, histopathology will be affected as well. So I want to bring in expert Dr. Sangeeta. Ma'am, how many, if I give you 100 histopathology reports, how many of them are from patients who have taken neoadjuvant therapy before RP?
Well, currently, we do not get those many radical prostatectomies and where patient has received neoadjuvant, but it's infrequent occurrence. But we do find such cases. Most often, it's never told to us that patient has received treatment. So we are Sherlock Holmes, so we find out from the
what are the factors you look at which you can pick up and you call back the surgeon?
Yeah, actually, tumor size reduces, overall tumor volume. Pathologic stage goes down staging of pathologic stage, and if there is a positive margin, the extent of that reduces.
Okay.
So the margin positivity, the incidence, it goes down with neoadjuvant. Okay. Another thing is Gleason score. I mean, if the patient has responded drastically or tumor has responded drastically to the treatment, then it's sometimes difficult to even make out whether there is a tumor. Yes. And so Gleason score is affected. There are a whole lot of changes which happen.
So, ma'am, this is regarding using hormone therapy, but there are some papers which are coming where we have used chemotherapy as well.
Yes.
So, do you think the difference, there will be some difference?
All kinds of neoadjuvant treatment, I would say, for any cancer, affects the morphology. Yeah. And but we would like to seek this information before the slide comes onto the microscope.
And would you be putting a disclaimer below that he has received neoadjuvant?
So what we say that then of course we make attempts to call up and find out, seek this information actively. And then we say that the prior treatment is acknowledged and whether the tumor has responded to the treatment or not.
Yes.
If the tumor has not responded, then we can offer a Gleason score, but mostly tumors respond.
Thank you, ma'am. Dr. Badwe, you wanted to say something?
Madam, I wanted to ask you, is there any evidence, any place where, it has been found that the tumor is not seen with neoadjuvant therapy and RP specimen?
It does happen when we are evaluating core biopsy, but in RP, it's not a complete eradication that I have not observed till date.
There are few case reports which mention about the vanishing tumor syndrome, which is usually seen in these patients when you give hormone therapy. So one more question I always wanted to ask, I wanted to bring Dr. Murthy here, is any contraindication to radiotherapy in these patients?
You mean...
in this scenario, sir.
After surgery?
No. In this scenario, if you were to give radiotherapy?
No. Unless a patient has had previous radiotherapy to the pelvis or has any other significant issues, a very large median lobe going into the prostate. Otherwise, there is no contraindication. Absolutely. I would consider that as a standard of care.
Okay. Thank you so much. So we move on to the next, where we looked at a cohort of patients which moved from HSPC to a MCRPC, which is the NMCRPC. And we are focusing on a drug which has come up a big way, which is darolutamide. And darolutamide, as we know, was included in one of the phase 1 and phase 2 trials as far as MCRPC is concerned, and even in phase 3 trials as far as metastatic HSPC is concerned, the Arsenal trial. So the question would be, is this practice-changing study? I would ask any of the, Dr. Nagaonkar, if you can pick do you think this is a practice-changing study? Would we be tempted to start with darolutamide when you know that there are other agents available, like enzalutamide as well? Apalutamide is not available.
Yes. Yeah. It is a practice-changing study, I think. It is going to change.
Okay, so you would be prescribing to a patient?
Yes.
Okay, just hold on to that, or I'll be coming back to you. So what would you prefer? Would you prefer it to enzalutamide, looking at the way both behave in the body? I mean, this darolutamide has been also given to patient who has a history of seizures because they don't cross the blood-brain barrier. So would you prefer it over enzalutamide?
So I think in Indian scenario, it all boils down to the pricing of this drug.
Yeah, I'll just hold. I'll just come to Dr. Joshi.
So, barring from the CNS, it's not only the seizure is the 0.01%. So mostly it is the fatigue, the tiredness. So that is also, if cost is not at all a constraint, definitely darolutamide is superior to enzalutamide. There is no doubt about that. The data and the safety profile consistent with that. If patient is not affording, then the enza will be second choice. The only thing with how commonly we see the NMCRPC, previously there was no therapy available, so we don't want to look into that. Now we know that there is a drug which is available and which has not only improved the metastatic failure-free survival, but also the OS. So in the current era, if patient is an NMCRPC fitting into the bracket of a rapidly rising PSA with the doubling time less than 10 months, there is a data to suggest either Daro or Enja.
Okay, so one thing I want to mention, the RMS did say that the discount, yeah. So please go ahead.
I just wanted to make a comment. You know, the PSMA PET CT has actually reduced the percentage of NM.
Yes.
So with ease of availability of PSMA PET CT, the patients who are actually categorized as non-metastatic CRPC is very small.
Thank you, sir. So,
sir, that is the reason the trial, the people, the Bayer people, they want to discourage the PSMA PET CT because we are detecting the even micrometastatic. So in the trial, the phase 4 study they are conducting, they have not taken the PSMA, the CT scan plus bone scan.
So the RMS did mention that the discontinuation rate was very less and the cause was 0.4% cardiac failure, but I don't think that is something which you would be looking at. But coming back to cost, I've been told that the cost of one therapy is 2.7 lakhs. So that is something which hit me immediately, and I would that is something which I am sure the surgeons will consider, or the medical oncologist will consider before prescribing this. There will be some patient assist program coming up in future, but we'll have to wait. Moving on to the next 3 papers where we looked at the oncological outcomes in patients which compared PSMA targeted therapy, PET-CT, and one is immediate radiotherapy versus observation in patient node-positive prostate cancer after radical prostatectomy. And third abstract was distinguishing between a PSA bounce and a BCR following SBRT in prostate cancer. So this is a case I'm putting up, 60-year-old male, performance scale is good, PSA 35, biopsy Gleason score 4+3, 4/6 course on the right side, T2N0M0 PET-CT done. The patient underwent radical prostate with bilateral EPLND. Final histo shows that the right EPE was there, margin focal positive. Nodes 2 out of 12 were positive and there was no external extension. I just want to ask Sangeeta ma'am, when I'm talking about EPE, has there been any change in literature right now? Because we don't talk about ECE now, we talk about EPE now. So has there been any significant change in literature as far as defining these terms are concerned?
Well, I don't think there is any change. It's extra prostatic extension, which is more important than the capsular invasion.
Yeah, thank you, ma'am. So I want to ask Dr. Basu, so what would be your take of doing radical therapy in this case? Radiotherapy.
So the patient has high-risk features, and we know that he has a node-positive disease. I mean, histopathologically, 2 nodes positive. Extraprostatic extension is also there, margin is positive. So definitely adjuvant treatment is required. Now the question would be whether we give it immediate adjuvant or can we wait? Can we wait or give as a delayed adjuvant or maybe an early salvage? That's the only question.
Okay, Dr. Vivek, to add? Dr. Vivek, right?
Yeah, I think we will check the PSA at 6 weeks.
Okay.
And if there is detectable PSA in my practice, I would,
if
discuss.
If there is detectable PSA in this case, what would be your protocol, sir?
He would be referred for radiotherapy.
Radiotherapy. Dr. Murthy, your dose preference in this case?
For adjuvant RT,
yes.
64 gray in 32 fractions. 6 weeks.
Okay, okay. So you will be happy following the findings of the radicals or raves?
None of these patients were there in radicals or raves. They were hardly about less than few percent.
Yes.
If you look at the Capra score of this, it will be close to 10. And the chance of failure after surgery is 90%.
Okay.
Why would we want to take a chance and wait? And because that is number one. So I would definitely offer adjuvant radiotherapy.
Okay.
Regardless of the PSA in this particular patient. I would like to point out the abstract that was presented. It was called a hypothetical randomized trial. I think that is quite preposterous to use such terms and publish it in leading journals. Hypothetical or emulated randomized trials from NCDB databases are nothing but rubbish.
Okay.
And we should not take it seriously at all. I mean, that's just a point besides this.
Okay, thank you, sir.
So, Santosh, can I just interrupt?
Yeah, please.
I just have a question. So, when you're thinking about giving radiation for this patient, do you actually look at the nodal yield? Because it was an extended lymph node dissection, but despite that, only 12 nodes were...
12 is not too bad. It is probably slightly lesser than what we see in our practice, but it is more than what we often see in so I think 12 is not too bad. I would also like to point out one of the reasons people say in node positive adjuvant radiotherapy may not help is because of possibility of distant metastasis. But we must remember in our practices we do PET scans, often do PET scans, and that takes away a lot of the micrometastasis or so that is something that we should also think. I mean, that adds, if PET is negative, then likely the disease might be local, especially if the PSA is rising. So,
Dr. Vagankar, one query here. Yeah. Just as in the lighter vein, we have had 6 abstracts, and on the 6 abstracts have had different statistical methods. So as a clinician, how do you understand these statistics? They use some strange terminologies like weighted means and this. And so do you think when you use different statistics, your answers will be different? Your p-values would be... See, many studies make things significant by using different statistical analysis. That's a fact which is very well known in literature.
Yes, so that's why we need to have these tumor boards where we discuss this, because when we discuss papers, we come across, as you rightly said, I was going through the abstract, there were various methods used. We may not be used to those methods, but when we discuss it among peers, that's where the things become clear. I would put it that way. Moving on, significant N1 disease on MRI, Dr. Palak. So how would you define that?
So earlier we used to have size criteria for an MRI detection of nodes. Should be like 6, 8, 10, 12. So for prostate, we would consider anything something more than 8 mm to be as significant, but the specificity is very low with this criteria, and we don't use that in our practice. What we see is a morphology of the nodes. If they are round, there is lost hilum, there is extra nodal extension or spiculated margins, heterogeneous enhancement, then we say that this is more likely to be involved by disease. We look at the diffusion, but diffusion can also be restricted in normal nodes and reactive nodes also. So one thing that helps the most is to look at the tumor and the nodes, because they do have a correlation and a resemblance. So size criteria should not be followed.
So would you go ahead and say that you go ahead and do a PSMA PET CT to know how the significance?
So if we have
I'm looking at false positives, yeah. So false positive MRI.
So when you ask me as a radiologist, I mean the answer may differ from the surgeon or the radiation oncologist or the medical oncologist. But for me, if you want to have an answer whether this node is metastatic or not, if it is frankly metastatic, I can say. So then we don't need a PSMA PET CT. On the other side, if I say that definitely reactive nodes, there are no small round nodes which are indeterminate. Again, we are very good at that. But there are these indeterminate borderline nodes where definitely PSMA PET CT has an added value. So as you said, I think it's an MDT case-by-case decision, unless there is a standard of care that is followed in an institute.
Dr. Badu, would you like to do a PSMA PET CT in this scenario, or you would follow what the MRI is telling you?
I would like to do a PSMA PET.
Dr. Nagaonkar?
Yeah, I agree. I think PSMA is a big.
But the reason why I'm asking is, I'm giving you a clinical scenario, is that the pre-op MRI, I'm specifying pre-op MRI, I'm just deviating a little, it shows clinical node, and it is not beyond the pelvis. Okay? So I want to ask the radiation oncologists as well as the surgeons, would you go for a radical therapy in this case?
Santosh, and before that, if I may just... point out, even in your patient, the PSMA PET CT was negative for nodes, but there were 2 nodes positive on surgery. So unfortunately, we're not 100% with any modality. So given a little superiority of PSMA over MRI, we are still not at 100%.
Okay. So Joshi?
But in this case, where there is a clear-cut node is seen in MRI, at least we should do a distant metastatic workup. Is there any doubt about that? If not PSMA, then a bonus scan in this scenario?
Yes. So we would definitely do a PSMA in this case. But the scenario I'm putting up is if the pre-op MRI is showing a clinical node, Dr. Murthy?
Yeah, I think clinical node positive prostate cancer is a curative disease. We should try to cure it with surgery or radiotherapy, along with either multimodality or hormone therapy or whatever. And maybe even abiraterone now.
Okay, and Dr. Basu, what sort of area would cover? Would you go beyond the conventional areas of radiotherapy, or?
No, so the radiation fields are very well specified for pelvic pelvis confined disease basically. So we will include the pelvic nodes bilaterally, and we can boost up the clinically or the radiologically visible node. We can give additional dose of radiation to that while we are treating this. So if I am giving radical radiation, so I'll boost up the prostate and the node as well, and treat the rest of the nodal regions as we treat it.
Okay, Dr. Vivek, would you be doing the same, your role of radiotherapy in young patients? Same scenario, young patient.
Sorry, just repeat the question.
Same scenario, clinical pre-op, clinical node 1 is a young patient. Would you still go ahead and give a radiotherapy for him?
Yeah, that is one that will be in our, one of the options that will be discussed.
Okay, all right. And what would be the duration of ADT if RT is opted to? Dr. Murthy?
We would look at about 3 years. If I suspect longer is better in node positive.
Because there was a study in Australia and New Zealand which looked at 3 years, right? And
3 years versus something else? For node positive, you are saying?
Yes.
You are saying in adjuvant setting?
Yes.
How long? I think, 2 to 3 years.
So, yeah.
But that was not post-op.
So, Dr. Nagaonkar, would you operate on this patient?
Yeah, provided he's happy to have the multi-modality therapy.
Okay,
Yeah.
so even a young patient, would you prefer to operate on him, or you would send him to a radiologist?
Definitely, younger patient is the more, I think, suitable for.
Okay. So the next would be a 61.
More relevant question will come with the availability of the markers. So I will further complicate the situation. as usual, the NGS has been sent. So now this has come out to be BRCA mutated, BRCA2. So then what will be the treatment scenario? Whether it will be a RT, the NAST RT followed by adjuvant, or a surgery followed by?
Dr. Murthy?
I think we'll discuss it in the multidisciplinary tumor board and ask him
I'll put the question open to be discussed on T. So we'll move on to the second last scenario. 61-year-old male, PSA 18, Gleason score 4+4, imaging T3B, undergoes radiation therapy and ADT. And this is for 3 years. And this is the PSA nadir reached during ADT was 0.02. And at the end of 24 months, 2 years, it was 1.2. So we know that PSA rise, we call it as bounce, it will go up by 2 nanogram, then come down. And the Finnish criteria is very clear as far as biochemical recurrence is concerned. But if you see this case, the PSA is increased to 1.2 at 5th year follow-up, that is 2 years after stopping ADT. Is this PSA bounce or a PSA failure? Dr. Basu?
To me, it looks more like a PSA failure rather than a PSA bounce. After 5 years of completing radiation, 3 years, 2 years post-completion of ADT.
Okay.
So this, I think it's a PSA failure.
But if you look at the definition, it should be, so Dr. Murthy, can you take that?
It appears that the PSA is gradually rising even a year after the RT. So the bounce would be characterized by a rise that starts after about 6 to 9 months of stopping the ADT.
Yes.
That may not be the case here.
But here, what do you think it is? Is it failure? Because we have got a nadir of 0.02.
Well, this is a PSA rise, but it doesn't satisfy the definition of biochemical failure. So I wouldn't scan yet.
These are the numbers. Clinically, would you see anything else to differentiate between a PSA bounce?
Symptoms. If there are any symptoms that can explain this, maybe underlying UTI, but that is not something that will keep rising over so many months.
Okay.
And the rate of rise as well.
Okay. And Dr. Basu, is there a particular subset of patients you have seen where you may...
Yeah, you see, these younger patients have generally, they tend to have the PSA bounce phenomena we see in the younger patients. Or patients with early stage prostate cancers, basically.
Okay.
So you have, I think you have remnant cells which can still generate PSA. That's the reason probably in those patients.
Dr. Murthy, you want to add anything?
No, I don't know.
Okay. So last case.
Do you think, excuse me, do you think the PSA dynamics like PSA doubling time, etc., plays a better role in this, in decision making, rather than, dilly-dallying between whether it is a bounce or a thing? I think the PSA doubling time is a more important factor and in helping decisions. What Vedang would say on that.
Yes, so I think that's a very important point. PSA doubling time and symptoms would be very important. We recently, after RT, when the PSA rises, we sometimes end up doing a PSMA scan if the PSA rise is very quick, even before it reaches 2. And we have seen that it is positive. The PET scan is positive in 30% of the patients, even under 2. So that is purely based on the fact that it was rising very quickly. So that is the point. If it is rising quickly, I would scan even 1.9, 1.8, 1.7.
Okay.
I would do it.
Quick question. But that positive PET scan, can it be collaborated with the radiation-induced prostatitis, or it has to be biopsy proven? The METs. Okay.
I think we go to the last now. The 60-year-old
Dr.
male.
Santosh, you have exactly 2 minutes to wind up.
I'll wind up.
Thank you.
So 62-year-old male, 3+4, post-RP, 4+3, T2N1, 1 node positive, post-op PSA, there was a rise and salvage RT was given with ITT for 3 years. PSMA, later on after 2 years, PSMA started rising, so we did a PET CT which showed 2 common iliac nodes and 4 lesions in the iliac bones. So my question to the radiation oncologist, Murthy sir, is would you look at further salvage treatment in this, or would you look for watchful waiting?
So there are 4 bone metastases, is that right?
Yeah. No, 4, same patient, 4 lesions in the iliac bone and 2 nodes, Common iliac, left side.
I mean, I would think of systemic therapy. There's no question about it. I mean, in the sense, he's had ADT, it stopped, isn't it?
Yes,
So
but would you look at salvage radiotherapy?
It's done, no?
No, again, it's done before. After that, he had a recurrence again.
Well, I think the backbone of this whole treatment has to be systemic therapy. Whether we add some areas of salvage treatment is a
So to
separate
continue
matter.
with that comment, would it be an intermittent or a continuous ADT? Because we are looking at long-term ADT and the chance of neurocoin differentiation in these patients would be a little on the higher side. So with that consideration in mind, would you be looking for intermittent or?
My standard would be continuous ADT, unless the patient has a lot of issues with doing it or is not tolerating it. I would prefer continuous ADT along with some additional therapy as well.
Yes, Dr. Joshi.
Santosh, is anybody still practicing the intermittent? Because I have not seen, I think seniors can, is there anybody still, though theoretically in the book has written, but I have not seen anyone prescribing intermittent. Most of the time in the data is about the continuous.
So only if the patient has got very debilitating symptoms, then probably they would opt for stopping the ADT. Otherwise, most of them would opt for that.
Dr. Santosh, I'm sorry.
Take-home message. Take-home message, the new adjuvant pre-RP treatment almost there, but we need some more. Dilutamide, obviously cost would be a deciding factor. And RT and NVERT good outcome in a particular subset of patients. PSA bounce in BCR. Dynamics of PSA has been mentioned, should be the focus. PSA targeted therapy doesn't help in BCR boost salvage. Thank you very much.
Thank you, Dr. Santosh <silence> And ladies and gentlemen, I think after such intense deliberations and the discussions still continue to simmer, you can have it over your tea or coffee. So we break for a tea and coffee break. May I request you all to please be back in 10 minutes by 10:55 when we resume our sessions. And I will request our chairpersons to please be back on time because you'll have to continue chairing the session. Thank you very much.
Pleasure to see.
मैं सरफिरा मुसाफिर हवाओं पे चलूं यारों का मैं यार हूँ हाँ हंस के सबसे मिलूं इन खाली खाली जेबों में इरादे बेहिसाब
You are listening to Sleep on Phantom Radio.
will be presented by Dr. Udip. Are you ready, Dr. Udip? Dr. Udip is a consultant medical oncologist at MOC Kemp's Corner, Mumbai. And the first two abstracts will be presented by Dr. Udip. So you have 6 minutes to present these two. Thank you very much. May I request the delegates to please be seated and continue your conversations outside the hall, not inside the hall. Ma'am, may I request you to please be seated? Excuse me, ma'am, in the center of the hall. We have started the sessions. Thank you very much.
Good morning, everyone. I am Dr. Udip Maheshwari. I will be presenting these two abstracts. The first one is PD-3508, which is oral relugolix for androgen deprivation therapy in advanced prostate cancer, pooled safety analysis from randomized control studies. So, relugolix is a Okay, so relugolix is a highly selective oral active non-peptide GnRH receptor antagonist. It is approved for treatment of men with advanced prostate cancer. In phase 3 HERO study, relugolix demonstrated sustained testosterone suppression superior to that of leuprolide. It had shown a safety profile consistent with its mechanism of action and a 54% decrease in risk of major adverse cardiovascular events relative to leuprolide. In order to provide a detailed summary of relugolix safety profile, there was this analysis done from 2 randomized relugolix clinical trial. The pooled safety analysis included data from 1012 men with advanced prostate cancer. 934 men were in the phase 3 HERO trial and 78 men were from the C27002 randomized phase 2 trial. Only men who received either relugolix, 120 milligram orally once daily and 360 milligram of a loading dose or leuprolide injections every 12 weeks for 24 to 48 weeks were included. Safety assessments included clinical laboratory tests. The adverse events were reported as per CTCAE, and the major adverse cardiovascular events, that is MACE, was defined as non-fatal myocardial infarction, non-fatal stroke, and death from any cause. Individual patient data were pooled and results were summarized. So the overall incidence of adverse events was 93% versus 93.7% in relugolix versus leuprolide. Hot flushes were the most common side effect, was similar, almost similar in both arms. Grade 3 AEs occurred in 17.2% and 19.6% in relugolix and leuprolide arm. The most common grade 3 AE were hypertension, which was 1.6 versus 0.6%. And syncope. Fatal events were reported for 1% of men in relugolix group and 3% in the leuprolide group, which is very significant. MACE incidence in this pooled analysis was 2.8% in the relugolix arm as opposed to 6.3 in the leuprolide group. So the thing that I want to highlight here is if you look at the grade 3 events, that is the MACE events, are significantly higher in the leuprolide arm, that is 4.2% versus 2.2%, right? So in conclusion, in the pooled safety analysis, 2 randomized clinical studies, relugolix was generally well tolerated with a lesser incidence of MACE related relative to leuprolide. So my thoughts, relugolix was developed as an oral highly selective GnRH antagonist that is given once daily with a half-life of 25 hours. Relugolix rapidly inhibits LH, FSH as well as testosterone levels. Death from cardiovascular events, cause of death in patients with prostate cancer and now account for 27 to 34% of deaths. So relugolix had significantly less cardiotoxic activities and it is a welcome side effect profile. So now coming to my second abstract. One second. You have to discount this timer of changing the slides. Sorry. So going to the second abstract, which is the magnitude study. First results of niraparib with abiraterone acetate and prednisolone as first-line therapy in patients with metastatic castration-resistant prostate cancer with and without homologous recombinant alterations. So I'll quickly go through the background. Approximately 20% of metastatic CRPC has alterations in gene associated with HRR and is responsible for PARP inhibition. Combined PARP inhibitor and androgen receptor pathway targeting also benefits unselected CRPC patients. Metastatic CRPC. Magnitude assessed whether adding niraparib to the abiraterone and prednisolone improves outcome in patients with mCRCC. So Magnitude trial is a randomized double-blind trial in eligible patients. So we go to quickly to the flowchart wherein HRR biomarker positive and HRR biomarker negative patients were separately randomized to niraparib plus AAP and versus placebo. Primary endpoints being RPFS and secondary endpoints being cytotoxic chemotherapy, time to cytotoxic chemotherapy and time to symptomatic progression. So if you see the HRR 423 HRR BM positive patients were randomized, and the NIRA and AAP delayed the time to cytotoxic chemotherapy, time to symptomatic progression, and also improved the overall response rates in HRR biomarker positive patients. The pre-planned futility analysis of 233 biomarker negative patients showed no benefit of adding NIRA. So in HRR negative patients, it was not beneficial. No safety signals were seen. HRR bone marrow, the biomarker positive patients, 67% and 46% had grade 3, grade 4 AE, and 9% and 3.8% discontinued treatment. So that was also okay. There were no clinically significant difference in overall quality of life. So if you see the results, there is improvement in RPFS in both the analysis, and HR is a significant of 0.53. So in conclusion, niraparib plus androgen deprivation therapy, the abiraterone acetate plus prednisolone improves RPFS and other clinically relevant outcomes in patients with mCRPC and alteration in HRR associated genes. There was no evidence of benefit with addition of niraparib to AAP in HRR BM negative patients with mCRPC. Last slide, up to my thoughts, up to 30% of the patients with metastatic CRPC have deleterious alteration in the gene associated with HRR. These HRR alterations are associated with poor prognosis, but also offer sensitivity to PARP inhibitors. Androgen receptor signaling regulates DNA repair in prostate cancer, providing a rationale for combining AR targeting with PARP. And niraparib is a potent PARP inhibitor that has demonstrated tumor activity in heavily treated mCRPC. In this study, ARP plus the AAP plus NIRA significantly improves primary clinical outcome with a 47% improvement in RPFS and in patients with BRCA1, BRCA2 alterations and 27% across HRR positive patients. However, OS data is still awaited, opens new options for HR positive patients. Thank you so much.
Thank you, Dr. Udip Maheshwari. Without wasting much time, I would like to call upon our next presenter, Dr. Akshay Shivchand, who is a consultant medical oncologist at MOC Kolhapur. The next two abstracts will be presented by Dr. Akshay.
Good morning. So I'll be going to present two abstracts. First is the overall survival in patients with metastatic hormone-sensitive prostate cancer treated with enzalutamide or placebo plus androgen deprivation therapy who had prior local therapy. That is a post-hoc analysis of the phase 3 ARCHES trial. It was presented by Taro Iguchi, Ishikawa, Japan in AU annual meeting 2022. So in ARCHES, as we know, enzalutamide plus androgen deprivation therapy improved radiographic progression-free survival and a key secondary endpoints versus placebo plus ADT for patients with metastatic hormone-sensitive prostate cancer. So final overall survival results confirmed the long-term survival benefit with enza plus ADT in the overall study population with hazard ratio of around 0.66. So here they report a post-hoc analysis of OS in patients with prior local therapy. So defined as previous radical prostatectomy and or a radiation therapy to the prostatic area. So the patients with metastatic hormone-sensitive prostate cancer, around 1150 patients were randomized to 1:1 to enza versus placebo. It was stratified by disease volume and prior docetaxel use. So after unblinding, around 31.3% patients from placebo groups had crossed over to the open label enza plus ADT. Median OS and hazard ratios were estimated by Kaplan-Meier and Cox proportional hazard respectively. And the further analysis by type of prior local therapy, that is RP, RT or type of RT were performed. So this was Kaplan-Meier showing, so the median treatment duration was 40.2 months with enza plus ADT, 13.8 months with placebo plus ADT, and in crossover patient, it was 23.9 months. So median follow-up time was 44.6 months, including crossover. The 69.9% patients, that is placebo plus ADT group, patient had subsequent life-prolonging therapy, and the prior local therapy was reported in 118 patients of enza plus ADT and 122 patients of placebo plus ADT. So the enza plus ADT reduced the risk of death by around 46% versus placebo plus ADT in patients with prior local therapy, with consistent with overall study population. And the median OS was not reached in either of the arms. So to conclude, the post-hoc analysis demonstrated that long-term survival benefit of enza plus ADT versus placebo plus ADT in patients with metastatic hormone-sensitive prostate cancer who received prior local therapy. So the quick comments, the ARCHES had already showed the survival benefits of enza plus ADT over placebo plus ADT, and it's irrespective of what the local treatment was given to the patient with low volume disease, with or without docetaxel use. So my next abstract will be overall survival with darolutamide versus placebo in combination with ADT and docetaxel for metastatic hormone-sensitive prostate cancer in the phase 3 ARASENS trial. It was presented at ASCO 2022 GU Symposium by Dr. Matthew Smith from Massachusetts General Hospital and Harvard Medical School. So as we know, darolutamide is a structurally distinct and highly potent competitive androgen receptor inhibitor. It has demonstrated improved overall survival and metastasis-free survival versus placebo, and a low incidence of treatment-emergent adverse events in patients with non-metastatic castration-resistant prostate cancer, that is in the ARAMIS trial. In the ARASENS trial, they investigated whether darolutamide in combination with standard ADT plus docetaxel would increase OS in patients with metastatic hormone-sensitive prostate cancer. So it's an international double-blind phase 3 trial. 1:1, they are randomized into darolutamide 600 mg twice daily versus placebo plus ADT plus docetaxel. It was stratified by extent of disease according to TNM staging and alkaline phosphatase level. The primary endpoint was OS, the secondary endpoints being time to CRPC, time to pain progression, time to first symptomatic skeletal events, and time to initiation subsequent systemic anti-neoplastic therapies. Safety was also assessed. So around 1,306 patients were randomized, 651 to Daro and 655 to placebo arm. Median age was 67 in both the arms. At the primary data cutoff, darolutamide significantly decreased the risk of death by 32.5% versus placebo. The significant OS benefit was consistent across pre-specified subgroup. Also, darolutamide significantly delayed time to castration-resistant prostate cancer versus placebo. The time to pain progression also significantly longer in darolutamide group. Time to first skeletal event also prolonged. Time to initiation of subsequent systemic anti-neoplastic therapy also prolonged. And in the treatment-related adverse events, in darolutamide, they had 13.5% of patients treatment discontinuation as compared to 10.6% in placebo arm. So in patients with metastatic hormone-sensitive prostate cancer, early treatment combination with darolutamide with ADT plus docetaxel significantly increased OS. It also improved key secondary endpoints, and the incidence of treatment-related adverse event was similar in the two treatment arms. Now, take-home message is darolutamide is now available in India, but the cost is an issue. It costs around 1.38 lakh per month for the patient. This study done in a population where docetaxel is indicated, and this study did not answer the question of whether adding docetaxel chemotherapy to the ADT plus novel hormonal therapy backbone will also improve the survival. Thank you.
Thank you, Dr. Akshay Shivchand, for finishing quite well in time. I invite our next speaker, Dr. Prasanna Deshmukh, who is a consultant medical oncologist at MOC Panvel, to present the next two abstracts. Thank you.
Good morning, everyone. I'm going to present the PROPEL trial. That was a phase 3 trial of olaparib and abiraterone versus the placebo and abiraterone. It was used as a first-line therapy for the patients who are having a metastatic CRPC. In the preclinical studies that have shown that when we are combined the combined anti-tumor effect through the interactions between the PARP and androgen receptor signaling pathways. There was a phase 2 trial in patients who are having a metastatic CRPC that was unselected by the HRS status and who previously received the docetaxel, they have demonstrated improved radiological PFS for the patient who were treated with olaparib and abiraterone versus the placebo plus abiraterone. So the primary endpoint of this study was the investigator-assessed radiological progression-free survival, and there are multiple secondary endpoints like the time to the first subsequent treatment and the time to the progression-free survival or death. So it was the randomized double-blinded placebo-controlled phase 3 trial in which the patients who are having metastatic CRPC undergoing the first-line primary treatment after failure of the primary ADT. They were enrolled independent of their HRS status. The patients were randomized to receive olaparib 300 milligram twice daily or placebo along with the abiraterone and prednisolone. So 796 patients were randomized to this in trial. And the interim analysis in this trial, the olaparib and abiraterone, the number was 399 and the placebo was 397. The interim analysis that has shown that first-line treatment with the olaparib and the abiraterone significantly prolonged the radiological PFS versus the placebo plus abiraterone in patients who are having a metastatic CRPC, irrespective of the HRS status. As we can see, the duration was 24.8 months versus 16.8 months with a hazard ratio of 0.66. The predefined subgroup analysis also showed that radiological PFS improved across all subgroups, and that was including the patients with or without the HRM mutations that was detected by the circulating tumor DNA testing. And a sensitivity analysis of radiological PFS was done by blinded independent central review was consistent with the primary analysis. The overall survival is currently immature. There are 228 deaths. The overall survival favoring the olaparib was observed. And the secondary endpoints that were also supportive for the long-term benefits of these drugs. So in an interim analysis, the PROPEL met its primary objective, demonstrating significant improvement in the radiological PFS for olaparib plus abiraterone versus placebo plus abiraterone in patients with newly detected metastatic CRPCs who had not received any prior first line of therapy, irrespective of their HRS status. The safety profile was consistent with what we are knowing, what are the side effects for the drugs. And the results also demonstrate the benefit of olaparib plus abiraterone without the need of HRS stratification in the primary first line treatment of metastatic CRPC. What I can see, the interim analysis is immature. The olaparib and abiraterone showed significant PFS without HR, and how we are going to use this in our current practice. Coming to the second abstract. The second abstract is how the patients who have received the ADT for the prostate cancer and what was the cardiovascular risk they are associated. So this was the evaluating cardiovascular risk in men starting androgen depressing therapy for the prostate cancer. ADT remains the foundation of the advanced prostate cancer treatment. Since 2010, the FDA has required a warning for the risk of cardiovascular disease in labeling of GnRH receptor agonist. In 2021, AHA has recommended baseline assessment of cardiovascular risk in the men who were started on the ADT. However, their optimal evaluation and the management of cardiovascular remains to be defined. And this is the real-world evaluation in which the man receiving ADT to understand the association between the cardiovascular risk factors and the further events. So in this, the patients who are having the prostate cancer and who have received the ADT, the duration was from the 2010 to 2019 were identified, and the index date was when they first started on the ADT, and there was a continuous enrollment of the 12 pre and the 6 post index was required. And the qualifying the cardiovascular events were the post-index hospital admission or any emergency department visit, whether it is because of the CVA, coronary bypass, or myocardial infarction, or PCA, thrombosis, or unstable angina. And a Cox regression model including the pre-index covariates of age, cardiovascular history, radiation, or prostate cancer surgery or other metastatic drug therapy. And time on the GnRH agonist was used to examine time to first CV event up to the 3 years post-index. And additionally, the CV risk based on the comorbidities and the CV-related treatment were evaluated by the subgroups of high, moderate, or low risk scores. So in this study, there were 10,530 patients who were having the prostate cancer and treated with ADT. And out of these, 10,008 patients received GnRH agonist during the 3-year observation period. And 99 patients, they experienced a cardiovascular event post-index. The Cox model showed that cardiovascular risk was the cardiovascular risk that has shown a hazard ratio of 2.80 with a significant p-value, and their high and moderate cardiovascular risk was 1.94 and 1.40 as compared to the low risk. And the metastatic drug therapy and the time to GnRH agonist and age that were associated with the high risk for the CV events. The radiation and the prostate cancer surgery was associated with the lower risk of CV events. To conclude, the CV history conveyed the highest risk of a new cardiovascular event up to 3 years after starting ADT treatment. Stratification by the risk level was predictive of a CV event, and the evaluation of this factor provides a framework for the physician to start men on the ADT to identify those who are having at the greatest risk of CV events. Thank you.
Thank you, Dr. Prasanna Deshmukh. Now we have a panel discussion on the same topic, that is metastatic prostate, and I call upon Dr. Chirag Desai as a moderator. Dr. Desai is a director and consultant medical oncologist at Vedanta Institute, Ahmedabad. I invite the panelists, Dr. Vashisht Maniyar, who is a senior consultant medical oncologist from MOC Ghatkopar, Dr. Kshitij Joshi, who is consultant medical oncologist, MOC Vilepale, Dr. Amit Joshi, who is a professor Uro-Onco DMG at Tata Memorial Hospital, Mumbai, Dr. C.V. Pete, senior consultant medical oncologist at MOC Nashik, Dr. Pradeep Kendre, who is consultant medical oncologist, MOC Borivali, Dr. S.K. Raghunath, who is director and head urologic oncology and robotic surgery at HCG Cancer Hospital, Bangalore, Dr. Baman Dhabar, who is a senior consultant medical oncologist at Fortis, Mulund. I hand over the session to Dr. Chirag Desai.
So good morning, everyone, and thank you very much for involving me in this wonderful discussion. So what we are going to do over the next 24 minutes is to discuss the last 6 abstracts which were discussed in last few minutes. So we have 6 medical oncologists and we have 1 surgical oncologist. I'm sure that Dr. Raghunath will be able to take on the all medical oncologists. So we have 24 minutes, so straight questions, straight answers. So these are the 6 abstracts, but broadly, one is about cardiovascular risk of ADT, one is about oral GnRH agonist, 2 are about castration-naive prostate cancer, and then 2 are about first line in metastatic CRPC. So androgen deprivation therapy is one treatment which is most effective treatment in the medical oncology as we are seeing. No other treatment is as effective as androgen deprivation therapy is in metastatic carcinoma of prostate. But it has its own side effects. And Dr. Raghunath, which are the side effects which you are often looking at in your practice?
No, generally, fatigue and outflashes are very common. Right. Apart from whatever you have said. In the long term, definitely we should look into osteoporosis and cardiovascular events.
And in general, Dr. Amit, how do you mitigate these side effects?
So I think in a busy OPD, it's difficult, but what I used to do, definitely for osteoporosis, baseline, if patient is reporting, I do for a DEXA scan. That is the one thing. And the baseline cardiovascular, do all the lipid profile, sugar for all patients for a baseline. Patients who are at high risk for or having a history of cardiovascular event past, I tell them to meet their cardiologist once and tell them that this drug may cause. And if we have a physiotherapy department, so we send the patient for a physiotherapy for muscle strengthening.
So that's correct. In general, we will try to identify the patient who will do good enough with intermittent androgen deprivation therapy. So now the subsequent discussion that we will go ahead will be about the patient who will require continued androgen deprivation. The first abstract was about, it was the last abstract that was presented by the previous speaker about evaluating the cardiovascular risk in men starting androgen deprivation therapy for prostate cancer. It included 10,000 plus patients, and most of them were treated with LHRH agonists. So this abstract will not guide you to what type of androgen deprivation you will be selecting. And the cardiovascular events were identified as the cerebrovascular accident, coronary bypass graft, myocardial infarction, cardiac intervention, thrombosis, and unstable angina. And time to first CV was up to 3 years post-index. So, Vasisht, when classically do you see cardiovascular event and most of these side effects in your practice once you start the ADT?
So I typically tend to see them in the first year. And very honestly, sir, of late, I have become much more cognizant of discussing these cardiovascular side effects. We tend to push it under the carpet. And also, sir, a very brief point on the castration-related effects that you mentioned. I believe it's a very under-addressed problem by a medical oncologist. Sometimes a patient comes to us, we only harp on the fact that the PSA decreased, but the patient is usually very unhappy. And I think spending time understanding and explaining them lifestyle changes is extremely essential, as Amit sir mentioned. I, sir, of late, for the last couple of years, have started involving a cardiologist at baseline for every patient that I start with androgen deprivation therapy.
So cardiovascular history was the most important associated factor with the highest hazard ratio for developing cardiovascular events, followed by high and moderate cardiovascular risk, other metastatic drug therapy. So Pradeep, if your patient has a cardiovascular history and patient comes with metastatic CRP, metastatic castration-naive prostate cancer, will you or will you not add any other drug to the androgen deprivation therapy?
So presently, whatever the basket that we are available, the medicine, if you consider the ADT is the backbone for the metastatic prostate cancer, so we don't have any another options until unless you discuss everything.
My question is
with the
about
patient.
adding another drug.
So among those things, the daycare was the most effective option that I feel
So
in
that
clinical
will
practice.
come with the subsequent. In addition to whatever ADT, we have 3-4 options: enzalutamide, abiraterone, docetaxel, or a combination thereof. So what will be your choice, or only ADT?
So enza would be the choice for me, sir.
Any reason for that?
So I'll be avoiding the steroids here. So steroid itself causes dyslipidemia and the diabetes-related complications, which will enhance the issues.
Right. And the length of ADT was not a very significant factor. So as the Vasisht said, beyond first couple of years, we don't see increase in the rate of cardiovascular adverse events once they are effectively managed. So this was a retrospective study mainly looking at GNRH analysis up to 3 years. Kshitij, will it affect your practice on Monday morning, or is it just additional information that you are gathering?
Yeah, definitely we are actually aware of the things, but this is additional information. We will keep always in the mind that we have to counsel them regarding the same, although we are doing that, and choose drugs accordingly. And definitely it will affect somewhere, but we are doing the same.
It is something like orange light, not a red light or not a green light. So it's a reminder that we have to look for the side effects, right?
Because we are dealing with very elderly population, half of them are the cardiac having this thing.
So for cardiovascular effect, ABCDE is what is required: awareness and aspirin, blood pressure management, cholesterol and smoking management, diet, diabetes, and exercise. So Chandrasekhar, we have a lot of discussion about antagonist versus agonist. So what is your preference and why?
So before answering that question, let me pull you back a little. For chemotherapy, the solutions are very simple. That we talk about chemotherapy toxicity, docetaxel, for a limited period of time, for say 18 weeks. That's it.
Yeah.
But for all these other agents, agonists, antagonists, we are talking of long-term therapy. So first and foremost, I think we should be concentrating more on the financial toxicity, in addition to the cardiovascular toxicity that we are already talking of.
Right.
Second, as Vasisht pointed out, we have to be very diligent about the first year after we start off with ADT.
Agreed. So that point is discussed. Now, my question is very specific. Are you convinced that antagonists are very safe as compared to agonists?
Partly.
Okay. Amit, what is your opinion about that?
So if you look to the data of this antagonist versus agonist, the event, the rate of event for cardiovascular was less on the, so they have not excluded that. So the cardiovascular was less in the antagonist arm. That was the interpretation. And from that point of view, I think the Degarelix people have come with this, that it is more safer. So we have to take little bit risk of that. If we have to choose in a known patient of a cardiovascular disease, there is a data that indirectly we can say that antagonist may be little bit safer, but it's not that it will not cause any harm. It may have its own associated, because of the effect is because of the reduced testosterone.
Right.
So the other question which is more relevant in the second question which you have heard, is there any benefit of the archidectomy versus the, so that question is still unanswered. Whether the cardiovascular risk in a patient who underwent bilateral archidectomy vis-a-vis received the antagonist or agonist, that question is unanswered. But I remember there was a pooled analysis of the US data, which indirectly shows that the incidence of the cardiovascular, particularly the metabolic abnormality, was lesser in the patient who underwent bilateral archidectomy. So from that point of view, I still prefer the bilateral archidectomy for a patient who has a metastatic disease, because the money can be saved in that.
Raghunath, quick answer.
Yeah, it is not just about suppression of the testosterone, suppression of the FSH, which is best with the Degarelix. Next is archidectomy, then is agonist.
So Vasisht, okay, we will continue the discussion over lunch.
Very clear.
We will continue the discussion over lunch. Let us finish these 6 abstracts. We are just on the second one. Vasisht, if you decided that you want to give antagonist, will the data presented about relugolix is good enough for you to switch from Degarelix to relugolix?
Sir, only 2 points. One is that I still don't have OS data. That is number one. And number 2 point is that here we are talking about a daily oral therapy versus an injectable which is once in 3 months. I think that's a very important point when we are discussing with the patient. It can add to a lot of...
That is good or bad?
It's bad. Definitely bad. Yes, absolutely. It significantly affects compliance.
Right. So what is the problem with Degarelix? He said that is problem with relugolix. Pradeep, what is the problem with Degarelix?
In some extent, I concur with Vashish Bhai regarding the oral formats of the treatment. I'll answer your question first. The first thing is besides the complication thing, what we need to see in oral format here is the most meaningful, effective, and the rapid reduction of the testosterone level, which is more with the Relugolix arm. The second thing is the easiness of taking the medicine. Though we feel it's a daily pain, but if you consider the patient's perspective, coming to the hospital, seeing the doctor, waiting for 2 hours, it's somewhere they feel more of trouble during this period. It offers some upper hand to the patient.
Please finish. Yeah. Just a second. Let me twist the question a little bit. We have 4 options. Once and for all, orchiectomy, 3 monthly agonist, monthly Degarelix, and oral relugolix. So what do you think your patient will accept more?
If finance is not a problem, and if compliance is there, probably relugolix is a better option. Degarelix, local side effects are more, and it's a monthly preparation. 3 monthly preparations are not available. These are my take on relugolix and Degarelix. Rest all we know.
Kshitij, referring to NCCN, there are a couple of paragraphs about relugolix. Can you have your comment on relugolix?
Yes, sir, definitely it's promising when you compare, that is the last question, to oral drug compliance of a patient versus injection. There is some psychological hindrance to take injections coming to the hospitals where it is beneficial. But still, as Vashish Bhai has pointed out, we still need some OS data. But definitely I will.
Quick comment. Yeah. So relugolix has fewer cardiovascular side effects.
Yeah.
But nowadays, what we are looking at is in CNPC patients, we don't give only ADT. We combine with some additional drug, and we don't have any data of combination of relugolix with the other drugs. That is the drawback, and we don't have the long-term survival data. There is another drawback. So with that drawback, relugolix seems to be a good drug, and we need to continue evaluation of that drug. So Chandrasekhar, again, Monday morning, if you have relugolix available, if you have everything available, and mind well, Modi has deposited 15 lakh rupees in everyone's account. So don't worry about finance. What will you do?
No, I think I would not change my practice so early. I am still very fond of getting orchiectomy done.
So you will need some more data about switching to relugolix, right?
Yes.
Good. So about metastatic CNPC, and we have enough evidence now that only ADT is not sufficient for most of these patients. ADT with docetaxel, abiraterone, enzalutamide, we have robust data with multiple clinical trials, and then we have the data of combining multiple drugs together. So we have two trials, ARCHES trial and ERASENS trial, and Amit. ARCHES trial randomized enzalutamide versus placebo, and the stratification factor were volume of disease and prior docetaxel therapy, right? So if your patient had taken docetaxel, so it was none, 1 to 5 cycles or 6 cycles. So what is your usual practice, whether you give docetaxel or something else in your practice?
So I think till the time when the piece 1 data was not available, we combined either the DOSI in a high volume patient and ENJA versus ABI in patients who are low volume. Those who are having some comorbidity and all that, we consider ENJA, otherwise ABI. DOSI with ENJA, we have not practiced much, but definitely the subsequent further data has shown that in patients who are of high volume disease, there is a benefit of docetaxel with. So we have not considered docetaxel with enzalutamide till now.
Raghunath, this abstract was looking at the patients with metastatic CNPC who were previously treated with local therapy, right? If you had done RP in a patient, or let us say you had given radiation to the patient and then patient becomes metastatic, will that factor affect your decision of offering the systemic therapy or not?
I don't think it is not going to matter much whether
The only thing is that majority of the trial have taken the de novo metastatic patient. So that is one thing that this trial, this post-hoc analysis has shown that this combination may work also in patients who have taken some treatment, because other have taken 80 to 90% are de novo metastatic.
So Vasisht, the entire population had the hazard ratio in survival of 0.66. And the patient who were treated with one of the local therapy earlier had the hazard ratio of 0.54. So does it mean that you will be wanting to offer enzalutamide to the patient who were treated with prior local therapy or not?
See, it may not change my therapy program, sir, because for me now this patient is metastatic and this patient deserves therapy and there is a drug combination available, I should use it. It does not change my treatment protocol tomorrow. Yes, the benefit is more in priorly treated patients. So on Monday morning, it doesn't change how we treat these patients.
Even though it's a good look at the patient in the retrospective manner, does it change your practice on Monday morning?
No, sir, not.
No, okay. So the ERASENS is one of the important trial which did not have the retrospective component, unlike the previous trials, previous presentations. So ERASENS is a good trial, darolutamide, docetaxel, and ADT versus docetaxel and ADT. The primary endpoint was overall survival, good number of patients, 1,300 patients. So this is the overall survival, which was the primary endpoint. Excellent. 0.68 is the hazard ratio, and the secondary endpoint also are better. Safety, surprisingly, I was expecting that the addition of one more drug will increase the side effects of the drug, but it did not. And the final comment is that it's a good drug. So Kshitij, what is your take? If darolutamide is available to your patient, will you change your practice tomorrow morning?
Yeah, but whatever the results suggest, it is quite promising. It is prolonging the OS. So definitely, if there is no availability problem, I would like to consider this option.
So we have the data of docetaxel, ADT, with abiraterone, with enzalutamide, with darolutamide. So looking at these three different set of data, what will you choose in your practice, apart from cost?
Can I get the question again? So I was just...
You have started ADT, you have given docetaxel, right? First dose is planned tomorrow. Will you prefer abiraterone, enzalutamide, or darolutamide, sometimes down the line?
Well, so current my practice, if you ask me to do tomorrow, the enzalutamide might be my option. But in darolutamide, the data is promising in the future, definitely.
So we have PIS1 data, we have Ɂagship data, we have ₦ARCHIS data, and we have darolutamide data. So what looks most promising to you, for you as well as then for Chandrasekhar?
So I think the most promising data looks to be of darolutamide only as of now. But will it change my practice? Probably that will be answered by finances more than.
Okay. Amit, any other comment?
Is that combining docetaxel with abiraterone, sometimes the fluid retention, because docetaxel itself causes some trouble. So sometimes, though in that PIS1 trial it has not quoted that, but in practice the combination of dosi with abi may be a troublesome thing, and we have seen in few patients. So if cost is not a constraint among all these three combination, dosi-daro will be preferred. And the other important point of this study that the crossover was allowed. So majority of the patient received the subsequent therapy. Still their OS benefit is there. So I will prefer this if cost is not a constraint, followed by Anja and then Abi in the third.
Now we have two abstracts on CRPC, first line CRPC. Whatever treatment you may have given in CNPC is okay. You may have given docetaxel, you may have given abiraterone within 3 months of putting the patient on the trial. And I want to discuss biomarkers sometime down the line. So in the PROPEL trial, no screening of HRR mutation was required. Primary endpoint was radiologically progression-free survival. But in spite of HRR was not required, 97% of the patients did have the HRR report. 27 and 29% were positive in olaparib and the placebo arm, and 69 and 68% were negative. So we had the information in majority of the patient. Primary endpoint of PFS by investigator was met with HR of 0.66 in the entire group, and in patients with HRR mutation, the HR was 0.54. Without mutation, it was 0.76. Still, it was statistically significant. So that was about PROPEL study, olaparib. And I will go ahead. The toxicity was equivalent. Clinical benefit of first-line MCRP is regardless of HRR mutation status. And before I start the questions, let us look at the magnitude data as well. Patients were stratified as per the biomarker positivity or negativity. Again, it was the foundation test, those 15 mutations, any of them could have been positive. IDMC recommended stopping. Look at the right lower corner, red highlighted paragraph. Recommended to stop enrollment of biomarker negative patient because of added toxicity and no added efficacy. And in biomarker positive patient, there was superiority of niraparib with abiraterone as compared to abiraterone alone. So the question is, starting from Amit, whether you will do biomarker in your patient or not.
So I think although there is some sort of some pharmacological basis for combining this the olaparib with the abiraterone and all that, but if you look from the realistic perspective, the benefit will be more in the HRR positive. So even this, and if that is the reason, and there is another study which is again negative, I'm not able to recall that study. So this combination of olaparib, abiraterone, although the data is there, I will not prefer. I will prefer using in a patient who are HR positive. Still will want to use.
So Vasisht, we have data for HRR negative as well, right? If you look at the markers, biomarkers for PARP inhibitors, we have BRCA, we have HRR. For ovarian cancer, we have HRD. We are thinking of adding some more genes in HRR panel. We are thinking of deleting some of the genes from HRR panel, less, more, none. So what is, how you will choose the treatment for your patient?
So, sir, I tend to get these biomarkers done for patients who have progressed, for CRPC patients. That's number one. Number two, I do not, as of now, use PARP inhibitors blanket irrespective of the HRR status. Point number three, let's not forget the toxicity of PARP inhibitors. In fact, sir, 80% of my patients do not receive standard dose of 300 milligram BD alone. Forget combining it with another abiraterone or enzalutamide.
All across the indications, right?
Absolutely, across the indication, be it any other HRR positive or BRCA positive. It's a toxic drug. Niraparib also is a very toxic drug in terms of the GI side effects. these are long-term, usages of the drug. Number 5, sir.
Okay.
Yeah. So just last and important point. There is no data as of now where we have compared the sequential use of an enzalutamide followed by a PARP inhibitor versus combining both of them. So I think that data was also very essential to understand the ideal sequencing of these drugs.
So this was the early presentation of the trial. We don't have the survival data as of now. But our PFS data looks promising, right? Pradeep, do you think that we are lacking something seriously in selecting the patient? We don't have a good biomarker for PARP inhibitor in our practice?
Yes, sir. So the only HRR positivity mutation should not be a sole criteria to decide whether to olaparib is to be added. Because I'll just like to quote one trial. It's a profound trial wherein a patient with HRR family mutated gene CDK2 and PPP2, they didn't show any promising response to the olaparib. In fact, the fatality events were more into. So eventually, in the future, it will be more of kind of molecular oriented among the families.
So this brings us to the end of the discussion. Thank you very much to all the... You want to make a comment?
A very quick comment, especially for me practicing in tier 2 and tier 3 cities. Let us not forget the role of platins in PARP in those patients who have HR or BRCA mutant. We have presentations of docetaxel plus carboplatin versus docetaxel alone with nearly a doubling of PFS.
So let us not forget as well. Yeah.
Yes.
So if you look at the 6 abstracts, oral relugolix, good data. Just a second. We need more data on the survival. Magnitude, niraparib, as well as olaparib. We need to have biomarkers, better biomarkers, and we need to have the survival data. And we also need to have the data on the sequential use of each of these drugs. Arches and darolutamide seems to be a promising drug. We need to have the first-hand experience of this drug. And cardiovascular risks are there, and it need to be active mitigation strategy. You wanted to have some comment. Last comment, and then we can...
Sir, I'm sorry, I'll have to interrupt the session. You have exceeded your time.
Fine. Thank you very much.
Sir, I'm so sorry.
Thank you very much.
Thank you, Dr. Chirag Desai, Dr. Ɂagship, Dr. Amit Ghosh, and Dr. Santosh Menon for chairing this session. Our next session is dedicated to bladder cancer, and to chair this session, I would like to invite Dr. Amit Ghosh, Dr. Devendra Pal, and Dr. Ajit Sawant. Dr. Amit Ghosh is a consultant uro-onco-robotic transplant surgeon, Apollo Multispecialty Hospital, Kolkata. Dr. Devendra Pal is senior consultant medical oncologist at Mumbai Oncocare Panvel. Dr. Ajit Sawant is professor head urology at LTMMC and LTMGH, Sion, Mumbai. The first session is sponsored by BMS, and this talk will be delivered by Dr. Vashisht Maniar, who's a senior consultant medical oncologist at MOC Ghatkopar, and he's going to deliberate his thoughts and experience on bladder cancer. I invite Dr. Vashisht Maniar.
Thank you. I guess what I'm talking about is not bladder cancer. We are going up north from the bladder to the kidney, is what I've been asked to talk about. So good morning, everybody. Thank you to the organizers for having me here. I'm going to give you a quick update on a novel combination of dual immune checkpoint inhibitors and how the world is rapidly moving from no treatment of metastatic RCC about 15 years back to TKIs, which were a game changer about a decade back, to second-line IO, which significantly improved survival, to a combination of IO-TKI, which seemed to be giving us zenith in terms of PFS and OS, now to a combination of not using any TKI and only using IO-IO combination. So here we are talking about, can we now control metastatic renal cell carcinoma patients and give them significantly longer PFS and OS without adding any TKI by just modulating your immune system? So here I'll be presenting the improving survival and quality of life in frontline advanced RCC with using both a combination of CTLA-4 and PD-1 inhibition. My slide set, please. Quickly going through what are the current guidelines as we suggest. The ESMO believes that in favorable risk RCC, in clear cell component, still the first line should be a single agent TKI, while in intermediate risk, ESMO suggests that we should either use an IO-IO combination or an IO-TKI, while in poor risk, again, the standard of care is an IO-IO, that's dual immunotherapy, or an IO-TKI. While the NCCN guidelines as of today suggests that in favorable risk patients, the first line category 1 recommendation should be a combination of IO and TKI, while in poor or intermediate risk patients, the combination of either an IO-TKI or an IO-IO can be the standard of care. Apart from cabozantinib, which is used in poor or intermediate risk patients, NCCN believes single agent TKI today should not be the standard of care afforded to our renal cell carcinoma patients. So we'll be quickly running through the updated analysis of the Checkmate 214 study design, which was for a metastatic treatment naive clear cell renal cell carcinoma, which was stratified based on their IMDC prognostic score. Arm A received Nivo with 3 mg per kg plus ipilimumab at 1 mg per kg every 3 weeks for 4 doses, followed by maintenance Nivo 3 mg per kg every 2 weeks, versus the then standard of choice, which was sunitinib, 50 mg per day once daily for 4 weeks on, 2 weeks off. The patients were allowed to even go down to 37.5 mg and even shift to a 2 week on, 1 week off regime. The patients were very well stratified basis their risk in both the Nivo EP and the sunitinib arm. The survival data analysis are there for all of us to see. There is an early separation of curves with significant improvement in the OS. And here we have patients, about more than half of them, who are alive at the end of 3.5, 4.5 years, with a very statistically significant and a robust hazard ratio. Interestingly, what we also see is the response rates. The CR rate of Nivo EP is almost as close to double than what we see with sunitinib. And you see early responses in the intermediate and the poor risk, and these responses tend to continue. The most interesting part about these complete responses that we see in the combination of Nivo EP arm, which amounts to about 1/3 of patients, is the durability of these responses. So even on stoppage of the drug, because of a drug-related toxicity, these responses tend to continue. So if you can see this plot, you will realize that about 30% of patients, even after discontinuation, continue to have long-term remission, and about 86% of patients who were on treatment and who achieved a CR did not lose response. So the moral of the slide is that if you happen to be one of those patients who achieves a complete response, the time that you may take to achieve that is as low as 3 months. And once you achieve a complete response, there is an 86% chance that you may continue to be in complete remission. And if at all you end up stopping the drug because of a treatment-related adverse events, 3 of these 4 patients will continue to have a remission. The PFS is also for all of us to see early separation of curves which continue to remain separate in the IO-IO combination versus Sutent. Treatment-related adverse events, I'll be very honest, when I was first asked to use this combination, or I decided to use it in one of my patients, I was petrified of using the IO-IO combination because of the significant side effects that I had read with the addition of ipilimumab. I had kept the patient in the ICU for the first 6 hours with a crash cart ready. And now I've been using this combination for a good 3.5 years. And luckily, I've never had to access the crash cart. So the infusional toxicities are not as often as we medical oncologists believe. And typically, what we can see, as we see even with Sutent, if the early side effects tend, over a period of time, the body tends to get used to it. And if you can probably navigate the first 2 months on sunitinib, with subsequent months, the tolerance significantly improves. We see similar profile with the immune checkpoint inhibitor combination as well, where over the first few months, if we can manage to navigate the patient through their side effects, the tolerance significantly remains good. Again, what I mentioned a few slides earlier is about the patient who did end up discontinuing because of a treatment-related adverse event. Again, you can see that those patients continue to remain in remission in spite of treatment discontinuation. Now, when we talk about intermediate and poor risk factors, is the benefit and all comers across the same? Well, when we see that the benefit is surprisingly more profound in this data in the IMDC1 risk factor compared to the IMDC2 risk factors, and also in high risk or poor risk, where the data is obviously much more profound. The reason I'm showing you these slides is because while we would want to believe that the benefit of using a dual IO is across the board in intermediate and poor risk, I've taken the liberty to very quickly go through what is this risk stratification and just revise it. These are the prognostic criteria of IMDC when we stratify the risk, and you need to have 0 risk factors to be called as favorable, and even 1 poor risk factor puts you in the intermediate risk arm. Important here is the fact that a hemoglobin of less than 12 is considered as an intermediate risk factor, and dare I forget the fact that we are in India, where 4 on 10 people will have anemia, either nutritional or otherwise. So this can be a major confounding factor when we risk stratify our patients of metastatic RCC using the IMDC criteria. So that is technically we would mean that 4 out of these 10 patients irrespectively will be in IMDC intermediate risk 1. So that brings us to the question that is an intermediate risk 1 as good as favorable risk or as bad as a poor risk? So this is a beautiful study which has studied sunitinib in metastatic RCC in IMDC stratified patients, and it tends to tell us that the IMDC1 risk factor behaves more like a favorable risk patient, and the IMDC2 risk factor tends to behave more like a poor risk patient. Similarly, a real-world data with sunitinib again tells us that, again, it's the favorable risk and the IMDC1 where the curves seem to be going together, and the IMDC2 and the poor risk where the curve seem to be going together. So this large Adonis real-world data concluded that the intermediate 1 risk, the OS was very similar to patients who had a favorable risk. So to summarize, in the first line treatment of metastatic RCC in favorable risk patients, as of now, today, IO plus TKI is the standard of care. In the intermediate risk 2 groups, dual IO or IO plus TKI should be considered the standard of care. However, if you have a progression post combination of IO plus TKI, there is no defined second line, though we have a bucket of few options, but there is no sacrosanct second line that you can offer. While if a patient progresses post an IO-IO combination, TKI remains a decent alternative. I believe in patients who are poor risk or who have high PD-L1 expression, dual IO does score over either single agent TKI or IO TKI. However, affordability is a concern when we talk about a dual IO combination. The current use of combination IO should be reserved, I believe, in poor risk and high PD-L1 expressing subset in the first line setting. Sharing a quick subset of, the slide looks quite busy, so I'll show you the chart of our experience at MOC using a dual IO combination. We've used it in 30 patients. We've screened 30 patients for it. It's a part of a trial. So I'll have limitations to the data sets that I can share, of which 20 patients eventually were on therapy. 19 of these are alive. 2 patients achieved a complete response, and 3/4 had PR or stable disease. And major dose-limiting toxicity was seen in a very small subset of patients, and overall the therapy was very, very well tolerated. Thank you.
Thank you, Dr. Vashisht Maniyar. We now continue with the abstracts on bladder cancer. The first speaker for presenting the abstracts is Dr. Uday Chandan Khede, who is a urologist and uro-oncosurgeon from Wockhardt Super Speciality Hospital, Nagpur. Dr. Uday will be presenting the first 2 abstracts. Thank you.
Hi, good afternoon. Thank you for giving me this opportunity. So I'm presenting first two abstracts, starting with this two abstract on NMIBC, primary TA high-grade bladder cancer tumor, determination of the risk of progression. Coming to introduction and objective, G3 bladder cancer is an under-investigated disease, and because of its rarity, it's common studies together with T1 high-grade disease. Objective was to exclusively study TA-G3 disease and to determine the factor associated with the disease progression. Coming to methodology, total 3,505 NMIBC patients were included, out of which 285 patients had primary TA-G3 with no concomitant carcinoma in situ. Median follow-up was 43 months, and all these patients, approximately 70% of patients received intravesical therapy in the form of adjuvant BCG. So coming to results, so progression more than PT1 occurred in 7.4% of patients, that is 21 patients. In multivariable competing risk regression analysis, intravesical BCG was significantly associated with lower risk of progression to more than pathological PT1, and recurrence in the first year of diagnosis was significantly associated with increased risk of stage progression to more than pathological PT1, and progression to pathological T2 was observed only in 3.2% of patients. In contrast, in variable competing risk regression analysis, again intravesical BCG was significantly associated with lower risk of progression to pathological PT2, and recurrence in the first year of diagnosis was significantly associated with an increased risk of stage progression to pathological PT2. In subgroup analysis of 199 patients who were treated with BCG, there was no statistically significant association with between tumor recurrence in the first year of diagnosis and stage progression. So coming to conclusion, so patient with TA-G3 bladder cancers are considered high risk, but if appropriately treated with BCG, that risk is considerably mitigated. TA-G3 without concomitant CIS should not be considered as aggressive as T1-G3, and it has a lower progression to muscle-invasive bladder cancers. Recurrence in the first year after the diagnosis is the strong predictor to progression to muscle-invasive bladder cancer. So coming to quick comments, so primary TA-G3, which accounts total 7% of bladder cancer, is a rare disease with heterogeneity and a good oncological outcomes. EAU and AAU both differs in the risk stratification, wherein EAU it is considered under high risk and AAU in intermediate risk. So TA-G3 should not be treated as aggressively as T1-G3. So coming to second abstract, long-term follow-up of intravesical gemcitabine and docetaxel as a rescue therapy for non-muscle invasive bladder cancer. So starting with introduction and objective, intravesical BCG is the first-line treatment for high-risk NMIBC. Disease progression and recurrence is common, and it's associated with increased risk of death from bladder cancer. As we know, radical cystectomy remains the preferred treatment for BCG responsive NMIBC, and many patients either which are unwilling or unfit to undergo radical cystectomy. So previous retrospective studies have demonstrated both the efficacy of gemcitabine and docetaxel for treating NMIBC after BCG failure. However, the long-term outcomes of these cohorts are unknown. So objective was 5-year survival outcomes of patients treated with intravesical gem-dosi after BCG failure. So it was a retrospective study done between 2019 to 2017. So patient received here induction course of intravesical gem-dosi installation, 6-weekly installation. The initial responders received monthly maintenance installation for 2 years, and surveillance was performed according to the AUA guidelines. Survival time was measured from the starting of this gem-dosi therapy. So outcomes included high-grade recurrence-free survival, progression-free survival, cystectomy-free survival, cancer-specific survival, and overall survival. And recurrence was defined as pathologically confirmed tumor relapse in bladder or prostatic urethra, whereas progression was defined as recurrence of disease with stage T2 or greater, or cystectomy or death due to bladder cancer. Survivor probabilities were calculated with Kaplan-Meier methods. So total number of patients were 97 and median age was 73 and median follow-up was 49 months. So total, so BCG failure was further stratified as like BCG unresponsive were 35%, BCG relapsings were 38%, BCG intolerant were 11 and unspecified were 16%. So coming to results, 71% and 21% of patients had CIS and high-grade T1 disease respectively. Complete response at initial surveillance was 74% and median duration of response was 26 months. Overall, high-grade recurrence-free survival at 1, 2, and 5 years was 60%, 51%, and 31% respectively. High-grade recurrence-free survival was similar and among BCG unresponsive patient and the overall cohort. During follow-up, 18 patients underwent radical cystectomy and 28 patients experienced disease progression. So PFS, CFS, CSS, and OS at 5 years were 68%, 75%, 91%, and 64% respectively. So coming to conclusion, intravesical gem-dosi for high-risk NMIBC after BCG failures offers long-term efficacy and substantial durability of response with a high likelihood of bladder preservation at 5 years after induction. Further prospective trials are needed for assessing gem-dosi. So quick comments. Sequential intravesical installation of gem-dosi are safe, well-tolerated, and efficacious. It can be considered in patients who are not willing for radical cystectomy after BCG failure. Thank you.
Thank you, Dr. Uday Chandan Khede. I now invite Dr. Amandeep Arora for presentation of the next abstract. And Dr. Arora is Assistant Professor in Uro-Oncology at Tata Memorial Hospital, Mumbai.
Very good afternoon, everyone. So this abstract is about comparing immediate, that is early radical cystectomy versus BCG therapy for T1 high-grade NMIBC. So when we read the title of the abstract, we kind of assume it is for T1 high-grade urothelial cancer, but they were actually dealing with squamous cell cancer in the abstract. So squamous cell cancers are usually locally advanced that we see, but they were dealing with the T1 squamous cell cancers. So for squamous cell, it ranges from either having a urothelial with some squamous differentiation or a pure squamous cancer. T1 with a variant is usually assumed to be very high risk, and the guideline recommendation is to go ahead with an early cystectomy. This paper wanted to look at how do patients who are treated with BCG therapy for such cancers fare. So it was a retrospective study, 15 centers across Europe. Across Europe, 15 centers in 20 years could still accrue only 188 patients. Two groups, either receiving early cystectomy or BCG therapy for T1 squamous cancer. And the two groups were then compared for cancer-specific mortality and overall mortality. And they also performed some analysis to look at predictors of recurrence or progression in patients who were treated with BCG and not with cystectomy. So coming to the results, they had a median follow-up of 3 years, which is pretty decent. Immediate RC was only in 20% patients, so just 20% of 200 is around 20 patients is what 40 patients is what was the cohort comprising immediate RC. So pretty small numbers. So when we look at results, if you can just see, yeah, so the green one, the cancer-specific mortality is higher in the patients treated with immediate RC. And even the overall mortality is higher in the patients treated with immediate RC. However, the p-values are not very significant. In fact, here the p-value is borderline significant, 0.052. So among patients who were treated with BCG therapy, T1 squamous treated with BCG therapy, there was a recurrence in 41% patients, median time of only 8 months, not very good. Progression in 24% patients, median time 19 months, again not very good. So pure squamous cancers, this was an independent predictor of progression. LVI was an independent predictor of recurrence and progression. Again, for recurrence-free survival, if we can see, the blue line as we see, those pure, the blue line is neither pure squamous nor LVI, so these patients fared better. So to conclude, the investigators say that for T1 squamous cancer, which is neither pure squamous nor it has LVI, you can still use BCG. But if you have a T1 squamous with pure squamous or it has LVI, you still need to go ahead with an immediate cystectomy or an early cystectomy. What I would want to say is T1 squamous is itself not a very common scenario. It came to less than 1 case per institute per year in this study. This was a retrospective analysis. Patients who were treated with cystectomy did not fare good, which tells us that they were all obviously selected patients. Investigators thought that these patients would not do good and hence underwent a cystectomy. We do not know the schedule of BCG because patients were treated over 20 years. We do not even know whether all of them underwent a re-TURBT because they were T1 patients. And we are not very sure if, the percentage component of SCC is very important. We know it is very important in micropapillary, but there was no mention about this. Probably they would mention it in the full paper later on. Thank you.
Thank you, Dr. Amandeep Arora. I now invite Dr. Keval Patel, who is a consultant uro-oncologist from Gujarat Cancer and Research Institute, Ahmedabad, to present the next abstract. May I request Dr. Jeevan-Jyoti Mishra to please come and have his presentations, which are back-to-back 2 abstract presentations. Dr. Jeevan-Jyoti is a uro-oncologist at Acharya Harihar Postgraduate Institute of Cancer, Bhubaneswar. Sir, I'll ring the bell when the first 3 minutes are over. Thank you.
Good afternoon. Thanks for giving me the opportunity to present here. And my first paper is Incidence and Outcomes of Nodal Metastasis in Clinically Non-Muscle Invasive Bladder Cancer. Radical cystectomy is recommended in non-muscle invasive bladder cancer patients in high risk of progression and with persistent disease despite intravesical therapy. The role and extent of lymphadenectomy is controversial and is not universally performed. And the objective of the study was to evaluate the incidence and pattern of nodal metastasis in patients undergoing radical cystectomy for treatment of clinically non-muscle invasive bladder cancer. And the data was collected prospectively. The study period was from 2002 to 2019, and the patients are included who underwent radical cystectomy with super extended lymph node dissection with intent to cure for urothelial carcinoma of the bladder. And the inclusion criteria was clinically stage 1 TA or carcinoma in situ or TU1. In TURBT specimen, if muscle is present but not involved, no prior diagnosis of T2 disease, no prior systemic or radiation therapy, and patients who had undergone super extended lymphadenectomy with up to the level of IMA with mapping information. Total number of patients were 223 and the median follow-up was 8.2 years. Lymph node metastasis was identified in 8.1% of patients, which is 18 patients. The nodal metastasis was not found in carcinoma in situ and TA patients, but it is found in only in T1 disease, which is 11.6%. Out of the 18 patients with lymph node metastasis in T1 disease, 61% had positive nodes below the common iliac bifurcation, 6% had positive nodes below the aortic bifurcation, and 33% or 6 had distant metastasis to the lymph node proximal to the aortic bifurcation up to the IMA. And there is no skip metastasis. After radical cystectomy, 89% of clinically T1 with nodal metastasis were obsessed to muscle invasive disease. And presence of LVI on TURBT specimen was significant predictor of lymph node metastasis. 5-year recurrence-free survival was 91% and 82% and 61% in pathologically NMIBC, clinically NMIBC, and pathological MIBC respectively. To conclude, routine lymph node dissection is necessary in patients undergoing radical cystectomy for clinically T1 disease due to risk of upstaging and lymph node metastasis. Presence of LVI in TURBT specimen of clinically non-muscle invasive is a predictor of nodal metastasis. So patients with nodal disease, metastasis beyond the limit of a standard lymph node template occurred in 2/3 of patients. So however, a standard pelvic lymph node dissection would have identified all patients with node positive disease. So my second paper is 18 fluoro FDG PET CT for bladder cancer staging and decision making in patients with high risk non-muscle invasive bladder cancer. Standard imaging such as CT and MRI has been failed to detecting lymph node metastasis in muscle invasive bladder cancer. But PET CT reported to be more sensitive than CT and MRI in staging muscle invasive bladder cancer, but no data has been reported about its role in non-muscle invasive bladder cancer. The objective of the study is to potentially clinical performance of 18 fluoro FDG PET CT in staging and decision making in patients with high risk NMIBC. It is a prospective study. The inclusion criteria was primary T2 or higher disease, T1 high grade or G3 with or without carcinoma in situ, BCG failure NMIBC. It compared the preoperative diagnostic performance of PET CT with diuretic administration and delayed acquisition with pathological data in patients who underwent radical cystectomy and concomitant pelvic lymph node dissection. The study period was from September 2020 to July 2021. Total number of patients were 47. In PET CT, correctly identified lymph node metastasis in 13 out of 19, which is true positive, and 23 out of 28, which is true negative. In 34 patients with definitive MIBC, PET CT correctly identified lymph nodes in 10 out of 16, which is true positive, and 16 out of 18, which is true negative. In 13 NMIBC patients, the sensitivity was 100%, specificity was 70%, with a positive predictive value of 50% and negative predictive value of 100%. To conclude, preliminary findings showed that 18 fluoro FDG PET CT with diuretic administration and delayed acquisition may detect lymph node metastasis in NMIBC. Larger and multi-institutional series required to confirm the data. So, FDG PET CT can be an accurate tool to detect lymph node metastasis in high risk or very high risk non-muscle invasive bladder cancer. Thank you.
Thank you, Dr. Jeevan Jyoti Mishra. Is Dr. Keval Patel now ready? Okay.
morning. Today I'll be presenting an abstract named PD-L1 expression and BCG response in non-muscle invasive bladder cancer. So, intravesical BCG is a standard of care adjuvant therapy for high-risk non-muscle invasive bladder cancer, yet many patients experience recurrence and as well as progression. The mechanism of BCG is thought to be related to the stimulation of immune surveillance. So, we can relate that systemic immune checkpoint inhibition is being utilized in advanced bladder cancer and approved for BCG unresponsive NIBC as well. The authors, they sought to determine the association between PD-L1 expression and BCG treatment. They traced 102 BCG-naive patients with high-risk NMIBC who were treated with BCG. An initial TUR was done. The specimen was subjected to DACO22C3 assay, and if it was considered PD-L1 positive if the combined score was more than 0. BCG unresponsiveness was defined by presence of high-risk disease at 6 months following adequate BCG. Now, adequate BCG was defined as 1 induction and 1 maintenance cycle only, or 2 induction cycles for PT1, 12 months period for carcinoma in situ, and presence of T1 at 3 months after induction. High-grade relapse was defined as high-grade disease after being followed for 6 months after BCG. They found out the median follow-up was 57 months, which is quite a good follow-up. The median number of BCG maintenance cycle was only 1. 16% underwent immediate reinduction BCGs. PDL expression was observed in 6% of PTA, 30% of T1, and 3.6% of carcinoma in situ patients. Unresponsiveness and relapse was observed in roughly 35% of the patients. On univariate analysis, PD-L1 expression was associated with BCG responsiveness but not with relapse. The sensitivity, specificity, positive predictive value and negative predictive value were 22%, 97%, 93%, and 41% respectively. PD-L1 positive patient had a post-test probability of BCG responsiveness of 93%. On multivariate analysis, T1 and carcinoma in situ were associated with BCG responsiveness. So the authors concluded that PD-L1 expression in high-grade non-muscle invasive bladder cancer was low, and those with PD-L1 expression at initial TUR were more likely to harbor invasive disease. Patients with PD-L1 expression were more likely to demonstrate BCG responsiveness. These findings suggest a role of PD-L1 in immune surveillance mechanism of BCG and may assist in predicting response. Further investigation is needed to determine if additional immune checkpoint inhibitors have strong correlation with BCG response. So what we could analyze the paper that the predictivity of PD-L1 for BCG response is very low. Roughly, to diagnose 1 case of BCG response, we need to test 20 cases of TA and 30 cases of carcinoma in situ. Secondly, the sensitivity is only 20%, meaning thereby that if the test is negative, we could still miss patients who can respond to BCG. And lastly, even after initial response, their relapse was shown even in PD-L1 positive. So that we need more specific and predictive markers for BCG response. Secondly, we also need to study the changes in tumor microenvironment after initial BCG so that we can predict long-term response of BCG. Thank you.
Thank you, Dr. Keval Patel. We now move on to the panel discussion. And as moderator, I would like to invite Dr. Puneet Ahluwalia, who is Director, Uro-Oncology and Robotic Surgery at Max Super Speciality Hospital, New Delhi. I also invite the panelists to take their position on stage. Dr. Ɂagship, who is Senior Urologist from AIIMS Delhi. Dr. Sujoy Gupta, who is a Senior Consultant, Uro-Oncology, Tata Medical Center, Kolkata. Dr. Shrikant Badwe, the Senior Urologist from Max Nanavati Hospital, Mumbai. Dr. Karthik Ganesan, who is Clinical Director, CTMR, Department of Radiology, Sir H.N. Reliance Foundation Hospital, Mumbai. Dr. Umesh Oza, who is Professor and Head of the Department of Urology, Bombay Hospital, Mumbai. Dr. Ananth Krishnan, who is Director of Uro-Oncology and Robotic Surgery, Chennai, at Urology Robotics Institute, Chennai. Dr. Viraj Burgaonkar, who is a Surgical Oncologist at Rupamai Hospital, Aurangabad. Dr. Archie Agrawal, who is Professor, Department of Nuclear Medicine and Molecular Imaging at Tata Memorial Hospital, Mumbai. And lastly, Dr. Kishore Vani, who is Consultant Urologist and Kidney Transplant Surgeon at Kidney Care Hospital and Research Center, Nashik. I hand over the session to you, sir.
Thank you so much for the introduction, and I welcome all my esteemed panelists here. So we have 6 abstracts of NMIBC, which we have just now heard. What my plan is to just keep the discussion based on those abstracts and try to take and derive some take-home messages from those abstracts. So the first abstract about primary TA high-grade bladder tumors and the determination of risk of progression. So Dr. Sujay, my first question is to you. Before going into details of this abstract, TA high grade, it's a sort of a paradox. On one side it is a TA and on the other side it is high grade. So how commonly do you encounter it in your practice, and what risk group would you put it in?
I think we see it quite rarely, certainly less than 10%, probably around 5% mark. And we do put them in the high risk group.
Okay, all TA high grades you will put?
All TA high grade, we don't differentiate.
Okay. All right. So as you rightly said, it's around 7% in the literature, and the risk grouping as per EAU and AAU risk groups, they put it either in the intermediate or in the high risk groups. So I'm not going into the details of these risk factors. We all know about it, multifocality, large size. If these are present, they put it in a higher risk group. So coming to this study, out of 285 patients, 124 patients developed recurrence. So around 43.5% of the patients developed recurrence. And also 21 patients developed disease progression to up to T1. Also 9 patients developed progression to MIBC. So even after 199 patients getting a BCG. So my question, Dr. Shrikant sir, so this study actually showed that the second TURBT was not routinely done in this study. So would you consider a re-TUR in TAG3?
Obviously, yes, of course. We do re-look TURP or second look TURP.
So all Amresh sir, all TAG3 you'll do a second look TURB?
No, as per the standard guidelines, restaging TURBT is not indicated in TA disease. But yes, if there is high-grade disease, we would keep these patients under close observation, and these checks scopy that is done at 3 months, normally it is done under local anesthesia. We may advise them to get it done under general anesthesia, and if there is any recurrence at that time, we will definitely not only go ahead with a deeper resection to establish whether there is muscle invasive disease or not, but we'll also take maybe multiple biopsies to establish whether there is carcinoma in situ or not. Because presence of carcinoma in situ puts these patients in a higher category and a higher risk.
Okay.
And the treatment has to be more aggressive in those patients.
Okay. So according to EAU guidelines, TA, they didn't advise re-TUR, not for high grade, but NCCN guidelines, if you see, for selected TA, which had large tumors, or if it was muscle was not seen, so for those high grade TAs, so they had advised re-TUR. So the second finding, both tumor size and multifocality were absolutely not statistically significant with risk of progression. And they concluded that in patients with NMIBC, these risk factors may help in stratifying the risk groups. However, their prognostic role in TAG3 as such is not sufficient according to this paper. So Dr. Anand Krishnan sir, so my question to you is, you have a TA high-grade disease with a multiple tumor, maybe 3-4 tumors, with one of the tumors of larger size. Would you consider these factors as important, or would you agree with this study that these are not at all important in this?
Yep. So, we always, in a T1 G3, we'd always have a discussion regarding cystectomy for the patient. In a TA G3, I'd be hard-pressed to have the same discussion. So I'll probably go in for treatment with BCG and stuff like that. So whether we treat them differently, I think High grades always risk is definitely significant, so they would need treatment, but not tending towards cystectomy would be my answer.
Okay, so that's what I wanted to actually know, that whether you will give them the option after this of a cystectomy in this group or not. So this is another paper. On the flip side, they have actually told, this paper was published in Journal of Urology, that you consider all TA high grade as high grade and treat them as high grade. Not as just if the patient is having multifocal tumors or larger tumors or other risk factors.
Yeah, to be honest, we don't see a lot of TA high-grade tumors. It's usually T1G3. So yes, I think this discussion, we're nitpicking here. It's high-grade. They kind of go into that program. Right. They behave like that as well.
Right, right. So, Dr. Umesh Oza, sir, so this third finding in this paper, they showed that there was a tumor recurrence in the first year, which was significantly predictor of progression. However, as we saw, 199 patients received BCG, and BCG mitigated the risk of progression. And even if the tumor recurred and the patient had received BCG, so it did not signify a risk of progression. So my question to you is, sir, if you have a patient who is TA high grade and probably multifocal or larger tumor, received BCG, after that recurred, would you agree with this study that, okay, his risk of progression is less and then I'll just follow him up, or you will now give him another option of second line treatment?
No, certainly I'll think of second line of treatment. When we talk of second line of treatment option, one of the options is radical cystectomy. However, I think it's an overkill because there are a lot of factors when we discuss about this particular histopathology. The first is pathological diagnosis. Though I know it's a very select group of people working in uro-oncology, but in day-to-day practice, getting a good histopathology report is a big challenge when you are working in non-institutional setup. Also here, they have not done multiple biopsies to see whether there is a carcinoma in situ. Now, with this background, I think, let me tell you two things. One, that I had a patient which showed superficial tumor with say, low grade, high grade. I think the treatment plan discussed was different. When I sent it to somebody else and it was rechecked, it was a low grade. The whole thing has changed. So what wisdom has dawned on to me? Two things. One, I think the good histopathology report, because see, the whole discussion depends on histopathology. So I think it's very important more for general urologists with a specific interest to understand that good histopathology is very important. Yeah. I also feel second thing is those who are doing a general urology with uro-oncology, in such situation, taking an opinion from uro-oncologists is also appropriate for the better patient care. Because then patient can be followed up, but I think the right diagnosis and guidance is very important. So I think that message has to be carried to general urologists practicing uro-oncology.
Right, sir. Like already we have discussed, immediate radical cystectomy is an option, but it's probably an over-treatment in more than 50% of the patients, and conservative approach, probably you can think of gemcitabine docetaxel in those. So we'll move into the second paper and discuss more about this approach. So I think TA high grade is actually a rare disease, and we have to look into a lot of factors, as all of you have rightly pointed out, about the pathology, about the biopsy report. So there is a significant possibility of pathologic misclassification. This was a retrospective study. Different pathologists had reported differently. CIS was not evaluated. Even there was a lack of fluorescent cystoscopy or random biopsies, which was not done. Also, this retrospective study included only G3 initial tumors, according to the older classification, and G2 tumors in which there may be many high-grade tumors which were missed. So that may affect the results. So moving on to the second paper, sir. So this is, I think, one of the most interesting papers of this panel discussion, because we are going to hear a lot about gemcitabine docetaxel in the recent times to come, and we are already having a lot of discussions about it. So this paper included high-risk tumors, and the possible limitation of this paper, which I immediately thought was definition of BCG failure. So this is a retrospective study of over the last few years, and BCG failures were defined differently in the previous years as compared to now. So it is possible that there is no actual definition which they have given in this paper that this was written as BCG failure. So some might not have actually failed, and inadequate BCG may have been given to these patients. Also, the effect of gemcitabine docetaxel was and their adverse effects were not discussed. Ideal way to check a rescue therapy would be probably a comparison with radical cystectomy. So, but this is a single arm study in which we can only evaluate gemcitabine docetaxel. So, my open question to anyone. So, anyone using gemcitabine docetaxel as a first line therapy, not a rescue therapy. I'll come to rescue therapy after this question. So, using first line therapy, anyone has used?
I have used it in 2 patients. I have used it in 2 patients relatively recently who had a small bladder capacity and significant irritative symptoms to begin with. Those who had overactive bladder and small bladder, because I knew that they will not tolerate BCG.
Okay.
And no point giving just 2 or 3 doses of BCG and then stopping there, and that is neither here nor there. Because after BCG, you have to wait for some time before you shift over to a chemotherapeutic agent. So why not begin with chemotherapeutic agent straight away? And I have done that recently in 2 patients.
So a short-term follow-up?
No, yes. One of the patients has become, actually, he had diffuse carcinoma in situ, and in the follow-up biopsies, his carcinoma in situ has disappeared. So he has a follow-up of about 6 months. At 3 months, his cytology was positive. At 6 months, his cytology became negative, and multiple biopsies also became negative. The second patient is still undergoing treatment, and follow-up is
Right. So I think in Indian scenario, we'll still have to wait for long-term results of these patients. So Dr. Kishore sir, options for rescue therapy, any non-inferior therapy to radical cystectomy in those patients who have failed BCG?
So this question itself has answer, because it is not substitute for radical cystectomy, that is for sure. There are a number of options available for rescue therapy, like one of those is like BCG with interferon. Another is thermotherapy of chemotherapy. Third is all these cytotoxic intravesical chemotherapies, and so on. But they will never substitute radical cystectomy, that is for sure. As far as gemcitabine and docetaxel doses are concerned, so normally we give gemcitabine 1 gram diluted in 50 ml of distilled water, and put it into the bladder, keep it for 90 minutes, then empty out the bladder, don't irrigate the bladder, then you inject, put docetaxel with 50 ml of normal saline and keep it for 120 minutes. Okay. This is a weekly cycle for 6 weeks, and depending on the progression and the further follow-up, we can repeat this cycle every monthly for 1 year to 2 years. That's what the standard of care.
So, and your preference out of these rescue therapies would be
intravesical chemotherapy in the form of gemcitabine and docetaxel will be preferred.
Right. So there are many trials going on according to the receptors also, and right now what we have is probably gem-dosi, and even we might move it to as a first-line therapy because of BCG shortage or probably side effects because of the present strain. These are the endpoints which they have considered: high-grade recurrence-free survival overall and in BCG unresponsive patients, progression-free survival, cystectomy-free survival, cancer-specific survival, and overall survival. So, Dr. Viraj, my question to you is, which endpoint is most important for you in these patients?
So, as with the BCG, we have to, for this rescue therapies, the recurrence of the disease will be the most important endpoint.
Okay. And is this percent, because we don't have actually any significant data of pointing out that if this is the response. So do you think this response with this percentage of recurrent-free survivals, is it significant?
The sample size is quite small for this particular trial, if you look after. So, but this is a quite promising data.
Okay. Sir, Amresh sir.
The definitions are very clear. If the patient fails to respond to BCG, then that is BCG unresponsive disease. But if the patient initially responds and then there is a recurrence, that is a BCG recurrent disease. And then there is a third group where the patient is not actually tolerating the side effects. And so So the management has to be different in the three situations. If a patient has initially responded and then has developed a recurrence, then we obviously have to see what is the grade of the recurrence and what is the stage of the recurrence. If the grade of the recurrence and the stage of the recurrence is low grade, then we have to treat that as low grade. But if it is high grade, then in that situation, the patient should be offered a cystectomy straight away. And there is data to show that if a patient is on BCG and needs cystectomy, if that cystectomy is done within 2 years of the diagnosis, then the long-term prognosis is better compared to those who have waited beyond 2 years and then have undergone the radical cystectomy.
Okay. So, coming back to this paper per se, so I think high-grade recurrence-free survival rates of 1 year of 60% and then 2 years and 5 years are given. And I tried to search the literature, and actually there were not many papers which tried to actually tell us that what response you can consider as significant benefit for the patient. So this was one paper by Ashish Kamath and his group, which actually tried to evaluate the different endpoints and whether what clinical trial design would be appropriate for these patients who are receiving rescue therapy. So for patients who have failed BCG, a single arm design would be good enough, and as logical, recurrence-free survival would probably be your primary endpoint. And they have given as 50% at 6 months and 30% in 12 months and 25% in 80 months as a cutoff or significant value. If you achieve that, then your GEM dossier has probably helped the patient. So I think in this study, the figures have crossed that. So maybe it's of benefit for Indian scenario. We'll have to wait. But the papers which we have in literature and this present website actually looks promising. So third paper, Amandeep very rightly pointed out, and this paper actually, the title initially was non-muscle invasive high-grade bladder cancer, T1 high-grade bladder cancer, but the patients which were evaluated were based on the squamous cell. So 188 patients of this, and the first thing again, out of 188 T1 high-grade probably squamous cell carcinoma, only 63 patients had TURBT, out of which 37 underwent RC, 8 upstage after TURB, and rest of the 29s either after initial or second TURB. And in BCG group also, if you're considering patient for the BCG, out of 151 patients, 109 patients didn't have TURB. So the finding of this paper was that pure squamous cell carcinoma or LVI were predictive of either progression or both recurrence and progressions. So, and if you consider BCG group, 60 patients of 140, because 3 had no data, had pure squamous cell carcinoma or LVI, and 61 patients underwent delayed RC after BCG treatment at a median time of 13 months, and on that pathology, only T1 was seen in 13%. So, we don't know actually out of how many of these had, because they didn't have re-TRB done, was initially only muscle invasive disease. So delayed RC, we know significant cancer-specific and overall mortality. Anand sir, do you always do a high-grade re-TR in high-grade T1?
Fundamentally, we need to understand something here. If it's a pure squamous cell carcinoma, I haven't ventured to give only BCG. But if it's a TCC with the squamous differentiation, that's a reasonable thing to do. Up to 40% is acceptable. But always definitely treat TURBT in high-grade T1. Right? If you're offering an ablative surgery as an option, right? You need to prove that.
So I'll come to that. This thing in RC group. So there were two things. If you consider overall group, 29% 5-year cancer-specific mortality versus 16% in BCG. However, 8 patients had muscle invasive disease on re-TR. So if you consider only confirmed T1, which consisted of only 13 patients in RC group. So 9% 4-year cancer-specific mortality versus 14%. So overall PT1 again in RC was seen in only 10% of the patients. So another limitation of this study was multifocality of the tumor or the completeness of resection was not mentioned. So Dr. Sujay, my question, what Dr. Anand was saying, T1 high-grade squamous. So you think of BCG in these patients, or we should directly go to?
You mean pure squamous?
Pure squamous. This was actually a heterogeneous group, so they have given BCG.
Yeah, I was a bit a lot of us, I was a bit, confused about the paper. And I'd like to go back on one point that just had mentioned. We have the benefit of uropathologists, so the initial histology is very important. And we get a lot of patients from outside our hospital. So we do the analysis of the slides that were available, RETU or BTS. If they're pure squamous, my preference would be to go for upfront radical cystectomy.
Right. So, and any other, if it is not pure squamous, then you would consider other factors to give the patient the option of radical cystectomy versus a conservative.
Yeah, I think one of the options mentioned that LVI, prostatic urethral involvement, if there is any, CIS.
So this was actually a bit confusing, because why are we altogether discussing only BCG in squamous cell carcinoma? The treatment is for this is cystectomy. So I actually am not convinced with this. We don't need to discuss this at all. So these were the risk models for the progression and recurrence. We all know about it, and then we can decide upon the treatment which needs to be offered. So pure squamous cell carcinoma, treatment of choice is radical cystectomy. This study concluded BCG was effective for T1 with non-pure squamous cell or non-LVI, but if these both are there, then you should offer radical cystectomy, which is the standard. So, Dr. Srikanth sir, do you think this paper adds anything?
Actually, in this situation, in clinical practice, it is going to be very difficult to offer radical cystectomy immediately. So, we have to have other options open to give them this.
No, I mean, if you have a squamous cell carcinoma, we have already, this paper I don't think adds anything to what practice we are doing. So if it is not squamous, then you can think of the two options.
If it is non-squamous, we can think of it. In squamous...
And if you are evaluating BCG versus radical cystectomy in a non-squamous, then probably the best way would be to do a radical randomized control trial.
In squamous, I really wonder whether we will rely on this paper and give them conservative treatment.
Yeah, so
all these years we have been doing cystectomy per se, right away.
Right, sir. So I think Bravo feasibility study was done, and initially they had planned 500 patients, but only 20 or 25 patients in each group. So it's not an easy study to do a randomized control study, and because probably this will also be an unethical thing. So we know that very high risk paper, and then you are not offering radical cystectomy to those patients. So it will be. So the
Can
next.
I say something, Puneet?
Yes, sir.
Actually, I think this paper has got no importance at all.
Yeah.
Because squamous cell carcinoma is a bad disease.
Yes.
And having pure squamous cell carcinoma in T1 is practically not seen.
Yeah.
And all these patients have to be treated with radical cystectomy plus minus chemo, and it's a very bad disease, very poor prognosis. The whole issue lies with the pathology, whether it is TCC with some squamous differentiation, when the patient has to be treated like TCC. But if it is pure squamous cell, then the patient has to be treated like squamous cell.
Absolutely. So the next paper now evaluates about the PDL1 expression and the BCG response in NMIBC. So in this paper, PDL1 expression was inversely associated with BCG unresponsiveness, but not BCG relapse. Means that if the PDL expression was more, so BCG response was supposed to be better, and it tells that PDL1 positive patients had a post-test probability of BCG responsiveness of 93%. So on multivariate regression, PT1, CIS, and PDL1 were associated with BCG responsiveness. So, Dr. Kishore sir, do you think, first, do you do a PDL1 check in your practice of high risk and very high risk group patients?
No, sir, because looking at his sensitivity, it's very low sensitive investigations to be carried out, because the sensitivity is only 20%, so we really don't do routinely.
Okay. And second thing, do you agree with this, according to the literature, that if a patient had PDL1 expression, then responsiveness was better?
See, when the test itself is low sensitivity, there are a lot of patients who had negative response, negative predictivity value. So I don't think so the test has any value as far as BCG response is concerned.
Okay. So I think when I went through the literature says exactly opposite. So it says that if there is a PDL1 expression, the immune mechanism gets exhausted because it binds on the tumor cell. PDL1 expression binds with the programmed death domain on the immune cells, they interact and then immune mechanism is exhausted, and so BCG doesn't have anything to act on. So what now we can do is to add a probably checkpoint immune inhibitor. That would be a more logical thing to do. So this paper actually tells about that, and it says that it's probably an escape mechanism for the tumor to express a PD-L1 expression, rather than helping the patient with the BCG. And with BCG, it increased the PD-L1 expression, right, but it increased the PD-L1 expression in the T cells, the tumor cells, but they are not effective. The anti-tumor effectivity goes away. So this is the second last paper. Very rare scenario.
Sir, I will request you to conclude in the next 1 minute.
Just give me 2 minutes. I just have 2-3 questions left, and I need to include my radiologist.
Okay.
So, okay. So, nodal mets in NMIBC. So, Dr. Umesh sir, I'll just directly come to you. We have already heard the paper. They have told that according to T stage. So T1 was a disease in which they had found out nodal mets, and actually the patients who had nodal met on radical cystectomy were upstage to T2 as well. And LVI was determinant of nodal mets. So do you think T stage is enough for assessing nodal mets?
No, I think we must take all other parameters to really assess before we take a decision.
Okay. Okay, so I'll not go into those risk parameters. We already all know about it. So let me come to Dr. Amresh sir and Dr. Viraj, your thoughts. In these patients, if you're suspecting nodal mets according to risk calculators, any particular number of lymph nodes removal predicting the response?
The studies have shown that if you carry out a more extended lymph node dissection, your positivity rate so therefore, your diagnostic and your prognosis categorization is better, but that does not actually lead to any significant survival advantage. That is what these studies have shown.
Okay, Dr. Viraj, you agree?
So, bladder cancer is one of the cancers where nodal dissection, excessive nodal dissection, will lead to improved survival and local control better. So, as per AUA guidelines, at least 12 nodes to be removed from the pelvic. But the standard lymph node dissection needs to be done if you have to do it.
So what has been suggested is that if you remove, especially in this patient, non-muscle invasive patient, more than 10 lymph nodes will probably help in lowering the risk of local pelvic recurrence, and more than 20 would probably help in cancer-specific survival. And actually extended lymph node dissection is good enough till the common iliac. You don't need to go all the way up to para-aortic or inframesenteric. That's actually superfluous. So it does not help you. Even if the patient is having a lymph node there, they will already be having it. So it's more important for staging purpose in this, and that this is a very rare group.
In addition to the numbers, the areas that have been cleared.
So just two more questions. The last subject I need to involve Dr. Archie and Dr. Karthik. So NMIBC lymph node, already we know less than 10%. We usually don't do any PET CT, and even CT scan we sometimes do after TURBT. So, Dr. Karthik, my question, this is my last slide. So, Dr. Karthik, my question to you is, currently we do as a uro-oncologist or urologist CT urography. So, are you happy with the predicting the nodal mets in those CT or MRI?
Okay, so if I'm looking at bladder wall, I'll just break it down to two parts. Bladder wall, MR is far better, far superior. And I use MR because I can easily stratify the depth of invasion.
So we will not talk about the bladder wall.
Yeah,
we
nodes,
all know about virides and all know about the MR.
Yeah,
Let's just keep it to nodal.
Yeah, but nodes, again, MR morphology is superior. Size is not so great. But just because you're covering a larger amount in CT, you're covering the entire abdomen and pelvis, you're able to stage higher nodes. But overall sensitivity and specificity is far lower as compared to...
And most of this has been studied in MIBC. We are talking about NMIBC.
Yeah,
so Dr. Archie, PET CT, is it any better?
Practically speaking, we never do a PET CT for non-muscle invasive. It's only for muscle invasive when we are looking at lymph nodes or something.
Yeah.
But here you don't expect lymph node metastasis. The incidence is very less. So practically speaking, we have never done PET CT in non-muscle invasive bladder cancer.
And even for MIBCs, if you extrapolate the data, do you find commonly the skip metastasis if nodal?
Very rare to find a skip metastasis.
So I think for NIBC, as of now, CT or MR probably is good enough. We don't need to do a PET CT. So I thank all my esteemed panelists for a good discussion, and thank you very much, organizers, for this.
Thank you.
Thank you, Dr. Puneet Ahluwalia, for this panel discussion. I also thank the chairpersons, Dr. Amit Ghosh, Dr. Devendra Pal, and Dr. Ajit Sawant for chairing the session. I'll request you, please, to continue chairing the sessions post-lunch. I have few important announcements before we break for lunch. There has been an instant photo session outside, so those who have posed for your photographs, please collect your photographs from the photographer on the desk kept outside. We are also capturing video feedbacks in the corridor outside the hall, so please be generous in giving your feedbacks. We are ready for both bouquets and brickbats to improve your experience in the next Wisdom of Ways. So I think the photograph is over. So I announce a lunch break for all of you to treat your impending hypoglycemia. Please be back by 1:30. We will begin our sessions sharp at 1:30. On silent mode. Can I have the music off, please? At the console. Yeah, thank you very much. An earnest request to all the presenters to please stick to the time slot allotted to you. As the first speaker after lunch, I invite Dr. Manoj Tumala, who is a consultant urologist and uro-oncologist at Chennai Urology and Robotics Institute, Chennai. Dr. Manoj will be presenting the first two abstracts. Over to you, Dr. Manoj. You have 6 minutes. At the end of 3 minutes, a small bell I will ring. Thank you.
So, good afternoon, everyone. Thank you for the opportunity. So, I'll be presenting two papers, which are done in AUA as a moderated poster. So, the first paper is how does the type of urinary diversion affect the health-related quality of life in the course of 4 years after radical cystectomy? It's a propensity score matched analysis. So we all know that radical cystectomy, we need to do a urinary diversion. Either ileal condo or the ONB or the orthorhombic neobladder is a treatment, a standard of care. However, it remains unclear how the patient's health-related quality of life is affected by the choice of diversion. So the objective of the study is to provide the insight in long term, that is 4 years follow-up, on these diversions. So it was assessed preoperatively and after surgery 3 months and post-operatively annually until a maximum follow-up of 48 months. Using 3 questionnaires. One is URTC QLQ30, which is a preoperative questionnaire. Then functional assessment questionnaire and QLQ BLM30. Both are post-operative questionnaires. So the variables age, ASA classification, the cardiovascular comorbidity were used for a propensity score matching, and potential predictors for decreased general quality of life was assessed using a multivariable logistic regression models. So these are the questionnaires which were used. So total 260 patients were included after matching, and the significant difference regarding preoperative QLC C30 symptoms and functional scores between IC and ONB, however, diminished during the post-operative course. So no significant difference based on bladder cancer specific FACT-BL and QLQ BLM assessment, including the body image. The cardiovascular comorbidity was an independent predictor of impaired quality of life post-operatively. So up to 4 years after RC, the study did not observe any significant difference between both type of diversions and cancer-specific subscores as well as generic quality of life. And consequently, the type of urinary diversion was not an independent predictor of a good general health-related quality of life. So even the literature remains inconclusive on the decision-making on whom to offer which type of diversion, which strongly relies on personal experience. And regarding long-term outcomes and long-term quality of life, the literature remains sparse as most studies only cover outcomes up to 2 years only. And this study shows that urinary diversion itself does not lead to increased or decreased quality of life, and that we should rather pay close attention to the comorbidities of what the patients have when we discuss radical cystectomy with our patients. Thank you. I'll go to the next abstract also. So the next abstract is the role of FDG PET in the staging of bladder cancer patients who are candidates for radical cystectomy. So till date, there are limited evidence available regarding the potential role of FDG PET in staging of bladder cancer and who are the candidates for radical cystectomy. So CT scan may not be accurate for diagnosing lymph node involvement. So the study is done whether FDG PET CT is superior to CT scan in primary staging of CA bladder or not. So 231 patients. The study was done from 2015 of January to September 2021. All patients underwent CT and FDG PET for primary staging of muscle invasive bladder cancer. It was operated by the same surgeon group and same lymph node template was done on all the patients. So the median age is 68 years, and 110 patients, that is 48% of patients, received the neoadjuvant chemotherapy, and post-radical cystectomy staging, pathological T0 and 31, TA or in situ is in 16, T1 and 6, T2 is 15%, T3 is 23, and T4 in 9% of patients. 167 patients, that is 72%, has no lymph node positivity. However, lymph node involvement was not detected in both imaging modality, that is both FDG PET-CT and contrast CT, in considerable proportion of patients, that is 6%. And those set of nodes which are in obturator fossa are missed in these patients. So this is the results where the CT scan and FDG PET are having almost same, but when you compare to the accuracy, the FDG PET is having slightly more accurate when compared to the CT scan. So the conclusion of the study is the FDG PET represents a very useful tool in staging of bladder cancer, and it has a superior to traditional imaging when CT scan. Though performances of the test were all suboptimal, they are not up to the mark. Therefore, other imaging or molecular tools are warranted to improve the diagnostic ability. So the clinical studies have shown that FDG PET-CT provides important additional staging information which influence the treatment in MIBC. That accounts to 18 to 68% of cases have a correct overstaging when compared to a conventional imaging techniques. And FDG PET-CT shows a similar accuracy to the MRI in end staging with faster whole body acquisition and a higher accuracy in M staging. So these are some of studies which were compared in the literature where FDG PET-CT has been the same low sensitivity but high specificity. And diuretic FDG PET-CT is highly sensitive and having high specificity and plays an important role in improved detection of primary tumor and loco-regional staging. And there are still inconclusive data regarding the role of FDG PET-CT in the evaluation results of neoadjuvant treatment. When to do a FDG PET-CT or whether to do it after second cycle or third cycle, still there is no data available. Thank you.
Thank you, Dr. Manoj Tumala. And for presenting the next two abstract, I invite Dr. Ajit Gujela, who's a senior fellow in uro-oncology at Tata Memorial Hospital, Mumbai.
Good afternoon, everyone. The first abstract is predictors of response following neoadjuvant cisplatin-based chemotherapy for muscle-invasive urothelial bladder cancer using molecular profile by ЇΕ et al. From Egypt. So neoadjuvant chemotherapy before radical cystectomy improves the 5-year survival by 5 to 10%. And however, many patients who receive this neoadjuvant chemotherapy don't get the survival benefit and only bear the burden of side effects. And we don't have any clinically applied reliable predictors for this to predict which patients will have a good response after neoadjuvant chemotherapy. So the aim of this study was to identify molecular predictors for good NAC response in a prospective study with a unified NAC regime. So the methods, so in this study, urothelial muscle-invasive bladder cancer, which is T2 to T4A, N0M0, who were fit for radical cystectomy and eligible for cisplatin-based neoadjuvant chemotherapy were selected. From the TORBT specimen, the mRNA expression levels of DNA damage repair genes, which are BRCA1 and ERCC1, and the CTR gene were measured. Then neoadjuvant chemotherapy was given, which was gemcitabine and cisplatin for at least 3 cycles, followed by response assessment in form of imaging, MRI, radical cystectomy done, and pathological response was assessed. Stage PT1 or lower were considered to be responders. So the results, total of 96 patients were included. Complete pathological response, which was defined as PTA1 or lower, was seen in approximately 38% patients. On bivariate analysis, the predictors for good response for neoadjuvant chemotherapy were increased RNA expression of the CTR gene, lower radiological stage preoperatively, and decreased expression of the DNA damage repair genes, which were BRCA1 and ERCC1. Whereas on multivariate analysis, a good response to NAC was predicted by increased RNA expression of CTR gene and decreased expression of BRCA1 and ERCC1. The conclusion, molecular profile, it plays a decisive role in identifying patients who will get benefit from preoperative neoadjuvant chemotherapy. The lower mRNA expression of genes of ERCC1 and BRCA1, in addition to higher expression of CTR gene, were good predictors for NAC. The cutoffs were also mentioned for each of these genes. So take-home messages from all the MIBC patients in whom the neoadjuvant chemotherapy is indicated and are cisplatin eligible. We need to identify and target the NAC responders one, and the molecular predictors for these were tried. This study aimed to identify these patients, the NAC responders. The second abstract is regarding the role of radical cystectomy and lymph node dissection in patients with non-metastatic clinically advanced lymph nodal bladder cancer, which is CN2N3. It is an analysis from National Cancer Database by Dr. Garg et al., San Antonio, Texas. So the role of radical cystectomy in non-metastatic clinically advanced lymph nodal bladder cancer, which is CN2N3, is controversial. The aim was to compare radical cystectomy versus systemic therapy alone in this cohort of patients. So the non-metastatic MIBC with advanced lymphadenopathy, which is CT2 to T4 with N2, disease and M0, were divided in 3 groups. Group A, which was definitive surgery with or without neoadjuvant or adjuvant therapy. Group B, systemic therapy alone. And Group C, no treatment. And the overall survival and predictors of survival were assessed. This was a retrospective study. So total of 3,928 patients, surgery plus or minus chemotherapy from neoadjuvant or adjuvant. The total number of patients were 1,366 with a median OS of 20 months. Group B, which was systemic therapy alone, the total number of patients were 2,372 with a median OS of 11.1 months. C, which was no treatment, the total number of patients were 190, median OS was 6.1 months. In this Kaplan-Meier curve, we see that in the radical cystectomy versus systemic therapy, the survival in radical cystectomy was significantly higher. The predictive factors for patients who were selected for radical cystectomy were male gender, age below 70 years, white race as compared to black race, and histology of micropapillary urothelial carcinoma. Radical cystectomy had significantly higher 5-year overall survival as compared to systemic therapy group, and radical cystectomy was identified as an independent predictor for overall survival. So conclusion, in clinically advanced non-metastatic lymph nodal disease, which is T2 to T4, N2 or N3 bladder tumor, radical cystectomy offers a superior survival benefit compared to systemic therapy alone. So if we look at the SEER data, the 5-year survival in the patients who undergo radical cystectomy in N2, N3 disease is up to 38%. So we can offer a better OS with radical cystectomy. However, it is associated with morbidity, which is around 40% patients, and mortality in 5 to 8% patients. Thank you.
Thank you, Dr. Ajit Kujela. I now invite our next speaker, Dr. Ritu Dave, who is a consultant medical oncologist at MOC Pune, to present the next 2 abstracts.
A very good afternoon. I'll be presenting the first abstract that's from PURE-01, which is of neoadjuvant pembrolizumab in biomarker unselected patients with muscle-invasive bladder cancer. So we all know that cisplatin-based neoadjuvant chemotherapy is the standard of care for muscle-invasive bladder cancer cases undergoing radical cystectomy. However, 50% of the patients are ineligible for cisplatin-based neoadjuvant chemotherapy. This study tested neoadjuvant pembrolizumab in patients with muscle-invasive bladder cancer following the successful use of immune checkpoint inhibitors in locally advanced and metastatic stages. So this was a single-arm phase 2 study, and patients with muscle-invasive bladder cancer, that is clinical stages T2 to T4 N0, a glomerular filtration rate of more than 20 ml per minute, ECOG performance status of 0 and 1, and predominant transitional cell carcinoma histology or other variants, but with more than 50% of transitional histology. Patients were given 3 doses of pembrolizumab 200 mg IV, and post the 3 cycles, they were evaluated with an MRI or an FDG PET-CT. Additional chemotherapy, neoadjuvant chemotherapy was given in case there were no responses seen. 143 patients received neoadjuvant pembrolizumab between Feb 2017 to 2020. 136 patients underwent radical cystectomy. 8 patients did not undergo due to either systemic progression or patient refusal. The endpoints of the study were primary endpoint being the pathological complete response rates, and the secondary endpoint being the event-free survival, recurrence-free survival, and overall survival. The results, so the pathological complete responses were seen in 42% of cases, and downstaging to non-muscle invasive bladder cancer was seen in 18% of the cases. We see that the 36-month recurrence-free survival and overall survival was around 95% in patients who had a pathological complete response, and the 36-month recurrence-free survival and overall survival was lowest in the nodal positive patients. In the intention to treat population, 36-month recurrence-free survival was 88% versus 72% for patients with CPS score more than 10% versus CPS score less than 10%. And the OS was also better in the patients with CPS score more than 10%. On multivariable regression analysis, the predictors of overall mortality were basically age and patients with nodal positivity. And the recurrence, the predictors of recurrence were again by T2 to T4, N0, and any patients with nodal positivity. These are the survival graphs that we see. So the best recurrence-free survival is seen with patients with pathological complete responses and YPT1A and carcinoma in situ N0 patients. Similar is the case of overall survival. Pembrolizumab followed by radical cystectomy confirms to be an effective treatment for patients with muscle-invasive bladder cancer, unselected for biomarkers and cisplatin eligibility. However, this trial needs to be seen in the light of the ongoing randomized phase 3 trials, which is the Genito-866 and 905. Moving on to the next abstract. So this is the updated analysis of Checkmate 274, which is adjuvant nivolumab in patients post-surgery with high-risk muscle-invasive urothelial carcinoma. So nivolumab was approved in August 2021 as adjuvant immunotherapy in patients with high-risk urothelial carcinoma after radical cystectomy. This was based on a minimum follow-up of 5.9 months. However, this abstract reports the DFS outcomes with a longer follow-up of minimum 11 months. This was a randomized double-blind phase 3 trial wherein patients with high-risk muscle-invasive urothelial carcinoma post-radical cystectomy who had received neoadjuvant cisplatin and were YPT2 to T4A or any node-positive patients went on to receive adjuvant nivolumab, or patients who had not received neoadjuvant cisplatin-based therapy and were PT3 or PT4 or nodal positive. Patients had to undergo. Patients were randomized within 120 days of the surgery and should have been disease-free within 4 weeks of study dosing. Patients were randomized into in 1:1 fashion between nivolumab 240 mg IV every 2 weeks and placebo, and the treatment was continued for a year. The primary endpoints were disease-free survival in the intention to treat population, and the secondary endpoints were non-urothelial tract recurrence-free survival, disease-specific survival, and overall survival. The exploratory endpoint was distant metastasis-free survival. As we can see in the table that the disease-free survival in the intention to treat population was, the median disease-free survival was 22 months, which is double of that seen in the placebo group. And in the PD-L1 positive group, it was not reached versus 8.4 in the placebo group. Similarly, the non-urothelial tract recurrence-free survival was 26 months in the intention to treat population of nivolumab arm versus 13.7 months in the placebo group. Was eventually not reached in the nivolumab arm as yet, and 10.8 months in the placebo group. The distance metastasis-free survival was 41 months in the nivo arm versus 29 months in the placebo arm. Nivo continued to show clinically meaningful improvement in disease-free survival versus placebo for patients with high-risk muscle-invasive urothelial carcinoma, both in intention to treat population and in patients with PD-L1 more than 1%. The non-urothelial tract recurrence-free survival and the distant metastasis-free survival were also improved with Nivo in both patient populations. Thank you.
Thank you, Dr. Ritu Dave. We now have a panel discussion on muscle-invasive bladder cancer. And as moderator, I would like to invite Dr. Hemant Өнгавkar, who is a senior consultant uro-oncologist and robotic surgeon at Max Nanavati Hospital, Mumbai. I also invite his panelists, Dr. Gagan Prakash, who is professor and head, the Department of Uro-Oncology at TMH, Mumbai. Dr. Swapnil Rane, who is a consultant pathologist at TMH, Mumbai. Dr. Mukund Andankar, who is a professor and head Department of Urology at Nair Hospital, Mumbai. Dr. Gagan Gautam, Director, Uro-Oncology and Robotic Surgery, Max Institute of Cancer Care, New Delhi. Dr. Ashwin Tamhankar, who is a consultant urological oncologist at Apollo Cancer Centre, Mumbai. Dr. Amit Joshi, professor and medical oncologist at Uro-Onco DMG Tata Memorial Hospital, Mumbai. Dr. C.V. Pete, who is a senior consultant medical oncologist at MOC Nashik. Dr. Sanjay Nabar, who is a senior urologist, head of the Department of Urology at Nanavati Max Super Speciality Hospital. And lastly, Dr. Vivek Anand, consultant radiation oncologist at Hinduja Hospital, Mumbai. I hand over the session to you, sir.
Well, good afternoon, everybody. There are 6 abstracts in the MIBC sector, and you'll be surprised that 4 of them are actually pertaining to medical oncology, something which was unheard of just 10 years ago. That time, medical oncologists used to be invitees to our conference. Today, we are the invitees, I think. So basically, I'm going to talk about the surgical or non-medical oncology abstracts first, because there are few, and then go on to the other ones. Okay. The first is the role of FDG PET in the staging of bladder cancer patients. So let's start with Gagan. Oh, now, how do I say that? White or black? Okay, white Gagan.
Okay, white Gagan.
Okay, and these are the results that were published, and the abstract showed that the PET CT was superior to conventional CT. However, both were suboptimal as far as the nodal staging of bladder cancer is concerned. So what is your standard practice?
So I think this abstract just proves what we have been doing all along for the last many years. I think we started using PET CT regularly prior to radical cystectomy almost 5 years back. And we've consistently found good results with that, with better correlation. But however, I would like to say that there is still an element of doubt regarding what SUV max should you take as the cutoff. Size criteria is pretty clear, 1 centimeter in the short axis diameter. But what is the size criteria? What is the SUV max criteria that you should use? And there are some studies which say if you use 2, the sensitivity is high, specificity goes down. If you take 4, it's better. But overall, I think it has become a standard practice in most of the centers which have access to a PET CT.
Yeah, but you're basically catering to a higher socioeconomic status patient. Let me, for the black Gagan, you deal with both kinds of patients. So In your general ward patients, what do you do? Do a CT or do a PET scan?
So first thing is that we would not do a FDG for all MIBC patients.
So which ones will you do them for?
The ones we would do, because if it is for the reason of not being able to use contrast, so essentially who's got a raised creatinine and we want to look for the staging workup. B, for a patient where there is something to suggest that this is a bulky disease, either in terms of clearly a T3 or T4 disease or clearly an N1 disease, where the possibility of picking up some distant mets in the bones or in the other distant sites is going to be there. Those are the patients where we would get an FDG in addition to a cross-sectional imaging or a CT scan.
So basically, for a T2N0, a patient who has a T2N0 disease on CT, you would not ask for an addition.
I wouldn't ask.
It's only for a high-risk patient where there's a higher chance of... Yes. Okay. Then you would do. Fine. What White Gagan brought out was very important, that, it is not just the PET CT, it is an integrated PET CT, which is very important, which integrates the SUV value and so many other nodal characteristics, and that would probably give you an edge over a routine CT scan. Anybody doing MRI for staging? Nobody? Good.
I think the radiation oncologists like to use the MRI a lot at the time of deciding regarding bladder preservation.
That's for much more for planning.
Exactly.
If we find something, that is after PET, if you say if there is a node, extravesical disease, then we would like to use, because the delineation would be easier so that precision will be better.
See, whenever we ask for any investigation, basically, we do that investigation if it is likely to change your line of management, change your staging or something. So do you think PET CT has a greater ability to change your line of management?
I would think so, yes.
Well, there is a big paper and more than 700 patients database, and where they said that in addition to the nodal staging, they found distant metastasis in a significant number of patients, 9% of patients. So the treatment philosophy changed from curative to palliative, and that's probably one advantage that PET CT has over a routine CT scan. And nearly in 18% of patients, there was a change in treatment. So I think we should accept that whenever it is possible, we should take PET CT as the standard of care. I think on a meta-analysis,
Dr.
let's say
Hemant,
that.
was this still this choline PET or a FDG PET?
FDG PET.
Because choline PET is supposed to be better than...
FDG PET is one which is very routinely
through
used.
Bladder. It can give...
No, this paper is about FDG PET.
So are we saying that a patient who's had a cross-sectional imaging of CT, including chest, abdomen, and pelvis, where there is no distant disease, we would still want to do an FDG for all those muscle-invasive?
In high risk, yes, probably I would, because these patients had a CT staging and then a PET staging. Well, coming to the next abstract, role of radical cystectomy and lymph node dissection in patients with non-metastatic, clinically advanced, that is N2, N3 nodal disease. This is the analysis from National Cancer Database. And by N2, N3, I mean metastasis in a single lymph node more than 2 centimeters, but less than 5 centimeters. And M3 is more than 5 centimeters. So we are really dealing with a large nodal disease volume. And the results showed that the median OS was 20 versus 11.1 months when the surgery was added. And 5-year OS also was significantly better when surgery was done as part of the treatment protocol. What they also found was that RC was independent predictor of survival. That was the only independent predictor of survival. So they said that RC, with or without NACT, offers superior survival as compared to systemic therapy alone. Ashwin, what is your take on that? Do you agree with the author's conclusion? See, remember that this is a registry data.
Yeah, so it's a retrospective audit. But I will probably say this is just the reinforcement of Will Roger. It's the reinforcement of a stage migration, which we always knew since beginning.
And a bias.
Yeah. And most importantly, sir, N2, N3, the comparison arm is only the systemic therapy and not the surgery. And we are not labeling them as metastatic. M1A is a different definition than N2 and N3 in a standard setup.
Secondly, what I find here is that only about 1,300 patients or so had surgery, while more than 2,500 did not have surgery.
Did not have.
So if they all had chemotherapy before, then do you really expect so many patients not having surgery? So, yeah. Obviously bias, I said no, obviously.
So they say
obvious.
that less than 70 will have a better survival.
But one thing you must remember, and which Amit pointed out to me just now, is most of the NACT trials have excluded patients with lymph node metastasis. So maybe here the response is not as good in patients who have lymph node metastasis. Is that true, Amit?
And sir, other point is also true that N2, N3 doesn't exclude the patient from the definitive treatment. At least in fitter group of the patient, give neoadjuvant chemotherapy, see the response, and those are responding should be that what we practice. So I think it's a reinforcement that still 25, if you see the curve, I think 4-year survival is reaching around 35-40%.
Yes.
It's a decent data.
Yeah. But what would you treat your patients with upfront? If you do with NACT or upfront surgery?
NACT, definitely yes, if there is a node.
If it's a resectable 2-centimeter node,
Still NACT,
even then,
100%.
Well, there is no evidence because the patients with lymph node positive were not included at all in the NAC trials.
Yes, sir. But it's a definition of locally advanced, so I will err on a side of systemic therapy earlier.
Majority of the patients, as I said, are NACT followed by response assessment. So what do you expect as Dr. Pete?
So roughly around 60 to 70% patients do well.
Would respond. And respond adequately to go on to local treatment,
yes.
Right? So how do you decide the further line of treatment? Patient has received NACT. How would you define the further line of treatment?
These patients I would always refer back to my surgeon for surgery. In fact, while reading this abstract, I was surprised that some patients did not undergo surgery. That is what actually surprised me.
Good. We are in safe hands here.
And around 200 patients has not received any therapy in that paper.
Yeah,
Around
those,
195%.
Those are probably patients who are too sick for any kind of treatment.
The other thing is that for the local treatment, we in Tata, we do the radiotherapy also. So some N2, N3 patient receives the, after NACT, they go for a definitive CTRT.
So, well, I think if majority of us would treat these patients with NACT and then decide.
And there is a thin line of demarcation between clinical versus pathological N2, N3 because it is difficult to identify whether there are only 2 nodes or 5 nodes.
This is clinical.
Yeah. So that is also another
more
difference.
significant than just pathology.
Clinical N2 may turn out to be N3 on the pathology.
No, Dr. Pete just said that he'll send the patients to the surgeon. I saw Vivek Kannan looking the other way. How do you decide whether surgery and radiation therapy?
I'll definitely do a PET and see how they've responded. If they've responded well, that means it shows us that it has responded to chemo, so it's going to respond to radiation too. If there is a definitive uptake, I think the dose required to treat those nodes will be a problem. More than the primary, I think.
So
the
no
node
response, no radiation.
I would refer to surgeon.
So for surgeons, we have response, no response, we can still operate. Yeah? Okay. So your point is well taken that whenever there's a good response, you can consider as an additional consolidation treatment, radiation therapy.
So is it not, in this paper, it's a retrospective study?
Yes.
This might reflect real world practice in N2, N3 patients, probably. We are saying that so many patients were given systemic therapy and not operated. But those many patients after systemic therapy may not have a good ECOG, or they might, very few would have refused surgery.
Yeah,
so I guess this is a retrospective data. As Amit was probably saying, I think this is reflecting real world data. Even it happens many times in our case.
Yes. But still, the numbers are too large. 2,500 patients nearly not having surgery that is, out of 4,000.
Maybe, but I still feel India also might have similar things.
Yeah. Now, what is the survival that you normally expect?
If I can just make a quick comment about what Sir said.
Practicing
in a different setup talks about those patients who are say willing to undergo RCIC. In my practice, is very less unless they are counseled very well.
Fine. Now, what duration of survival do you really expect in these patients, Gagan?
So I think what the data in this paper, what we have seen around, I think 30-35% after 3 to 4 years.
And does the extent of lymphadenectomy make a difference, Gagan?
Not really sure, sir. So all we know is that once there's an N2, N3 disease, the outcomes are really poor, whatever you do, despite all combination
You're
therapies.
right, but if you look at the retrospective data, there is data where even for N2 disease, there is a significant survival that is reported with an extended lymphadenectomy. And this has happened still from the time of Donald Skinner, when they didn't even have any adjuvant treatment to offer. So I think we should be doing our best, probably do an extended lymphadenectomy.
So, sir, I mean, doing an extended lymph node dissection when we are doing a cystectomy is I think across all stages and across all end stages. Probably NMIBC is the only scenario where we would not want to do it.
Having said that, the only randomized trial that has reported extended versus limited lymphadenectomy has not shown an advantage in survival. But there was a huge ask from that trial. They wanted to show a 15% survival difference in 5 years, which was very difficult to achieve. So yeah, for somebody who has had obvious nodal disease, doing an extended lymphadenectomy after chemotherapy would be the standard practice for all of us. I agree.
But I think the reported survival is also a bit low because you have chosen patients who are good risk. Then you have chosen patients who have responded to neoadjuvant, and yet after doing a surgery, the survivals are good. Now, the third, let us be very quick about this. Now, how does the type of urinary diversion affect quality of life? Now, we all know that initially the workhorse was ileal conduit, and in recent years, the standard of care has been orthotopic neobladder whenever it is possible, the patient is suitable. And the present study surprisingly showed that there was no difference in survival whether you used a general quality of life questionnaire or a bladder-specific FACT-B questionnaire. So, does that come as a surprise to you? Yeah.
No, it doesn't. Because I think that and as has been proven in this abstract itself, it was the cardiovascular morbidity which impacted the quality of life rather than this. And we have also seen that in patients who, after radical cystectomy, who are, the quality of life is primarily determined by two things. One is the cancer coming back? Secondly, what are the complications? And what are is the patient having any long-term complications which require him or her to come to the hospital again and again? Whatever diversion one has is something which patients get used to over a period of time.
Dr. Nabar, do you want to have something on that?
I think there are, what I feel is that many times is orthoptic bladder patients, they need self-catheterization to empty their bladder. So the chances of infection along with that, which is not there in ileal conduit. Secondly, I have come across a very interesting case recently where ileal conduit was made and the intestines, the ileum went down and it got stuck to the raw area behind the symphysis pubis, giving a very, very bad degree of intestinal obstruction. The patient is still suffering since last almost 2 years. So whether I want to ask from the other panelists whether such a complication in case of orthoptic bladder if we do.
Yes, see, intestinal obstruction can happen after any major intra-abdominal surgery. And so given basically, I think if you want to counsel your patient for a neobladder or for a urinary diversion, what would you tell him or her? Any, black or white?
Sir, I think this is an aspect for which it is extremely important that one should audit their own centers and say it. So a center which is, say, doing 90% of their diversions as conduits and 10% a neobladder, and quoting a paper which says that the quality of life is, either superior in one or the same, may not be the right thing to be done. And we all know that neobladder, both have their share of complications, but neobladder does need a learning curve and does need to reach a certain level.
You need to be really very aggressive in the post-operative period.
Yes.
But when you have a patient who's suitable for a neobladder,
yes, sir.
Do you leave the choice to the patient also after explaining all the problems and the benefits of both?
Yes, of course.
Does that really happen?
So it would depend on the disease-related factors. It will depend on the kind of support that the patient has in the post-operative period, and of course it will depend on what is the complications of our center that we are dealing with. And when we are talking about quality of life things, it could start from the immediate perioperative period. Whereas most papers would look at longer-term quality of life issues, but we wouldn't want a situation where the complication itself is leading for a longer stay.
But what is surprising is if you see the quality of life in the first 2 years, the quality of life after neobladder is better. But if you go longer term, then there's no difference, like 4 years. Is it because of the acceptance?
It is probably.
Probably because of the acceptance.
Or because some of them are getting long-term problems because of the neobladder.
But if you look at the...
Acceptance is more likely the correct answer though.
If you look at the literature, again, neobladder scores or ileal conduit in most of the physical parameters. But yes, it's a question of acceptance. We should be offering that. And I don't think just because one study says that there is no difference, we should be saying that, oh, I can do ileal conduit and still that's good enough for the patient. No. I think it has to be a combined decision. And this is going to be very important because, there are not every center that does orthotopic neobladder. There are many centers in Mumbai, outside, in Delhi, I'm sure, where they don't do an orthotopic neobladder. Now, does this study show them or tell them or give them permission to do an ileal conduit across the board in all patients? That's something that we need to think about. Now, the 3 medical oncology abstracts. How much time do I have? Excuse me. 17. 4 minutes, how can that be?
Medical oncology gets only 4 minutes?
No. You'll have to give me 5 minutes more. Okay. 5 minutes more, huh? Yeah. So there are 3 papers. Basically, one looking at neoadjuvant pembrolizumab, one looking at adjuvant nivolumab, and predictors of response. So let's be quick about this. In your practice, do you use neoadjuvant chemotherapy as a routine?
In cisplatin fit patient, definitely we consider for a neoadjuvant chemotherapy. Yeah. T2 onwards.
And of course, we know that there's a strong evidence with 16% reduction in the mortality rate, etc. Now, what percentage of patients who are eligible for neoadjuvant therapy do you actually accept your neoadjuvant therapy?
Sorry, these around 30 to 40%. So 60 to 70% is not fit for cisplatin.
And this is in the US, it is about 19%. So a majority of patients don't accept. But why is that? What are your concerns as a surgeon, Gagan?
I don't see so that neoadjuvant chemotherapy would lead to a higher surgical complication or morbidity. But there is a set of patients, particularly the kind of patients that we see, where the disease is so bulky that we would prefer to have it out early in terms of presenting with either hematuria or hydronephrosis and the whole cycle of trying to do a nephrostomy and DJ stent and such things.
Are you worried about the complications?
No.
Are you worried about the patient may not respond and will actually progress?
So that is, of course, a worry in some patients, and I think that is what one of the papers is trying to see, to better select patients who may or may not respond to neoadjuvant.
So we need to have predictors, right? So
we need to
come to Dr. Swapnil Rani. The pathologist, I had not asked him a single question, but tell me.
I was wondering when that is.
Where it will come to you. Yes. So are there any predictors, pathological, that some kind of subtypes which would respond to chemotherapy?
Right. So usually the conventional cancers, the conventional urological cancers respond very well, much better than the squamous ones, as pure squamous as well as the pure adenocarcinomas. So histologically, the conventional histological features, that is one of the things.
Urothelial cancers, are there any subtypes, say basal subtype, luminal subtype, any markers that you would report on?
So currently we are not doing any such markers that we are reporting on. There are obviously work happening in the genomic side, wherein we try to predict protein expression as well as mRNAs. But all of these are still in the discovery stages. That's like one of these abstract reports on a better response to the lower level of expression of BRCA and ERCC gene, etc. There is a lot of morphological correlates also sometimes to these. So the presence of lymphoepithelial type carcinomas predicts the presence of MSI high tumors. So those patients at times might respond better to chemotherapy.
Yeah. So it is not only the pathology, but also the genetic factors and the molecular factors which would probably define the responders in future. Now, coming to the 2 trials where we've used pembrolizumab in a neoadjuvant therapy and nivolumab as an adjuvant treatment. Now, both have shown significant survival benefit of DFS, not OS. And if the patient today is suitable for cisplatin-based chemotherapy, then would you still give these patients cisplatin chemotherapy, or would you put them on, say, neoadjuvant pembrolizumab or adjuvant nivolumab?
I think till the data of phase 3 data is not available, patient is fit for cisplatin, I will consider neoadjuvant cisplatin-based chemotherapy, surgery, followed by discussion for a adjuvant nivolumab. Till the time, still in cisplatin ineligible patient, definitely with this pure one and blast data, we can have a discussion regarding the neoadjuvant immunotherapy in cisplatin ineligible patients.
Yeah, cisplatin ineligible patients, I think the only option that remains right now is immunotherapy, where Pembro as and Neo as adjuvant. But if you have used neoadjuvant chemotherapy, then post-op you will not give adjuvant chemotherapy again? Why adjuvant nivolumab?
Generally, we can conclude the 4 cycle of neoadjuvant chemotherapy. In Tata, we give 3 cycles followed by 1, but we can conclude, if we are giving a DDMVAC, then we can complete whole 6 cycle of DDMVAC, followed by surgery, followed by adjuvant.
I think it has been shown that if you use neoadjuvant chemotherapy is unlikely to...
In somebody who has not received neoadjuvant chemotherapy, surgery has been done, would you prefer cisplatin or would you prefer nivolumab?
I was discussing with Randeep. So if the patient is fit for cisplatin in an adjuvant setting, I think still I will like to go ahead with adjuvant cisplatin rather than the nivolumab.
I think the question cannot be answered till we have head-to-head comparisons. Both the chemotherapy as well as immunotherapy trials are against placebo. But secondly, we have some OS data available for adjuvant chemo. We don't have any OS data available for adjuvant immunotherapy. So are we really justified in changing the the practice? That is our last question, which I want just everybody to just say, do you change your practice based on this? Or do you think in near future it is likely to change?
Yes, in near future it will change, not right now.
Because the toxicity is less, the eligibility is more, the cost, of course. I mean, for the patient it is bad, for the doctor sometimes it is good, that's different. Yeah. So, anybody who will change your practice now for cisplatin eligible patients? No. So I think, but the time will come certainly for immuno-oncology, I'm sure. And well, thank you very much, panelists, for this discussion. Thank you so much.
Thank you, sir.
Thank you, Dr. Tóngaonkar and the panelists for this excellent panel discussion. We move on to advanced bladder cancer. And for the next set of abstracts presentations, I invite Dr. Randeep Singh, who will present the next 2 abstracts. Dr. Randeep Singh is the Director of Medical Oncology at Narayan Health Centre, Gurgaon.
हम लोग का नंबर ही नहीं है.
Can I have my slides? Yes, thank you. So, thank you UCF and MOC. I will be presenting 2 abstracts. Both of them are actually interesting abstracts. The first one is TROPHY-01, which is based on sacituzumab govitecan. For simplicity, I will call it as SG. This is famously in medical oncology not known as Sudeep Gupta, it is SG, in combination with Pembro, for metastatic urothelial cancer patients who have progressed on platinum. So this is basically a second-line trial setting. And on the right-hand side is Atlantis, which is actually a maintenance in the first-line setting after the patient has received chemotherapy. So this is a phase 2 trial. TROPHY-01 is a registration trial, and based on this trial, SG got approval on cohort 1. In April 21, SG got an accelerated approval by FDA for all patients who have progressed on checkpoint inhibitors and platinum-based chemotherapy. Here we present the results of cohort 3, where the patients who have progressed after platinum-based therapy have been subjected to a combination of SG plus Pembro. SG for the surgical colleagues is an antibody drug conjugate, something similar like a TDM1 used in breast cancer. It has a payload, which is MMAE, and pembrolizumab is the immune checkpoint inhibitor. The primary endpoint was ORR, objective response rate.
The baseline characteristic of cohort 3, if you concentrate on the left-hand side red table, most of them is third line, that is 2 prior therapies have been received, and there is a good amount of liver as well as visceral metastasis in 68% of patients. So these are heavily pretreated and a high tumor burden patients. The response rates, which was the primary endpoint, is total cohort is of 41 patients. The objective response rate is around 34%. And the clinical benefit rate, which is CR/PR and stable disease for 6 months, is 61%, which is encouraging. The median follow-up is only 5.8 months. And the median PFS, median OS is not reached, and the median PFS is 5.5 months. The combination is toxic. Grade 3 for adverse events is 60%. Discontinuation rates is 39%. And the majority of the side effects are myelosuppression and GI side effects, along with febrile neutropenia. These are the investigators' conclusion. Combination of SG plus Pembro, ORR of 34% is encouraging, and that was the primary endpoint of this trial dataset. At a median follow-up of 5.8 months, median duration of response and median OS has not been achieved, and thus it's a quite short follow-up, and safety profile was manageable. I have not given my conclusions of this because I will be moderating this session, so I'm not concluding from my perspective. The second data set is Atlantis. This is a trial platform where the maintenance regimens have been tried after patients have been subjected to a platinum-based chemotherapy. And this is a biomarker-based Atlantis data set where a DDR positive patient goes on rucaparib, an AR biomarker positive, which we don't check, usually goes on enzalutamide, and then all other biomarker negative goes on cabozantinib. Here we present in this abstract the results of rucaparib compared to placebo in DRD positive patients. The primary endpoint is PFS. And to define the DRD, as per this abstract, is patients who have more than 10% of LOH, which is loss of heterozygosity, somatic alteration in HRR gene mutations, which are BRCA, ATM, PALB2, CHEK2, and out of this data set, 40 patients have been taken who were DRD mutation positive, and out of these, half of them 10% LOH, having a high LOH, and another were DRD positive. Now when we see the PFS and OS, the median PFS, this is in weeks, not in months, 35 weeks versus 15 weeks, is the PFS of rucaparib compared to placebo, and overall survival is not reached in rucaparib versus placebo is 72 weeks. To conclude, the Atlantis investigators concluded that this is a phase 2 trial. In this randomized phase 2 trial, patients with metastatic urothelial cancers pre-screened for DRD biomarker and then subjected to maintenance rucaparib after chemotherapy, platinum-based doublet chemotherapy. The median PFS is 35 weeks versus 15 weeks, and it is only based on 40 patients, but yes, definitely encouraging with a hazard ratio of 0.53. Safety profile was well tolerable, and they concluded that results further support the study of PARP inhibitor therapy in biomarker selected patients with urothelial cancer, either as a maintenance or in other combinations. Thank you.
Thank you, Dr. Randeep Singh. I now call upon Dr. Lavin Wilson, who is a consultant medical oncologist at SNBT Ghoti, to present the next 2 abstracts.
Good afternoon, everyone. I would like to thank the chairpersons and the organizers for this opportunity. The first abstract I'm going to talk about is a BAYU trial. It is a phase 2 randomized double-blind study of durvalumab in combination with olaparib for the first-line treatment of platinum-ineligible patients with unresectable stage 4 urothelial carcinoma. The prognosis of patients with advanced urothelial carcinoma remains poor, particularly those who are not able to tolerate platinum-based chemotherapy. Defects in DNA damage repair are common in urothelial carcinoma and render tumor cells sensitive to PARP inhibition. HRR gene mutations and PARP inhibition may enhance the anti-tumor response of the immune checkpoint inhibitors. This was the rationale for this study. The method of the study, the key inclusion criteria was over 18 years of age, unresectable stage 4 urothelial cancer, treatment naive patients, and those are ineligible to platinum-based chemotherapy, both cisplatin and carboplatin, and with a ECOG performance status of 0 to 2. They were randomized into durvalumab plus olaparib arm that had 1,500 mg 4-weekly dose of durvalumab and olaparib as a 300 mg BD dose, and the comparative arm was durvalumab plus placebo. It was pre-decided stratification was done based on HRR mutation and Bajorian risk index. The primary endpoint of the study was progression-free survival, and the secondary endpoints were progression-free survival in the HRR mutation subgroup, the overall survival, the duration of response, the ORR, and also the safety and the tolerability. Coming to the results, in the Kaplan-Meier survival curve showed here, there were total about 150 patients in the durvalumab plus olaparib arm. There was about 78 patients that showed a median PFS of 4.2 months, and in the durvalumab plus placebo arm, there was 76 patients that showed a median PFS of 3.5 months. It was non-significant with a p-value of 0.78. But in the prospectively planned subgroup analysis of the HRR mutated subgroup, the median PFS was 5.8 months with adding olaparib, while in the placebo arm with durvalumab, it was 1.8 months. And with a hazard ratio of 0.18, and it was a significant finding. Coming to the, you can see in the right side of the screen that in the forest plot, that most benefit was seen in patients having HRR mutations and along with a good performance score. In conclusion, the BIO study did not meet its primary endpoint, that is of increase in PFS in the durvalumab plus olaparib arm. However, the results of pre-planned secondary analysis suggest a potential role of PARP inhibition in urothelial carcinoma patients harboring HRR mutations. It is more of a hypothesis-generating study for examining the role of PARP inhibition in HRR-mutated urothelial cancer patients who are platinum ineligible, and it needs further larger studies. But it gives us an idea that we can't blanketly add olaparib to all the patients, and only a subgroup of properly selected patients will show some benefit. Coming to the second study, it is a study, it was presented as a poster, a study of RC48C014, preliminary results of RC48 ADC combined with toripalimab in patients with locally advanced or metastatic urothelial carcinoma. RC48 ADC is a novel humanized anti-HER2 antibody drug conjugate which showed promising data in HER2-positive and even surprisingly negative patients with metastatic urothelial carcinoma. Toripalimab is an anti-PD-1 antibody with a durable anti-tumor effect of metastatic urothelial carcinoma. The rationale for the study was that the combination may have a synergistic anti-tumor effect. The method of the study, the main aim of the study was to see the safety and tolerable recommended dose for the RC48 and ADC. The key inclusion criteria was unresectable, locally advanced or metastatic urothelial cancer, who even treatment naive and already pre-treated patients were included with a performance status of 0 to 1. Since it was a dose finding study, it was a 3+3 dose escalation study that had one arm having RC48 ADC with a dose of 1.5 mg per meter square, and the other had 2 mg per meter square, along with toripalimab as a dose of 3 mg per kg. And the endpoint was progression or unacceptable toxicity. The secondary endpoints were objective response rate and progression-free survival, OS, and pharmacokinetics. With the primary, as I told before, it was safety and recommended dose for RC48. So the results on as of cutoff of September 23, 2021, there were total 32 patients with metastatic urothelial carcinoma enrolled till August 2020. 53 of the patients with were systemic treatment naive in locally advanced or metastatic setting, while HER2 expression was positive in 19% of the patient, with PD-L1 CPS more than 1 in 56%. Confirmed investigator-assessed objective response rate was 75%, including 15% complete response, and disease control rate was 95%. Objective response for first-line previously untreated was 80%, while for liver mets patient it was 75%. The objective response rate was 100% for patients with HER2 3+, while it was 77.8 for HER2 2+, and 66.7 for HER2 1+, while even the HER2 negative had 50% of response. ORR for 97.1% in patients with PD-L1 with CPS more than 1, and 50% with CPS less than 1. Coming to the safety, there was no dose-limiting toxicity was reported, and recommended dose was for RC48 ADC was 2 mg per kg. Most common side effect was asthenia and anorexia, while immune-related side effect was interstitial lung disease. The conclusion by Dr. Zhu himself after the presentation was RC48 ADC in combination with toripalimab demonstrated promising efficacy, that is ORR of 75% in all patients, and the assessment of RC48 plus toripalimab versus platinum-based chemotherapy in treatment-naive metastatic urothelial carcinoma is being planned. Thank you.
Thank you, Dr. Lavin Wilson. I quickly call upon Dr. Makaran Randave, who is a consultant medical oncologist at MHC Nagpur, to present the last two abstracts before we move to the panel discussion. Please honor the time schedule which is allotted to you.
Good afternoon, everyone. So my first abstract is a standard of care, first-line avelumab maintenance for advanced urothelial carcinoma. It's a updated analysis, long-term follow-up results from the Javelin Bladder 100 trial. So it's a phase 3 Javelin Bladder 100 trial showed significantly longer OS with avelumab plus best supportive care versus best supportive care alone in patients with advanced urothelial carcinoma that had not progressed with first-line platinum-containing chemotherapy. Avelumab first-line maintenance is now considered standard of care in treatment guidelines. Trial data with 2 years follow-up in all patients, additional 19 months from the initial analysis is reported. So method, patient with unresectable locally advanced or metastatic urothelial carcinoma without disease progression with 4 to 6 cycles of first-line gemcitabine plus cisplatin or carboplatin were randomized with 1:1 to receive avelumab plus best supportive care or best supportive care alone. The primary endpoint was overall survival, assessed from randomization in all patients and in patients with PD-L1 positive tumors. It was done on Ventana SP263 assay. The secondary endpoints include PFS and safety. So result-wise, 700 patients were randomized, 350 per arm. 358 patients, that is 51.1%, had PD-L1 positive tumors with extended follow-up, that is median of 38 months in both arms for all patients. Data cutoff of June 4, 2021. OS remained significantly longer in avelumab plus best supportive care versus best supportive care alone arm in all randomized patients and in patients with PD-L1 positive tumors. And OS benefit was observed across all pre-specified subgroups. The PFS by investigator was longer with avelumab plus best supportive care versus best supportive care alone in all randomized patients and in patients with PD-L1 positive tumors. In the avelumab plus best supportive care and best supportive care alone arms respectively, 185, that is 52.9% versus 252, that is 72% patients received subsequent anti-cancer drug therapy, including a PD-L1 inhibitor in around 11.4% versus 53.1% patients. Long-term safety was consistent with the previous avelumab monotherapy studies with no new safety signals. So this slide shows the hazard median OS in both all patients and in PD-L1 positive tumors. It was significantly, hazard ratio is a significant of 0.76 and in PD-L1 positive tumors of 0.69 and median PFS of 5.5 versus 2.1 in all patients versus PD-L1 positive 7.5 versus 2.8 and hazard ratio for PFS was also very significant. To conclude, long-term follow-up from the Javelin Bladder 100 trial continues to show prolonged overall survival with avelumab plus best supportive care versus best supportive care alone. These results further support the standard of care role for avelumab as first-line maintenance in patients with advanced urothelial carcinoma that has not progressed with first-line platinum-containing chemotherapy. So coming to the next abstract, it's a circulating tumor DNA is a strong predictor in patients treated with systemic therapy for urothelial carcinoma. In patients with urothelial carcinoma, management decisions are mainly based on clinico-pathological characteristics. However, there is need for more accurate prognostic and predictive tools. So previous studies have suggested that circulating tumor DNA can reflect the tumor burden and guide potential therapeutic strategies in several malignancies. These studies aim to summarize the available data and identify the prognostic value of circulating DNA in patients treated with systemic therapy for urothelial carcinoma. The Medline and the MBASE databases were searched in October 2021 according to the PRISMA statement. The studies were deemed eligible if they reported on oncological outcomes in patients treated with systemic therapy for urothelial carcinoma based on their circulating DNA baseline profile, that is before the start of the systemic therapy and or changes over the course of the therapy. The primary outcomes of interest were DFS and the OS. Forest plots were used to assess hazard ratios and 95% confidence intervals to describe the relationships between the circulating DNA and the survival outcomes. So 5 studies out of all the studies screened met the eligibility criteria. Among the included studies, patient populations were highly heterogeneous, including some treated with immunotherapy and others with chemotherapy within either the neoadjuvant, adjuvant or metastatic settings. We found a strong association between high baseline circulating levels and worse DFS, hazard ratio of 3.53, 95% confidence interval of 2.5 to 4.84, and overall survival hazard ratio of 2.99 in urothelial carcinoma patients treated with systemic therapy. The patient with decreasing circulating DNA level in response to immunotherapy had better DFS and OS compared to their counterparts who did not exhibit a decline in a circulating DNA. So this forest plot shows the baseline circulating DNA. It's favoring circulating DNA negative thing, both in DFS and the OS, that is baseline DNA if it's high, and changes in DNA, if it is a positive for that, then it favors the decrease circulating DNA. It shows a positive level for the DFS and the OS. To conclude, our analysis indicates that increased levels of circulating DNA are associated with worse survival outcomes in patients treated with systemic therapy for urothelial carcinoma. Urothelial carcinoma patients who exhibit a decrease in circulating DNA levels during the course of systemic therapy had better survival outcomes compared to those with stable or increasing circulating DNA levels, while promising the role of circulating DNA as an adjunct to establish histopathologic characteristics for clinical decision making requires further validation as a part of biomarker-phased approach. Thank you.
Thank you, Dr. Makarand Randive. And now to sum up all these extracts, we have a panel discussion, and I would like to call upon Dr. Randeep Singh once again as a moderator of this panel discussion. He's the Director of Medical Oncology at Narayan Health, Gurgaon. May I invite the panelists, Dr. Sevanti Lime, who is a Consultant Medical Oncologist at Sir H.N. Reliance Hospital, Mumbai. Dr. Prakash Devde, who is a Consultant Medical Oncologist at MOC, Aurangabad. Dr. Nilesh Chordia, who is Director and Senior Consultant Surgical Oncologist at Surgical Super Speciality, Mumbai. Dr. Chirag Desai, who is a Director and Consultant Medical Oncologist at HOC Vedanta, Ahmedabad. Dr. Nagaraj H., who is a Senior Consultant Radiation Oncologist at Max Nanavati Hospital, Mumbai. Dr. Preetham Kalaskar, who is a Consultant Medical Oncologist, MOC, Thane. Dr. Amandeep Arora, Assistant Professor in Uro-Oncology at Tata Memorial Hospital, Mumbai. Dr. Kumar Prabhash is a Professor and Head of the Department of Medical Oncology at Tata Memorial Hospital, Mumbai. Dr. C.V. Pete, who is a Senior Consultant Medical Oncologist at MOC, Nashik. I hand over the session to you, Dr. Singh.
Okay, and please remind me 5 minutes before when the time is about to end.
I'll do that.
As we know, we have 25 minutes. I would request all the panelists to be very precise. Dr. Kumar, sir, and Dr. Nilesh and 70. They are not there. So we have total 6 abstracts, and to focus, we have 2 abstracts for the patients who have, this is a session of metastatic urothelial cancer. The 2 abstracts are the patients who have received platinum-based chemotherapy and they have gone on a maintenance by avelumab, which is Javelin trial, and for the Atlantis, which is rucaparib trial. One subset is in the platinum ineligible setting, bio study, and then we have second-line therapy, post-chemo, second-line urothelial post-chemotherapy. So this is the description of the abstracts. So we'll start with the medical oncology colleagues. We can start with Dr. Prakash and Dr. Chirag, followed by Dr. Chirag. How do you treat your metastatic urothelial cancer patients who are eligible for chemotherapy? And let us presume they are cisplatin eligible for this discussion.
Yeah, usual practice is with platinum-based, that is cisplatin gemcitabine for 4 cycles, followed by avelumab maintenance is
followed by avelumab maintenance. Okay. Dosed as MVAC?
No.
Okay.
Only cisplatin gemcitabine.
Chirag sir, any difference or gemcis?
Gemcis, but if the patient is fit enough, I will give 6 cycles.
You will give 6 cycles?
6 cycles. I mean, I will not stop at 4 cycles.
Okay. Anyone who would like to restrict to 4 cycles among the medical oncology colleagues, or 6? Because the trial permitted 4 versus 6, followed by avelumab maintenance. Yes, Prakash.
If performance status is good and tolerating chemotherapy better, then may go to 6 cycles. But
okay. And anyone who would like to give MVAC in today's era, and let's presume they all will go for avelumab maintenance. No one is for MVAC. And anyone is for triplet. There is some data set of paclitaxel, gem and cis. It's a phase 3 trial. Gem, cis, pacli, PGC regimen. Does anyone practice PGC regimen in the first line urothelial?
Slight improvement in survival, a lot of increase in the toxicity.
A lot of increase in the toxicity, and I think 0.5 month improvement is in the survival. Median OS was not significant. So we will just remember these figures. By doing this, we achieve a ORR of 45%, 50%, 8 months PFS, and a 15-month OS. So this is our landmark, which was there till we had the Javelin trial data set. And in the Javelin trial data set, the median OS is around 24 months. This is on the follow-up of 36 months. I mean, at a 3-year follow-up, the median OS is achieving 24, which is quite encouraging as compared to our previous landmark set which we had seen. So, Chandrakant, do you divide between PDL1 positive, negative? Does it make a difference, or do you check for PDL1 at the time when you enroll the patients?
I have nearly stopped doing PDL1 now.
Okay. What you were doing earlier?
I was doing earlier.
Okay. And why have you stopped? If the patient is eligible for platinum, will you do a PDL1?
If the patient is eligible for platinum, will I do PDL1? No, I will not do.
Okay. And if the
As I
patient
said, I have stopped doing PDL1.
Okay. And if the patient is cisplatin ineligible, then?
Probably yes, because I want to select patients for whatever drug that I plan to use, either Pembro versus Nivo versus Avelo.
Pembro or Atezo versus Gem Carbo. Okay. So yes, Dr. Chirag sir.
So if the patient is cisplatinum ineligible,
cisplatin ineligible, I'm talking. Yes.
I will still want to give carboplatin rather than doing PDL1 and giving immunotherapy.
Okay, fine. So this is what has changed, I think, in last 2 years. As the data has evolved, we have seen that the PFS has been inferior, and we tend to put the patients on Gem Carbo rather than putting them on atezolizumab or pembrolizumab, which we used to do it. And even the FDA has also issued a warning, and even in the PDL1 enriched populations, we would try to put the patients on Gem Carbo. Coming to the second data set, Atlantis, and we can have comments from any medical oncologist to your mindset, where does this maintenance fits in? So we have we have set our standards. We have our Gem Cis as the standard, or Gem Carbo, and then they go on avelumab maintenance. So where is the role of rucaparib? And let us presume that this is a DRD biomarker positive patient. HRR has been done, and it is an HRR or BRCA positive patient. So where will you put, is there any place in your practice of using this data set?
Yes, I think if you look at the data, looks promising in an HRR positive patient.
Yes.
So definitely with this data, I would like to pursue the testing in all the metastatic cases, and would like to offer them BRCA, olaparib, or a PARP inhibitor, whatever.
Okay, fine. But will you not offer them avelumab then?
Presently with the data, it is very, we don't have a head-to-head. And even in this trial, there is no head-to-head comparison with an immunotherapy. There is a comparison
There is
with
no comparison. We will come to the combinations also, but as of now, I already told you that we have set our standards, and now this has come into the. We can have Dr. Chandrakant and then Dr. Chirag.
Randeep, I think the better way out of this particular gamut of all the trials which get published is always go on to the financial aspects to make life simpler for us. Avalumab maintenance
Let us
costing is
presume
so
that
and so.
financial is not a problem, but still, would you and HRR positive will go on avalumab or not?
No, I would prefer, yes, I will prefer avalumab, yes.
In an HRR positive. Chirag sir?
So both in Evelyn as well as Atlantis, the PFS is 3.74 versus 2 months.
But sir, but yes, PFS is incorrect, but OS is in front of you.
OS is there in Evelyn. It is not there yet in Atlantis.
Yes.
And in Evelyn, it's phase 3, 700 patients. Well, here it is 17 plus 18 patients. So, I mean, this is too early data. Let us see. I would want to have a trial of IO plus.
I was about to come. I wish the trial the next trial which we see are avalumab plus olaparib and
that
then
is first line. That is first line.
First line, yes, the maintenance of avalumab plus olaparib. We will come to that durvalumab trial, but I wish that the trial we have is, as a medical oncologist, we see is avalumab plus a PARP inhibitor in an HRR enriched population, so that we can have a judicious use.
If we go on to our experience with say ovary, those patients who are HRR positive patients would respond even in later line of therapy also. So why not
But
just
see,
keep it
ovary
reserved for
patients
later
are not urothelial tumors, so we can't compare them with urothelial malignancies,
But then
which are really
the only
immunohot.
gist that we get is that they work in n number of lines also.
Okay, so we will just switch gears and I will take help from my surgical and now radiation colleagues. These are the biomarkers which medical oncologists, they talk, then they withdraw. Like they said, they will do PD-L1, then they may not do. Then the TMB came for pembrolizumab approval. We have two biomarkers which have been discussed here, ctDNA, which was presented, as well as HER2. And to be frank, I think as a medical oncologist, I can make this statement that we don't check for HER2 and at least in urothelial malignancies. And these are HER2 amplifications which have been tried. So how do you, counsel the patients? First, Amandeep and Nagaraj, sir, that when you see your metastatic patients, do you suggest any biomarker? And these are what are all been tested in clinical trials. And some are available in the FGFR, NTRK is proven, TMB is proven.
So, in the clinic, I do not speak to my patient about these biomarkers. They would, I think, be counseled by my medical oncology colleagues only. I think my job would only be to get the tissue sample for my medical oncology colleague. I do not speak to the patient.
And sufficient sample so that they can do all these, and keep on confusing yourself as well as ourselves. Okay, fine. Sir.
I think I'm an odd man out here, sir. I asked Ashish to handle all this.
Sorry, sir?
I asked Ashish to handle all this.
Okay, so Ashish is not in the panel. We will
having
take.
said that, I just want to ask all of you, how many of you are really gung-ho about circulating DNA as a unique one predictive marker? I'm not, but how many of you would be?
Okay, fine. So we can, we can take comments from any medical oncologist about ctDNA first. And before, I will just skip these slides and go, since sir has touched upon ctDNA. This was presented also, and this was actually the ctDNA prognostic and predictive role, mainly prognostic role. So would you like to do ctDNA, and then we'll come to the previous slide of all the biomarkers. Very quick comment, Chandrakant.
As a thumb rule in my practice, I don't do any testing which is not going to change my line of treatment.
No biomarker. ctDNA, no.
I would not.
Anyone would like to do ctDNA, and we end this abstract there only. For prognostic role?
No at present.
Chirag sir, prognostic?
As a part of clinical trial, yes,
No,
not in
clinical.
practice. Not in practice.
Okay, so we will not discuss this abstract, and thank you for making that simple and giving time to me to discuss the other. We'll come back to the other biomarkers. Sorry for jumbling of the slide. So this one. So PDL1, yes, no. We can have a consensus.
No.
Any role of PDL1? No. Okay, TMB?
No.
For pembrolizumab as a blanket approval, second line therapy.
Yeah, in second line, yes, and complete
Second
NGS.
line, yes. ctDNA, prognostic predictive, right now, no. Okay. HRR.
We'll do now. Looking at the data, I'm encouraged to do that.
When, sir? At first line, post first line, or at diagnosis?
If cisplatinum eligible, post first line.
Post first
Otherwise,
line, okay.
At diagnosis.
HER2? Yes.
Attempt to do it in second line.
Okay, yes, but.
Yes.
Okay. And HER2 which mutation or IHC?
IHC.
IHC, okay.
regarding biomarkers, I think in general, metastatic urothelial cancer is very bad prognosis and very poor survival. So before first or second line also, if patient is affording, then I would go for all these markers.
All these markers?
Yeah, all these markers, so that I can individualize the therapy. So, and as data comes, we can individualize therapy then.
And so you will use ctDNA as a, Ashish, I will take the comment, ctDNA prognostic predictive, since you said yes.
Yeah, it's prognostic.
But you would like to use it?
You can say the prognosis to patient also, and if ctDNA is rising after chemotherapy, say, then we can have close watch for symptomatic progression or radiological.
So if you start someone on GemCis, 4 cycles GemCis, ctDNA positive, you will put them on avelumab maintenance, or you will put them on pembrolizumab as second line, or you will directly shift to...
No. At present, not regarding this ctDNA.
Okay, Ashish, a quick comment, yes. Okay, so...
Second most mutant solid tumors.
I agree.
So you are likely to get something in the NGS. So it might be prudent to do NGS upfront. We may not use it for the treatment decision making, but yes. So that is point number 2. Point number 2, there will be some place for PD-L1 because for the atezolizumab bit, which is still approved for platinum ineligible when there is a CPS score of more than 5%.
I agreed. I think I will take the last comment. Sir, I will respond to the last comment, others, Chirag sir, that yes, if someone is platinum ineligible, yes, I have that slide also that if you have atezolizumab and your IC is more than 5%, then you can use in the second line. But the other thing is that the FDA has withdrawn. FDA has withdrawn. First line. You can use it in the first line. FDA has withdrawn the approval of atezolizumab as well as durvalumab. Yes, sir.
So in the first line, if the patient is cisplatinum ineligible, I will want to give carboplatin. And if the patient is any platinum ineligible, I want to look at PD-L1. I will give...
Then both are approved. In platinum completely ineligible, both pembro, ato are approved. And for a cisplatin ineligible, but carboplatin ineligible, if you have PD-L1 more than 5%, and you have approval for atezolizumab also.
I agreed. So I will just summarize the confusion, and that's why I did not oppose is that the panel do agree that gem carbo is a better regimen as compared to immunotherapy. And if anyone is not eligible for cisplatin or carboplatin, then there is no option. And then whether you check a PD-L1 of 3% or 5%, it will not make a difference. And I think both the four panelists of medical oncology did allude to that. So, thank you, Ashish, for your comments. ctDNA, I mean, of course, ctDNA versus tissue biopsy, we have to have more data, liquid biopsy. Here, the ctDNA has been used more like a prognostic and to follow it frequently. I will just go through 1 or 2 slides and then come to the third row. Platinum eligibility, I think we all know. We'll skip this. And so, again, to the medical oncology colleagues, chemo ineligible, I think we have already said that they will go on atezo or pembro. Anyone who would like to use any other immune checkpoint inhibitor apart from atezo or pembro? No. Okay. I will tell you why I'm asking is that we will just skip this and come to BEO. So comments about BEO trial, because the trial has used durvalumab. They have not used pembro and atezo. It is a first line setting, platinum ineligible. And as far as, to summarize is that if someone is platinum ineligible, we all agree they will go on a checkpoint inhibitor, and as of now it will go on an atezolizumab or pembrolizumab. Now how do we use this data set? Suppose we have a HRR positive, and to the house it was surprising when I was preparing these slides that 20 to 25% of the patients are HRR positive if you check them in urothelial cancer, 1/4 of our patients, and we never used to check them. So please make a note of that, that this is not 2%, 3%. In lung cancer, when you have 2%, 3% ALK inhibitor, the industry go gaga and the whole globe is singing. Here the HRR is 20, 25% in the trial. Okay, coming to the bio, starting from Chirag sir. Sir, how would you like to use this? Of course it is early, but how do you take this data set? Someone who is platinum ineligible and HRR positive, I will come to this, and HRR positive. Are you okay with this trial data set, and what a combination or atezo pembro? Now,
This is exciting, interesting.
Yes,
I would
sir.
want to look at the survival data before
Survival, sir, of course, the numbers are less. The survival is here. Durva plus olaparib versus Durva, 8.6 versus 5.8. And my reservations are that they are already comparing it with the Durva, where we won't use Durva in the platinum ineligible as a comparator. I am not happy with the comparator which they have used.
So some for IO plus if the patient is HRR positive, I would want to give targeted therapy, PARP inhibitor.
So platinum ineligible, first line, HRR positive. What would you use? PARP inhibitor plus checkpoint or only checkpoint as of now, Monday morning?
At present, I will give checkpoint only.
Okay.
But the data looks interesting.
But you would not jump to a
not at the
combination.
moment. I would want to look at the further data.
So,
yes, no. Will you buy it or not?
data is not very mature, but still for a metastatic setting, urothelial who is not fit for platins, with immuno, I would tempt to use a PARP inhibitor. That is something last line the patient is going to use. After that, it is supportive care. So why not to use upfront with a lower dose?
I will come back to you after this, what we can use. I will just come back to you about the third lines. Okay. Prakash, na? And then Chandrakant. Do you buy this data or are you tempted if the patient pushes you hard? Would you like to use it or hold?
I'll wait for the trial where HRR positive subsets where this olaparib and versus this immune checkpoint inhibitor is compared. At present, still in ineligible patient, HRR positive with some longer follow-up, I'll tend to use this.
So I do agree. Chandrakant, anything? Yes, no?
I would always use carbogem because the definitions of
No,
platinum.
platinum, they are chemo ineligible.
Yes.
Chemo ineligible.
Okay. If there was a third arm in this of using olaparib,
this is what we have now.
Yes. I would not buy this data.
So I am not tempted. I agree with all of you. The response rates are also not huge. I have put that keynote 5.2. The response rate, keynote 5.2 is single agent pembrolizumab phase 2 trial in chemotherapy ineligible first line urothelial. The response rates were around 27%. And I think the numbers are just 40. And yes, there is some encouraging data. But let's watch this space for the combination of checkpoint with PARP inhibitors for HRR positive urothelial cancer. I think that is what we can carry as of now. Okay, coming to the third line now, and I'll start with Preetham. This slide is, we don't have these molecules available, but yes, some are available like enfortumab, erdafitinib is available by compassionate access or you can import it. So we have patients who have been subjected to platinum and checkpoint inhibitors. I mean, either as an avelumab maintenance or in sequence. Most of us will have patients who will be subjected to a chemotherapy, gemcis, gemcarbo, then they will go on avelumab maintenance and then they will progress. So let us discuss about how to manage these patients who have already been exposed to chemotherapy and IO. Currently, we have FGFR positive, they go on erdafitinib. If they are FGFR negative, they go on enfortumab, which is, as per the approvals, is again an antibody drug conjugate. And yes, there is some accelerated approval of SG, that is sacituzumab govitecan. And we also have paclitaxel and docetaxel, which we do. Most of our patients, I think, will go on pacli and doci. And why I have summarized this, that I can have comments now from the all four colleagues about Trophy 01. If SG is available to you, how would you like to use it? I mean, are you okay using it in cohort 1? Because I feel the cohort 3, which is presented here, I will not discuss that because most of our patients will be exposed to platinum and checkpoint inhibitors. So cohort 1 was the patients who have been exposed to platinum and IO and they have been subjected to SG. So Trophy 01, anyone, any thoughts?
So if
Chirag sir and then Preetham and then, yes.
If I had two drugs available, enfortumab and sacituzumab, I will be interested in using enfortumab. But if that is not available, sacituzumab is a good drug.
Sir. Yes, sir. Very well said. Actually, the data is actually more mature. It was cohort, the Trophy 01 is actually a response rate was the primary endpoint. And it is a multi-cohort study, whereas enfortumab vedotin, we have a phase 3 data set where it has been proven. And what is encouraging is for the house is the median OS, if you see on the first column, is 13 months. In a third line setting, 13 months OS is actually encouraging. Yes, Preetham?
No, I agree with Chirag sir. Only concern was the side effect profile of sacituzumab.
Yes, yes. And even enfortumab vedotin has been
you
combined.
have 5 minutes now.
Yes, I will be able to manage. Thank you. Yes, thank you. Prakash and then Chandrakant, how would you like to use tomorrow if the SG, I mean, as per this data set, do you find any place in your prescription of SG? Let's say patient can import it and they are doing it for a hormone receptor positive breast cancers and they try to do it. I mean, we do have colleagues who are using SG for breast cancer, though very, very occasional. It's a very, very costly drug. Trodliv is the brand name. It's extremely costly and not available in India. But tomorrow, if it is there, would you like to use it? And how would you like to use trophy data?
So at present, in practice, we have progress after platinum and immune checkpoint inhibitor only.
Yes.
At present. And about this trial, I think there was toxicity also, and there is small sample size. So I would not go for this as for my practice.
Not go for it. Perfectly fine.
What this abstract actually tells me is that
yes.
what this abstract actually tells me is that I've got one more option for treating those patients whom I would have actually put on best support care. But before using this drug, I would always go back to the patient profile, check the patient profile, how long the DFS was after platin, and probably reuse platin before putting the patient on a toxic drug like HG. As will all other agents, we'll actually learn to use HG like we learn to use other drugs. We start off with a lower dose, start off with a tolerated dose. Probably we'll learn to use it one fine day.
Okay, and this is also actually very early. I will just, any comments for RC48 plus toripalimab? It is antibody drug conjugate. To my mind, I have no experience of using HER2-targeted therapy in metastatic urothelial cancer as of now in my practice. But anyone who has an experience of using a HER2 positive, anyone from the group or the house or the panel, do they check for HER2 or would you like to check for HER2 because of these trials coming in?
Yeah, definitely after this trial, would like to check for HER2. We have a new target.
And I think the duroxetine, at least in the trial settings, it is available for the breast cancer, though it is not available. TDX is definitely tilting the balance towards checking for HER2. And here, as of the story evolves, it is HER2 amplification and not mutation as of now. I think we are done and we can have the final comments from the panelists about we can start from we have 3-4 minutes. We can take the final take-home message. So I will start with Dr. Chirag and then others. Sir, we will talk about first-line platinum eligible avelumab maintenance and rucaparib.
So,
sir, very brief.
I already said that I will want to use the rucaparib with an immuno-oncological drug
in the as a maintenance
positive patients.
As a maintenance or later on?
As maintenance.
As a maintenance, you would like to use. Okay.
And I would like to add quickly that the first line, Evelyn Blader, not first line, Evelyn Blader Asian subset analysis is being presented in ESMO Asia in Singapore in this December.
Okay.
I am the second author in that presentation.
Okay, and can you reveal the results, sir? They are as encouraging as the avelumab or they are
as good as the entire subset.
Okay. So I will, we can have the comments from, in the second line, once the patient progresses. You can have the comments for the first line as well as second line.
So only promising thing was the PARP inhibitor study. If more data comes in, that is something encouraging apart from immunotherapy. Rest, second line onwards, NGS-based regimes like HER2 positivity is an encouraging study. And the sacituzumab 1 for third line.
Okay. Prakash?
So out of these 6 abstracts, I think for Monday morning practice changing is we should would like to check HER2 testing, HRR mutation, and one trial which had showed dramatic response rate, that was anti-HER2 therapy. And I think this is the most important trial, I think, out of these 6 abstracts.
Very well said. Chandrakant?
Anything more to add?
Nagraj, sir, any comments?
No, I was just merely ruminating. I think it's also important to identify the phenotypes who are going to respond besides the biomarkers, because most of the biomarkers seems to be not so critical. So even identifying, because that's a clinician's job. I had listened to some brilliant lecture on breast cancer and how we can identify the phenotypes along with the markers. That should probably help in individualizing the treatment.
Okay, sir. Amandeep?
Nothing much to add, sir. Just that a lot of times I'm the first point of contact for a patient in the clinic, even though if it turns out to be metastatic. From this, I'll probably just take heart in telling the patient that instead of a 15-month OS, my colleagues on the other side can probably push you to 2.5, 3 years with the advancing therapies.
No, thank you. Yes, that is there. At least if someone goes through all these therapies, I think they can at least be 2 to 3 years of survival can be expected, which is actually how the disease has evolved. That is one of the messages, that the median OS is not 12 months, 15 months, it is at least 2.5 to 3 years. Okay, thank you. Can we have a round of applause? And thanks a lot to all my panelists. It was actually very interactive and they really made my job easy. It was too difficult to incorporate these in the current practice as of Monday morning. But thank you to all the panelists and thanks to the organizers. Thank you.
Thank you, Dr. Randeep Singh and all the panelists for this excellent panel discussion. I thank all the chairpersons, Dr. Amit Ghosh, Dr. Devendra Pal and Dr. Ajit Sawant for chairing these major back-to-back sessions. Ladies and gentlemen, the tea is not yet ready, so I'm sorry, I'll have to keep you back in the hall till the tea is managed outside. And because we do not want to waste time, so I think we'll first have the inaugural function and that will be followed by tea. So the stage is being set for the inauguration. Give me a minute. Start calling you on the stage? Or लैंप कौन जलवा रहा है? हाँ? कौन है लैंप जलवाने के लिए? आप हो? आपके पास में है? मैं बुलाऊं? Good evening, ladies and gentlemen. I welcome you to the inauguration ceremony of the conference. To begin with the proceedings, I invite the dignitaries onto the dais. May I request our chief patron, Dr. ଂagship, sir, who's the senior uro-oncologist, Nanavati Max Super Speciality Hospital, to please come up on stage. I also invite program directors, Dr. ଂagship, who's a consultant uro-oncosurgeon at PD Hinduja Hospital, Dr. Santosh Menon, who's a professor pathology uro-onco at DMG at Tata Memorial Hospital, Mumbai, to come up on stage. Dr. Ashish Joshi, who's a senior consultant medical oncologist, MOC Borivali. And Dr. Ritu Dave, who's a medical oncologist from Mumbai Oncocare, Pune, also to come onto the dais, please. Knowledge has to be improved, challenged, shared, and increased constantly, or it vanishes. I request the dignitaries to formally inaugurate the conference by lighting the lamp, which is symbolic of sharing the knowledge and alleviating the suffering and disease. Can we have the lighting of the lamp? Sir, ଂagship, sir.
शुभं करोति कल्याणम् आरोग्यं धनसम्पदा शत्रुबुद्धिविनाशाय दीपज्योति नमोऽस्तुते दिव्यादिव्यारे दीपत्कार कानि कुण्डलमोतिहार दिव्याला पाहून नमस्कार तिळाचे तेल कापसाची वात दिवा तेवे देवा पाशी उजेड पडे विष्णू पाशी माझा नमस्कार.
Thank you, sir. So will you please come back onto the stage? There are things known and there are things unknown. And in between are the doors of perception. A great teacher is the one who takes a hand, opens the mind and touches the heart. It's my pleasure to invite Dr. Hemant Tungaonkar sir, who's not only a renowned uro and gynec oncosurgeon at Nanavati Max Super Speciality Hospital himself, but he's also an avid, dedicated and highly respected teacher who has trained several renowned uro oncosurgeons around the world. Over to you, sir.
Well, good afternoon, everybody. Well, it's my proud privilege and pleasure to welcome all of you, although it's quite late in the day, but I'm really grateful to all of you for having spared your valuable time to come here and be a part of this academic program. When we started the Urologic Cancer Foundation, we had decided that it would be a purely academic organization. And we decided to have something called Wisdom of Waves, wherein we would discuss the different abstracts, the newer trials, all the new data that's come up. It's impossible today for a single person to handle all the data that's being thrown at us. And I thought that we will have a multidisciplinary kind of a panel where we could discuss the application of all this data and the trials in the Indian context and see whether we can change our practice, whether we can advance our knowledge to a certain extent to give our patients the best. And this year, of course, we have had the great pleasure of partnering with Mumbai Oncocare Centre, which is another excellent clinical and academic organization. We are really happy and proud to be your partners. And I think normally we've been shall I say, stressing upon bladder, kidney, and prostate cancer. But I think a time has come when in the next program, we should also include the penile and testicular cancers, which are our cancers, and we've been not really paying too much attention to them. So please enjoy yourself. We still have half the program to go. And thank you very much.
Thank you, Dr. Tungaonkar. A dream doesn't become reality through magic. It takes sweat, determination, and hard work. Some people want it to happen, some wish it would happen, and some make it happen. Dr. Ashish Joshi, the founding member and director of Mumbai Oncocare, the largest chain of cancer daycares in India, wasn't looking for his dreams to interpret his life, but rather his life to interpret his dreams. I now invite him to take you along his journey of making this dream come to reality. Dr. Ashish Joshi.
Good afternoon, everyone. I think to speak after Tungaonkar sir and in the presence of all the dignitaries here, it's indeed a humbling experience. I stand here on behalf of MOC and not as an individual. So I think all of you are aware about what Mumbai Oncocare Centre is all about. So in a nutshell, it's by doctors and for patients, and that's where the story ends. We work together as a group. We share, we agree to disagree, and we cherish in sharing and exchanging knowledge. And that's the reason we requested Dr. Tungaonkar sir and Dr. Bakshi sir to give us an opportunity to participate in this academic feast, because we've been a part of Wisdom of Wave even before, but we thought we will engage formally and try to exchange, understand, learn and unlearn the nitty-gritties and craft of uro-oncology, which has seen a sea change over a past decade. So thank you so much, sir, for giving this opportunity. I wish there have been a lot of players here who have worked hard. To mention few, Saurabh and our marketing team has been instrumental in getting this organized. All the delegates, all the faculties, and all my colleagues, my teachers and my mentors are here. And I thank you very much for your presence. And thanks for giving us an opportunity to be a part of this academic feast. Thank you so much.
Thank you, Dr. Joshi. No one ever made a difference by being like everyone else. In order to be irreplaceable, one must always be different. For one who chases perfection, excellence is never an accident. It is a result of sincere effort, skillful execution, and vision to see obstacles as opportunities. I now call upon Dr. Ɂagship, who is the organizing secretary of this conference and who is known for these qualities, for his closing remarks and to propose a vote of thanks.
Thank you for giving me this opportunity. I begin with saying thanks to all the faculty and delegates who have been since yesterday probably coming in and giving participation in this program. A lot of you have traveled a long distance, so thank you very much. As Dr. Tongaonkar sir said, this program is all about getting the updates and the newer things in the literature and going ahead with it, whether we can apply it in our scenarios, in our daily practice, and whether we change for the better. So there are a lot of delegates here. Thanks for that. The organizing team, Ashish has already thanked Saurabh and his team. There are a lot of pharma people who have helped us in this endeavor in a lot of ways, including grants to the conference. So thank you very much. And we look forward to continuous discussions from your side, from the dais as well as down, where points or anything can be discussed and we all become much more knowledgeable about what we should do tomorrow. Thank you so much.
Thank you very much, Dr. ₦agship. I think the tea is ready, so I thank all the dignitaries present on the days for doing us the honor of inaugurating this conference. And I thank all the delegates for your beautiful presence. And now you can please have a tea break. It is a 15-minute break. I will be starting the sessions bang on time at 3:35, so please be back on time. Thank you.
You're listening to Proton Radio.
much rejuvenating tea and coffee break. Our next session is on geriatric cancers, and I call upon as chairpersons Dr. H.S. Pava, Dr. Kumar Prabhash, Dr. Randeep Singh, Dr. Ajay Kanbur. Dr. Pava is a senior consultant uro-oncosurgeon and urologist at King George's Medical University, Lucknow. Dr. Kumar Prabhash is professor and head of the Department of Medical Oncology at Tata Memorial Hospital, Mumbai. We all have heard from Dr. Randeep Singh, who is the Director of Medical Oncology at Narayan Health, Gurgaon. Dr. Ajay Kanbur is a senior urologist from Thane. I invite the first speaker, Dr. Joyita Banerjee, who is a consultant at Venu Geriatric Care Centre, Venu Charitable Society, National Representative SIOD, India. Dr. Banerjee, you have 3 minutes to present your extract. I'm sorry, it's 5 minutes. 5 minutes.
So should I start? So good evening, everyone. So as first of all, I think we are the minorities here, the non-oncologists. Very few handful, and I've been listening to all the treatment part and everything. So as we all know, there's a global demographic shift, and we are looking at an aging world. And you all will agree with me, cancer is a disease of aging. So we really need to gear up, because you all will be seeing more of older patients in your practice, and you might be seeing also. And there is a stark difference in treating younger adults and older patients. So with that, I would like to start with the abstract, then afterwards we can discuss some more. So this was a ASCO presentation. Does screening for frailty with the Vulnerable Elders Survey identify older adults with genito-urinary cancer malignancy who benefit most from a consultation in a geriatric oncology clinic? This is a group of Canadian geriatric oncologists who did this study. And so the introduction and objective, the role, so we geriatrician, we hold on to the comprehensive geriatric assessment. So this is something about assessing the patient in whole. It's not disease-oriented, it is patient-oriented. When the patient comes to us, we do a comprehensive geriatric assessment. And it has been seen increasingly being recognized as a cornerstone of assessment in geriatric oncology. So one of the scales, one of the common global scales that we use is the Vulnerable Elders Survey 13, the WEST 13 scale, a short screening tool, and it is very popular and is a brief frailty screening tool for persons 65 and older years of age. So the scorings are equal to or more than 3 are at higher risk for adverse outcomes and will benefit from a comprehensive geriatric assessment and cancer treatment decision optimization. So the objectives of the study were, the primary objective was to determine if the WEST 13 screening tool can predict which older adult, 65 years and older, with GU cancer has subsequent treatment modification after a CGA, after a comprehensive geriatric assessment. And the secondary objective was to investigate if there is any association between the WEST 13 score with comorbidity and chemotherapy toxicity. So the methods were, the WEST 13 was administered to consecutive patients referred to the geriatric oncology clinic, and 77 patients were included in this analysis. All patients also underwent a comprehensive geriatric assessment. The CGA has 8 domains. We see the functional status, the comorbidity status, medications for polypharmacy, cognition status, fatigue, psychosocial status, nutrition, and geriatric syndromes, or specific things that happen to older people, like falls or incontinence or mood deliriums. These are the geriatric syndromes. Then the descriptive statistics was done. So results was, it was seen that WEST 13 score of 3 or more, that's the vulnerable group, were almost 67.5%. And this vulnerable group was significantly associated with higher comorbidities and worse chemotherapy toxicity score by the Cancer and Aging Research Group. And the final treatment plan was modified in 47% of these 77. So in univariate analysis, the odds ratio was not very statistically significant for change in decision of treatment. But interestingly, it was seen that there was a strong association between final treatment plan with false risks or physical performance or cognition of the older adults. So the conclusion was that West 13 identified vulnerable GU cancer patients who would benefit from a comprehensive geriatric assessment. This is a screening tool. They have identified some vulnerabilities, and these people should go for a comprehensive geriatric assessment. And this may also predict treatment optimization by identifying patients at higher risk of chemotherapy toxicity and higher comorbidity, geriatric issues like functional deficiencies or falls or cognitive impairment. So here, my quick take-home message will be the comprehensive geriatric assessment, which we think is a cornerstone of geriatric assessment, is an effective tool for assessing a patient's functional age. Here, we are not talking about the chronological age, we are talking about the functional age. And it has been proven to be a strong predictor of adverse events in geriatric oncology. Identification, it also helps in identification of health problems, usually not screened during routine oncologic assessment, implementing non-oncologic interventions, and may also influence change in cancer treatment plan. So it is also recommended by the International Society of Geriatric Oncology. And above all the domains that we do in a comprehensive geriatric assessment that we have already discussed, frailty is an add-on. Frailty in older adults. It reflects well the functional reserve and is increasingly recommended in the oncogeriatric approach. And geriatric interventions are likely to facilitate a more appropriate and effective treatment plan. With this, I hand over to Dr. Prem, who will talk about the next abstract.
Thank you, Dr. Joyita Banerjee. Dr. Prem Narasimhan is a consultant in geriatric medicine, elder care specialist, physician at Jaslok Hospital, Mumbai. I invite him for a presentation of the next abstract.
Yeah, good afternoon, everybody. The contest has already been said by Dr. Joyita. There was just one correction. I'm also with Mumbai Oncocare Centre as well. So yeah, this was another abstract, but this was much earlier. This was actually in ASCO 2018. Again, a Canadian group only. So it was an impact of geriatric oncology clinic on cancer treatment plans and supportive care for older people with, again, you're talking about genito-urinary cancer. So older adults with cancer, as we know, have multiple morbidities, and they can either lead to over-treatment or under-treatment. So that is usually the issue or the gray area. So it has been seen that geriatric assessment in older adults for various cancers, I'm not talking only about GU cancers, has found that around 39% treatment plans have been revised. So although these findings support the need for a geriatric oncology clinic, whether such a clinic changes the treatment plan was not very clear. So they examined the impact of the treatment or plan of a geriatric oncology, clinic assessment in especially genito-urinary cancer patients with other enhancements in patient care for consecutive patients because they have a geriatric oncology clinic in a tertiary care center. So all refer patients, that is abroad it is age 65 plus, with a genito-urinary malignancy was seen in the clinic, again in Princess Margaret Cancer Center. There have been a lot of studies actually from that center, especially in geriatric oncology. Now patients were seen by geriatric oncologist, then the nurse, as well as treatment recommendations were provided to the referring oncologist. So it's pre and post geriatric oncology treatment plans and enhancements to supportive care were recorded. Now analysis was descriptive. Okay, now as far as the results are concerned, 98 patients were there and mean age was 80. So that's quite a bit. And 35 were seen pre-treatment, including 25 prostate, 5 kidney and 5 bladder. out of which 31 out of 35 were referred for input on the treatment plan. So the initial plan, which included surgery in 6 people, radiation in 14, systemic therapy in 8, and hormonal therapy in 11. Whereas the final treatment plan was intensified, that is obviously changed in 1 patient, reduced in 6 patients, changed to the best supportive care in 8 patients, and unchanged in 15 patients. So you can say around maybe an equal split wherein the treatment plans were changed and not changed. Now, overall, it results in the treatment modification as much as 52% of patients. And the enhancements to care, especially were in comorbidity management, that was 87%, then educational support, disease-related symptoms, that is around 39%, and the perioperative management, which was around 19%. So the conclusions were very clearly the geriatric oncology clinic helps in resulting in the modifications to the proposed treatment plan in half of the referred patients, so predominantly a reduction in the treatment intensity, and the enhancements to care in the vast majority of the patients. Now, geriatric oncology clinics obviously have a potential to avoid over-treatment and improve care for older adults with GU malignancies, so that is why we're here. So the quick comments or take-home will be, yes, geriatric oncology clinics, according to me, should be there. Collaboration of the geriatrician oncology, yes, we will talk about it in the panel as well, how we can do that. What is important, it helps in uncovering the geriatric impairments, evaluating a person's reserve capacity and ability to tolerate treatment, which is important, and estimating maybe a remaining life expectancy with and without cancer, estimating the prognosis and the risk of treatment-related toxicity and complications, and most importantly, not only managing and optimizing comorbidities and geriatric impairments, but invariably these things have an effect also on the oncological treatment. So thank you. Thanks for your patient hearing.
Thank you, Dr. Prem. May I also request you now to be the moderator for the panel discussion. I invite the panelists, Dr. Joyita Banerjee, Dr. Amit Joshi, who is a professor Uro-Onco DMG at Tata Memorial Hospital, Mumbai, Dr. Vivek Venkat, who is a consultant uro-oncologist and robotic surgeon, Mumbai, Dr. Vedang Murthy, who is a professor in radiation oncology at TMH, Mumbai, Dr. Nagaraj H., who is a senior consultant radiation oncologist, Dr. Rajiv Joshi, who is a consultant urologist at Hinduja Hospital and Shushruta Hospital, Mumbai, Dr. Amish Vora, Director and Consultant Medical Oncologist at Hope Cancer Centre, New Delhi, Dr. Ashish Joshi, who is a Senior Consultant Medical Oncologist at MOC Borivali. I hand over the session to Dr. Prem.
Yeah, so first of all, thanks a lot to all the panelists. I mean, we're obviously trying to get into a new sort of branch of geriatric oncology. Geriatrics per se in India is quite nascent. 1996 was the first MD in geriatrics which came in Madras Medical College. So we are almost just around 26 years into the specialty as well. But as an oncologist, there has always been, I mean, maybe a lot of you will agree that a challenge in taking care of older people. And it's sort of, we have discussed earlier as well that it has always been whether we go over or under, and sometimes we have learned from cases where we might have done either things. So just to a bit of content setting, the thing is, yes, we have to realize that we are an aging population. 2020 to 2030 was actually the decade of healthy aging. Now, what has happened, of course, is 2 years we lost in the pandemic. So we even got to think even better, actually, about how we will approach older people, because there have been a lot of innovative things which have actually happened technologically and non-technologically. And cancer has been a disease of the aging population. Now, in India, of course, the cutoff is 60. Probability of a diagnosis or a mortality is almost 11 times more or 15 times more as far as more than 65 years of age. So, and the prediction is very clear that we are almost going to have 4.5 lakhs older men and around 3.7 lakhs older women with cancer. Now, why geriatric oncology? Older patients can be underrepresented, especially in cancer services utilization and clinical research. Then secondly, national data, as of now, is having a lack of data, especially in the knowledge, attitudes, and practices as well. I mean, there was a recent study, especially from TMH only, which was done by Dr. Vanita. So that clearly told a lot of oncologists had an idea, but they did not necessarily actually do the geriatric assessment as well. Now, urgent requirement is needed, of course, to address this population, because this is actually, I mean, we are sort of fighting a silver tsunami very soon. Now, proper assessment protocol and management, which obviously, as ma'am has highlighted, geriatric assessment, then independent functioning, what is their physical and psychological health. Now, what's most important for us as geriatricians is to align it with the goals of treatment, especially for a person with cancer. That is the need of the hour. And sometimes care, cure, supportive, palliation, all these things will go together as far as an older person with cancer is concerned. Now, just before I go into the actual guidelines, I just want to take a quick comment from all the panelists about the two abstracts that we have. I can start with Dr. Ashish.
I think both the abstracts have been fairly interesting, and I think what it basically does is get to the subject of objectivity rather than a subjective assessment, which we all have been clinically doing. So to be very honest, I was just discussing with Dr. Amish that in the clinic, how do I take the decision? I just perceive that this is my perception that this patient would not tolerate a chemo or tolerate and he probably goes for a supportive care, or probably I need to de-escalate the treatment. But there have not been any hard tools, though they're obviously there, but they're not routinely used in my clinic. But I think that's probably the place where we need to get your inputs in order to make and fine-tuning the decision.
Yeah, Dr. Amish, because you obviously have been having a keen interest in geriatric oncology, and he is one of the very few who have actually done the assessment as well at his center.
I have little different take from Ashish that, I've been doing CGA for last many years, and I have done, in a literal sense, comprehensive, which will take around 35 to 40 minutes for each patient. 2013, I was doing exactly the same. 2022, I'm exactly doing the same. Somewhere, I think we have stuck. But one of the paper which you presented, which was very interesting, is hyper-escalating the treatment. I think that is the crux of geriatric oncology. Ashish and I seeing a patient in the OPD, 81-year-old, sheer number we are afraid. A frail lady walking, CO ovary, stage 4, pleural effusion and ascites. I'm little afraid. I think that's where the GA tells us, go ahead. Treat as you want to treat. I think that is going to be helpful.
Sir, please.
I'm a urologist. And the hospitals where I practice, we don't have a geriatric oncology clinic as such. So I personally have to assess the patient myself and then see whether suitable thing is possible for him, treatment is possible. Then we'll refer him to the medical oncologist, and then they take it from there. After they see the medical oncologist, the patient somehow comes back to me and says, is he suggesting this? Is it right? Should I go ahead? Should I not go ahead? And I tell them, see, they are assessing you with certain guidelines, and they will estimate what is the proper dose, whether you're suitable for the treatment or not suitable for the treatment. And only if that is going to benefit you with no toxicity. And the treatment should not be worse than the disease. If that is the baseline that you follow, then the patient does have a positive outcome from his treatment.
Thanks.
Right. I think that especially in urologic cancers, each cancer is very different. Each cancer has a lot of, the treatment options are very selective for each cancer. So there is a lot of component of surveillance in our cancers. There's a lot of component of very aggressive treatment like a cystectomy. So there is enough literature, especially in bladder, for elderly population, frail patients, and all those kind of vulnerable age groups and vulnerable population that we have. But we do need to develop it in other cancers, especially for the surgical point of view. I'm sure in medical oncology there is a lot of literature, but in surgery it's not yet that well developed.
Ma'am, just a quick comment.
Hello. Is it working?
Yeah.
So, for me, I think both the abstracts went a long way, good way in evidence building. That's what we need in geriatric oncology now. So we all know that we will be looking at aging population, and they are different from our younger population. And as Dr. Amish said, we break that inertia and go ahead. We have to take that step. Yes, this person, before it was only 60. When people used to, patients used to come to the OPD at 60 years only, we would say, oh, 60, no, we cannot do anything else. But now, see, things are, improving, and we now take patients at 75 and 80 and 81. So what we need to do is we have to incorporate this geriatric assessment. As oncologists, you all need to incorporate it. Maybe not the whole of comprehensive geriatric assessment, it is a time-taking thing, but we do have other scales, just a geriatric assessment. When we tell about comprehensive, we mean interventions also in the different domains. But just a geriatric assessment to know where the patient is standing and what are the other things we need to do for the patient other than treatment, to enhance their quality of life, which should be a very important thing in an older patient, where the quality of life is very important, and the goals of treatment are also very important, and we need to stratify them into fit, vulnerable, and frail. Because in resource-limited setting like ours, we should not send the frail patients ahead for all the PET scans and the radio diagnosis and everything. We should give them palliative and supportive care. This also is important. Where we are pushing for treatment, we should also know where to stop treatment and let go. So I feel it's very important for a geriatric assessment.
So as far as ASCO is concerned, of course, the use of the geriatric assessment has become the standard of care. The roles are pretty much three-pronged. So one is to identify the vulnerabilities that the older adult is having. Second is to use it along with obviously the oncological prognosis which you have in mind. And secondly, to target interventions, because ultimately that is what we need to know, where this particular patient will go, whether it's going to be aggressive, whether not aggressive. We take a step back, we wait. And of course, multidisciplinary team interventions guided by the assessment can significantly decrease toxicities without affecting the survival likelihood. So there is a lot of talk about the CRASH and the CARGE, which are tools which have been developed especially to sort of look at these toxicities. So by targeting interventions, especially to the specific needs, and by changing the decision-making treatments. So if you look at this is what, if you look, there is a balance of the patient vulnerability and the life expectancy and benefits and harms from treatment. So geriatric assessment can obviously be used to measure the vulnerability so that we actually know that we see whether there is a patient who actually will not benefit and still we end up giving the treatment. Or there is another thing which is very important, which I'll come in the case, which I'll discuss, of course, is that patient preferences have always been taken into consideration by oncology, and I don't think that it has not been taken. But when we have a geriatric assessment and the patient preference, I think it obviously will help in assessing outcomes better. So as far as this case is concerned, so this is basically Mr. K. He's a 75-year-old gentleman, self-defined as healthy, because there are a lot of people who we ask, ki aapko kaisa lag raha, how are you? And they are pretty much saying that age is a number, I feel quite fine. So having an intermediate risk prostate cancer, but comorbidities. So comorbidities is coronary artery disease, status post CABG, then there is hypertension, there is dyslipidemia, there is chronic kidney disease, and there is osteoarthritis. So there are a lot of organs affected, a lot of organs maybe to an extent dicey. The medications are, yes, aspirin, atenolol, lisinopril, paracetamol, and rosuvastatin. Paracetamol, he just takes it very occasionally for the knee pain. Apart from that, these are the only medications. Then as far as the labs were concerned when they presented, so he had an anemia, a PSA of 11, doubling time was around 11 months. The prostate biopsy Gleason score was 7, 4 plus 3, and CT and bone scan did not really show any overt metastatic disease. However, the person had mild fatigue, lives alone, has a daughter with him at the visit who lives nearby and works during the day. So it's quite stone throw, so she actually does visit. And ECOG-1 is the sort of performance status. So to bring in, of course, the oncologist, medical oncologist here, so how would we want to proceed? Do you think there is a need of a geriatric assessment?
So typically, I think assessing patient from a geriatric, the way I do it in my clinic, I look at incontinence, I look at cognition, and I look at fall risk. These are the three things which I look, apart from the social support that the patient has, and then most of the decisions would be governed on this. So here I see that he's laden with comorbidities. He has fairly localized prostate cancer, I believe.
Yeah.
With the intermediate risk thing. So first and foremost in prostate cancer, we define what is the life expectancy of a patient and then decide about the treatment plan. So, I mean, with so much of comorbidities and his age is 82?
No, 75.
75. So we are at least having a life expectancy more than 5 years for them.
Yeah.
Then the first decision whether to decide to treat or no is to be made. So that's point number one.
Okay.
And once we decide to make the treatment decision, we have 3 treatment options. Probably surgical option looks little less on the cards with so much of comorbidities. We'll have option of ADT and RT. These are the 2 options that we have. I think ADT also there will be challenge because she's got coronary artery disease and other comorbidities, and the ADT will put them at a risk of enhancing those toxicity. So we will obviously discuss the risk-benefit ratio of treatment versus no treatment and treatment side effects versus the benefits with the caregivers, and eventually may for this patient land up with simple orchidectomy.
Okay.
At the end of the day, if patient is not willing for anything else. But this is the sequence in which one would assess.
Okay, sir. Amey sir, I'll ask you a question which you always ask us. Finally, I'm on the other side today. So do you think geriatric assessment will help you in this patient or it will make it
1000%.
Okay.
This patient, you have picked up a very right case, and as Ashish mentioned that it is very crystal clear, intermediate localized prostate cancer, patient is going to live beyond 5 years with the disease if treated properly. There is almost no doubt about that. So here the most important thing about the geriatric assessment, what is the life expectancy without cancer? So normally what I do in my clinic is e-prognosis calculator, and I add Charlson comorbidity index because that gives me 10 years. This particular patient will be very important to know because he is not going to die of cancer. So we have to be very crystal clear, is he going to die of comorbidities? Is he going to die of cancer? Yes. I think also this particular patient, single shot surgery if he is very fit, 75, because all the comorbidities, I don't see any end organ damage as of now what you have shown. So either radiation or surgery, one of the 2, and the person will be cured.
I just want to know how bad is the CKD?
A CKD is pretty managed. It's not bad. Okay, I mean, I just want the surgical opinion. Do you agree with?
Yeah, I agree pretty much with everything. It's just that, like he said, there is no end organ damage. His ECOG is pretty good. He's a functional person. And if his life expectancy we expect will be for me to operate at least 10 years, then only I would even think of surgery for him. Otherwise, I think radiation would be a pretty good option in this particular case. So that's why we need to know the details of his physical assessment, echo, all those functional status, as well as the geriatric assessment, his frailty. That would be also, all those variables will play a role in giving us an idea.
Sir, in a standard, if you want to take this person under knife, so in a standard pre-op assessment, what would you want? Is it the usual echo and...
Anesthetist would require 2D echo, stress test, the regular biochemical workup.
Yeah. Okay, and
if he's certified fit, we can do orchidectomy.
Yeah, would you be worried about the comorbidities because he's got almost 4?
Orchidectomy, I would not worry so much.
Okay. Okay, so basically ADLs, that is the activities of daily living. Now, so the daughter is the one who fills the pill boxes each week and manages the finances. So he's not entirely independent as such. Fall assessment, he has had 2 injuries due to falls. Then a short GDS was done. So now one of the very important questions that always comes in every geriatric oncology clinic is the duration of the geriatric assessment. Now it's always, there is a waiting period. There is a time that you actually see the doctor. And then, of course, the decision making. So a lot of times, especially abroad, they use the waiting period to quite a bit of extent. It might or might not be very easy to do it in India because the waiting period might not be as sort of smooth as compared to abroad. So overall, if you see this, around 10 minutes is what it will take. But again, with the help of the daughter. So if the person would have come alone, then he wouldn't have been able to do it. Then his CAST toxicity score was around 12. So placing him as a high risk for worsening frailty from surgery, radiation, and hormone therapy. So this is what we saw. However, for his non-cancer life expectancy.
Dr. Prem, sorry, if you go back to the previous, CARG, does it cover surgery and radiation also? It covers mainly chemo.
Yeah.
In fact, it does not cover hormone also, does not cover IO also. So I think what Dr. Joyita and you together are trying to do,
Exactly.
an Indian scoring would be a better option here.
Yeah, so that is why the slide, and you saw it also, that I have not written chemo in that. Okay, so for the non-cancer life expectancy, of course, Schoenberg index was derived from e-prognosis. So it's 12. So 5-year non-cancer mortality is 37, whereas cancer-based prognosis is well over 90% with treatment. So he's more likely to die of something else as compared to prostate cancer in the next 5 years. So in this particular case, the decision was actually radiation. But whole hormone therapy, pre-treatment physical therapy was done, OT was done, home safety evaluation, because he's fallen. So we need to take care of those things. Mild cognitive impairment was there. So he needs help with medications, finances, and shows. So that was also sort of helped by the daughter. Now, the most important thing here I also want to highlight is that everything was communicated, of course, to the patient. So the patient actually told the preferences and decided against hormone therapy, saying that no, he listened to all the side effects, and he was like, he will not go for hormone therapy. So overall, this case was just trying to help you out in saying that it can help in optimal and comprehensive care for the older adults. But at the same time, a person who's 75, and so there definitely shouldn't be an ageist sort of attitude, and I don't think it happens at all during this particular sort of way of treatment. Now, just going on to another way, there is obviously a scope of collaboration. Now, geriatrician and oncologists and models of geriatric oncology care are there. So I'll just bring in Joyita ma'am here. So ma'am, how do you think is the best way? Because I will go to the slide next where there is mentioned and how different ways we can sort of work together. But what do you think? Because there's a lot of problem, especially in India, where the biggest challenge we always had is we have a lot of sort of trials abroad, we have a lot of research abroad, but those scales might not always be applicable to India. So would you just want to your comments on that, and then I'll just talk about the models a bit.
Yeah, this is a very optimum, very nice, beautiful case. You are taking the patient in consideration, which is the first thing that we don't do in India. The patient half of the time doesn't know that he is having cancer. We don't take the patient in decision making. And what we call a shared decision making in all our articles from the Western countries, we don't have a shared decision making here. So first thing that we should be doing, first, all the scales that we follow, the globally popular scales like we presented the West 13 or the Geriatric 8, or all the scales that we follow, they are very oriented towards the Western culture. In India, it is totally different. In India, most of our older patients are minimally educated. Awareness about cancer is not there, and there is a big, fear of cancer. So the patient party, when they come to you, they first tell you that don't tell the patient. The patient is totally anxious because he or she has come to the hospital, and he or she knows that something is happening, but we are not telling the patient. The patient's anxiety level is there, stress is there, depression is there, pain is there, everything is there. So first what we need to do is, as geriatricians, what we do is we take into account the patient's perspective, and while the oncologist takes care of the tumor perspective or disease perspective. So what we need to do is we need to have a scale which is oriented to our cultural milieu. We actually need to do all the domains that the CGA tells. Including the social support domain, which is very important in our scenario again, because they have to be seen through the whole cancer treatment. They need to have social support. And cognition is very important. Here we see the doctor is taking care of the pill box. If the cognitive acumen is not there, then the taking the medicines and all, there will be problem, there will be falls and all these things. So first we need to do a geriatric assessment with a scale which is more, can be used in our scenario, not some of the scales that we use in use abroad. So we have actually developed a geriatric assessment scale after about 5-6 years of study and seeing how the patients come to us. We have developed such a kind of scale which does take around 20 plus minus 5 minutes, but we can always shorten it again and look into the immediate things like Dr. he said that we should be looking into, cognition, or we should be looking into incontinence or falls. So these are some of the important things that we should be seeing, and the functional status. So even the scale that we have developed, it is very heavy on the functional status of the patient. The functional status goes a long way. It has been proved also. Evidence is there that functional status goes a long way in survival, and also toxicity and taking in medication and for everything, and the quality of life of the patient. So I would suggest that we first go do a geriatric assessment, which is more for our cultural milieu, and then we go to the oncologist, and then there is a collaboration between the oncologist and the geriatrician.
Just wanted to add, and I wanted to ask urology friend here, suppose if you or Joyita ma'am has done CG on this patient, and you have found that there is history of 2 falls in last 6 months, both the fall resulted in injuries, there is a cognition issue. In this patient, shouldn't the category 1, as Ashish suggested, can be a simple bilateral orchiectomy? 20 minutes of procedure, I'm sure they know better than us, but and there is no risk involved. And we definitely know that bilateral orchiectomy without radiation will pass through patient 7-8 years definitely. And let's not put the patient under rigor of RT, which is EBRT for 5 weeks, with incontinence issues, as Ashish has said. So
I think the issue here of cognition is more important, because the ADT will worsen his cognition. So I think that just a orchidectomy is not, in this particular case, I wouldn't agree with that, because he still has a good life expectancy. And he has
you have last 1 minute to wind up, Dr.
We have 6 minutes left.
You have 6 minutes, right? The timer shows.
No, sir. It is 25 minutes, so 24 minutes are over. So last 1 minute.
Yeah, no, because it was okay. Let me just talk about models of care here. So these are the various models which have been sort of enlisted in one of the sort of research by Dr. Mohile. So one is, of course, screen and refer. So screen with a validated tool, and then, of course, you can obviously see the advantages and the disadvantages. Then, of course, the shared care, in which the medical management will be divided between the primary care provider and the oncologist. Then, of course, the multidisciplinary model, in which, of course, the patient will be referred. Then geriatric assessment is actually performed by the multidisciplinary team. Then, of course, there are other models as well. The geriatric-driven or the embedded consultative model. So in which a geriatrician or a geriatric-trained nurse or physician embedded in the oncology clinic as well. So that is something which is obviously coming up in quite a bit of areas in India as well. Then a geriatric oncology as the primary provider. So for example, an oncologist who is trained in geriatrics or a geriatrician who is trained in oncology. So that sort of dual training also might be the way to go. And of course, a self-administrated geriatric assessment, which might or might not always work, because trust me, whenever we have done scales, we have seen the understanding of the scale, however simpler it will be, is quite difficult. So they need sort of help. So I would just want to take final word from everybody that which model do you think of these will work best in India, or which models will work? I'm not necessarily wanting to say that one model will work. So we can start with Dr. Ashish and we'll end with Dr. Joyita.
Yeah, so I think it has to be plural. It can't be singular model because it also will heavily be contingent upon what setup of practice that you are into. But definitely, geriatric assessment will add a lot of value to oncology care in general. And we definitely need a India-specific guidelines, and that's where probably people like all of you and even the oncologist community needs to contribute to come to a consensus that there could be 2 or 3 different types of models which are quick, which are applicable, practical, and which could probably help us in making a quick decisions for the patient.
Yeah, Amir sir.
Just whatever Ashish said, I agree. Just we need to add one more specialty of geriatric molecular oncology. That is what I would strongly suggest we start now, so that 5 years later we have our own data.
Multidisciplinary model will work better.
Yeah,
Rather than one person doing everything. You should have a team.
Yeah, if you can sit with us till we know how to assess the patients well, and we work as a team together, MDT, with such interesting cases, that would be the best way.
I also agree with the multidisciplinary model, but it's not everywhere, it's not possible. So one more thing is that there will never be enough geriatricians, there will never be enough geriatric oncologists. So I feel because the oncologists are actually geriatric oncologists, you are all seeing older patients, so a basic training in geriatric ways among oncologists will actually help a lot. And we should start, during the medical training process of the oncologists, and some geriatric assessment should be taught to them so that, they can carry on with a simple assessment. So I would say the optimum thing would be a geriatrician seeing the patient and then referring to the oncologist and then a multidisciplinary team working together. But an oncologist should always have the basic knowledge of the geriatric assessments, simple geriatric assessments that we do, and awareness of the geriatric issues.
Yeah, I just want to add to it that ultimately I think it is the responsibility of us being geriatricians and the oncologists to actually understand which patient might need it and which might not need it, because ultimately that is what will improve the treatment. And before I end, there is going to be an online advanced course in geriatric oncology, so that is on November 19th. So that is with Sehwag and Tata. So, I mean, you can register on the SIOG online portal which is given, and the last date is, of course, November 6th. So thank you. Thanks for your patient hearing. And thanks a lot, panelists and chairpersons, please.
Thank you, Dr. Prem. I thank the chairpersons, Dr. Pawa and Dr. Randeep Singh, for patiently chairing this session. Thank you very much. I now invite Dr. Reshma Kurgaonkar to enlighten us about the clinical trials at Mumbai Oncocare with respect to GU malignancies. Dr. Reshma is the head clinical research operations at Mumbai Oncocare. Over to you, Dr. Reshma.
Good evening, everyone. So, I am here today to present clinical trial contribution of Mumbai Oncocare Centre. So, if I say highlights or strength of Mumbai Oncocare Centre Clinical Research Department, first and foremost is efficient, experienced, and very enthusiastic investigators to guide a research team for clinical trials conduct. And our medical oncologists are really backbone of the clinical research department. The second point is dedicated research team for prospective clinical trials. So we do have dedicated research team, be it research coordinator, quality assurance officer, clinical trial assistant, and also the data associate. The third point is clinical data associate for retrospective studies and publications. So here I would like to specify on our centralized electronic medical records, which gives us access for retrospective studies as well as the potential patients identification for prospective studies. So having robust medical record across all Mumbai Oncocare Centre is playing really vital role in every clinical trial and also the prospective and retrospective studies. The next point would be developing well-equipped and trained clinical sites at various MOCs. So considering importance and needs of clinical trials in medical oncology, we are developing new clinical research sites, which are our MOC centers, which are well-equipped and trained clinical research team. Then internal quality check and quality assurance plan. I would like to elaborate more here because it is really unlikely that clinical research sites have quality check and quality assurance plan. Up till now, it is a domain of sponsors or CROs. So we are one of a kind clinical sites wherein proactively our clinical research quality assurance officer reviews the site processes, documentation, protocol compliance, and also the patient care. Then the next point is regional institutional ethics committees. So we do have 3 regional ethics committees. So these are these 3 committees for Mumbai region, Nashik region, and Pune. So we have our institutional ethics committees to ensure the competent and the timely review of all ethical aspects of projects, proposals received in order to safeguard the dignity, rights, safety, well-being of all actual as well as potential research participants. Mumbai region, Mumbai Oncocare Centre Institutional Ethics Committee is looking after 3 of our centers, like one is Vile Parle, Thane, and Kemp's Corner. Nashik Ethics Committee is reviewing for Hope MOC centers clinical trial projects, and the Pune Ethics Committee is under the registration. So this is our clinical research unit for Mumbai region. This unit is for Nashik. Okay. After this details of ethics committees, we do have multiple clinical research sites, as I mentioned. So active sites are Kemp's Corner, Vile Parle, Thane, and Nashik. And we are running actively phase 2, 3, 4 clinical studies at these centers. And also in development, Pune, Kolhapur, Aurangabad, Nagpur, and Indore. So what is our research team? So research team at our clinical trial function. So 1 head clinical research operations, the 7 clinical research coordinators which are conducting actual clinical studies, 1 quality assurance officer who is taking care of all quality check and assurance plan, 2 EC coordinators, one is for Pune, one is for Mumbai, one is for Nashik, 1 biostatistician for publication and all our retrospective studies, 1 clinical trial assistant to take care of all other clinical trial assistant programs, and also 1 clinical data associate who is playing crucial part of all retrospective studies, journal publications, and collating the data. So here again I emphasize on research-specific equipments. So these are the equipments our all sites have. Here again I will take the privilege to share that our each site is well equipped with, to conduct various studies. For example, phase 1, phase 2, phase 3, phase 4, bioavailability, bioequivalence, pharmacokinetic, pharmacodynamic, immunogenicity, biospecimen, interventional and non-interventional studies. So these many equipments are really not easy to keep it in community oncology practices. So we have started 2 years back, and in these 2 years we have completed almost 83 plus feasibility studies for various stages and various indications. So this is how the national and global approach to the sites, various CROs and various sponsor companies. And we have completed feasibilities for all those sponsors. So in our ethics committee, Mumbai, we have approved till date 35 pharma-driven projects and 16 academic projects in various indications, various phases. So this is something important. These are the projects in hand right now. Various indication you will see, the study medication, various phases. There are identified patients, and I would like to share you that almost 40% studies we are the highest recruiter. And these are the site location like Vile Parle, Thane, and Kemp's Corner. Nashik is starting very soon in like next week itself. Certain projects recruitment is open, certain projects recruitment is closed. This is the second part of this projects in hand. So up till now, there are 26 projects in hand right now. We could identify 188 patients, and we enrolled actually 141 patients. So this is where our EMR, electronic medical data, helps us, like to identify patients who are potential for upcoming studies, also to generate some analysis plan based on the existing patient data. So as I said, there are 16 projects approved by EC, 16 protocols, academic protocols approved by EC. However, I will emphasize only on the retrospective projects which are in GU malignancies. So we have done prostate cancer and one in renal cell carcinoma. In prostate, we have evaluable patients were 75, and rationale was to assess treatment patterns in advanced prostate cancer of Western India. The other project was renal cell carcinoma. We evaluable patients were 48. And rationale was to evaluate clinico-pathological profile, pattern of treatment, and response to the treatment in patient with metastatic RCC. So there are 26 odd projects in our hands. Still, I would like to discuss about 3 studies which are related to genitourinary cancer. So first was immunotherapy in metastatic renal cell carcinoma. You would see the numbers. We have identified 30 patients. Total patient enrolled were 20. 8 patients were screen failed because the sample was not evaluable. There are 2 patients still in screening. 4 patients completed. Rest all patients are on the study treatment. Few are discontinued. There are minimal SAEs in past 1.5 years. There were only 3 SAEs. The common adverse events are being increased creatinine, skin rash, itching, weakness, cough, increased bilirubin, fever, etc. We do assess overall response, wherein complete response, we achieved complete response for 2 patients and partial response for 6 patients. So even after the completion of the study participation, as per CT Clinical Trial Rules 2019, patient could get the post-trial access program, wherein after study participation also we could provide immunotherapy to the patient as a compassionate ground. And there is survival follow-up wherein only 1 patient died and rest all 19 patients are alive. The other study was tablet pazopanib in renal cell carcinoma. So total identified patients were 12 and enrolled were 11. 1 was screen failed. Completed treatment 9. SA happened 1, early discontinued 1. And there is overall response CRPR, ST. And patient continued post-study, that is on compassionate ground, were 2. Survival follow-up, 7 patients alive, day 2. So the third project in genitourinary is for advanced prostate cancer, wherein goserelin 10.8 mg injection. So here we identified 4 patients and enrolled 3 patients. 1 patient was screen failed because of testosterone levels, and treatment completed 2. 2 are still, 1 is still on the treatment. And patient is 1 patient was continued on the post-study treatment program. 2 alive, 1 dead. So this is goserelin study. This study was phase 3, 2-arm, multicentric, randomized, open label, parallel study to compare pharmacodynamics of goserelin, test versus reference in advanced prostate cancer. So duration of the study was 183 days, and total 84 patients will be enrolled in the study. So here test and reference, 2 doses are provided in the study, day 1 and day 85. And rest all doses will be on compassionate ground. So these were the study objectives and endpoints. Primary objective being pharmacodynamics. Secondary was pharmacokinetics and the safety. Endpoint, proportion of patients achieving castrate level of testosterone. The range is mentioned, that is less than or equal to 0.5. And the secondary endpoint is proportion of patients achieving serum testosterone level less than 0.5. Pharmacokinetics and safety. So main inclusion criteria for this study is patient with confirmed advanced prostatic adenocarcinoma, stage being 3 or 4, or recurrent metastatic disease. And second important inclusion criteria is serum testosterone level more than 2.5 for age 20 to 49 and more than 1.9 for age more than 50 at the screening. So the objective of this presentation was to give brief idea about clinical trial at Mumbai Oncocare Centre. So let's work together for patient care and expand our vision for future benefit to the society through clinical research. Thank you so much.
Thank you, Dr. Reshma Kurgaonkar. I welcome you all to the next industry session, which is being supported by MSD. And I invite Dr. Shivam Shingla to deliberate on new paradigm in the management of urothelial carcinoma. Dr. Shivam Shingla is a medical oncologist from SL Raheja Hospital, Mumbai. Over to you, Dr. Shingla. Is he here? MSD people, are you here? Let me just find out outside. Have gained time. Dr. Shivam is here. Is Dr. Shivam? Yeah. I'm sorry we have gained time, so
yeah, we are,
sorry we got you in
time.
Earlier.
No, I'm happy.
But I think you can go and enjoy your dinner much early then.
So 5:50. So thank you, MOC. Thank you, Dr. Ashish, for having me here. And I would like to extend this thanks to also MSD for having me for this talk. I have been instructed time and again that you cannot be finished before 30 minutes. So let's go slow by slow and let's look at what we have been able to achieve with this product in metastatic urothelial cancer. So these slides have been given to me by MSD. Again, if there is any adverse event, please report. Let's look at urothelial cancer per se. It still remains to be one big problem that we face in our country. It's the 10th most common cancer across the globe, 13th leading cause of death. And somehow we see that the incidence in men is 4 times higher as compared to women. Majorly, when a patient comes to us, we ask a history of smoking, alcohol, dye industry. These are the main predisposing factors which lead to development of this cancer. Overall, Asia is considered to be a hub of urothelial cancer primarily because of high incidence of tobacco use in our subcontinent and countries. And the presentation, the median presentation is about 70 years of age.
INTAS. At the outset, we have a talk by Dr. Preetam Kalaskar, who will be talking about the advances in novel formulations of taxanes. And I would like to invite Dr. Preetam Kalaskar. Dr. Kalaskar is consultant medical oncologist at MOC Thane.
Hi, good evening all. As been a urology conference, docetaxel is one of the chemotherapy molecule which most of the people who are in the hall must be aware of. Used in breast, used in prostate rampantly, and a very, very useful drug there. There is something related to the drug administration which happens, and some patients, I would say, not a significant number, but yes, there are patients who have hypersensitivity, and this hypersensitivity sometimes can be bothersome. On that, I would like to begin this presentation. It is a sponsored session. This is on advances in the novel formulation of taxanes. Based on the hypersensitivity, there have been some changes into the molecule which will be presented. We all have been using conventional, and the change which they are proposing is nano-Ɂgship technology. Is this just for hypersensitivity, or is it a solution or a more effective drug? We have been using it in breast. The drug, the conjugate, which causes the hypersensitivity, we all know it is polysorbate 80. 30% is what they say cause hypersensitivity if you don't give pre-medication, but I hardly remember anybody not giving pre-medication. The percentage of patients showing reaction, I would say, is around 5% in clinical practice. Though it is reported here 8 to 13, but it is actually, I would say, not very high. Patients who receive prophylactic steroids, the percentage is even lower. Based on the hypersensitivity, which sometimes can be fatal in some patients, though reported. Hence, FDA has issued a black box warning for the docetaxel on this hypersensitivity. So, it suggests an adverse effect as an associated with prophylactic use of steroid. One has to be very cautious giving this prophylactic doses of steroids. Initially, it was for 2 days of 4 milligram of dexamethasone, then on the day of therapy, and then 1 day later. So almost 3 to 4 days of steroids sometimes make this patient more hyperglycemic, or there is maturation of cataracts, or there are other side effects because of the steroids which are commonly seen. Nowadays, we have reduced the use of prophylactic steroids because of these complications, and in some cases, using these molecules which are advanced, we don't have to give steroids. So, message is, when you use conventional taxanes, there is a risk of using excess of steroids which can harm the patient. Another complication which can be seen with use of docetaxel and high dose of steroids is candidiasis, more so with the diabetic patients. Then comes this technology which is called as nano-₦gship technology, which tries to remove the polysorbate 80, which was actually carrying the paclitaxel molecule and causing the hypersensitivity. With this technology, you can avoid it and indirectly avoid the hypersensitivity reaction. This is the structure of it. I may not be the right person to comment on, but this is how it looks like. So, this molecule, there is no grade 3, grade 4 hypersensitivity, no need of steroids as a pre-medication. If you compare the conventional versus the nano-₦gship form, yes, the conventional requires polysorbate 8. Here it is completely aqueous. You require a PVC bag for the conventional one. Here we don't require it. Hypersensitivity, yes, in the conventional form. No, not a major concern with nano-₦gship. Adverse effects of steroid, yes, on the conventional form, not on this side. Safety concerns, yes, they say, and limited as per the formulation, but other than hypersensitivity, most of the other side effects, what we clinically practice are almost same when it comes to taxane to taxane. Other than hypersensitivity, it is almost same. Size of the molecule is somewhere around 100 nanomicrons, and this they suggest it helps in penetration of the drug into the tumor tissue because of the size. These are some pharmacokinetic profiles which are almost same to the conventional one. The peaks are almost matching when you come to the, when you compare it with the original molecule Taxotere compared to nanoalcoholic form. This was the open label randomized trial for multi-dose clinical study about the same drug which was done in metastatic breast cancers, and the doses were around 75 milligram per meter square, 6 cycles. And if you see the overall response rates were almost same when you compare both. Again, the adverse reactions, when you compare the conventional Taxotere to the nanoalcoholic, the hypersensitivity was more with the conventional one. Rest of the side effects, I would say, more so almost same. Even neutropenia is slightly more reported on the nanoalcoholic form. Serious allergic reactions like bronchospasm or swelling of face were not observed with the nanoalcoholic form, whereas conventional docetaxel, 2 cases of bronchospasm and 3 cases of swelling on face were reported. These are the various dose rangings of docetaxel. We usually practice around 75 milligram per meter square. Yes, in breast we sometimes use 100 milligram per meter square also. Dose ranging efficacy, as the dose increases, the efficacy increases, but tolerability is an issue beyond 80 milligram per meter square. So with this, there is an FDA approval for triple negative breast cancer after failure on prior line of therapy. This is the clinical global development of nanoalcoholic, where there are the 2 dosages compared with Taxotere at 100 milligram per meter square. That is the standard dose used for breast cancer. Clinical development. So most of the, I think, approvals, they suggest DGCI for head and neck cancer, for non-small cell lung cancer has been completed. For prostate cancer, I think it is still recruiting, and also for gastric adenocarcinoma, it is recruiting. Again, for non-small cell lung cancer with platinum-based therapy, there is a comparative study where you have 75 milligram per meter square of nanoalcoholic versus 100 milligram per meter square of nanoalcoholic. This is the trial design, demographics of the study, and the response rates. So almost comparable to the standard line of conventional docetaxel. PFS at 12 months. More importantly, when you look at this drug and compare it to the conventional one is concerned about the side effect profile, which I don't see much of grade 3 on either sides. So safety wise, yes, almost equal. Again, the same drug in head and neck cancer, where we use it in inoperable setting for NSCT, neoadjuvant chemotherapy, and here again the demographics and the results are almost matching to the conventional one. Then comes the one for the castrate-resistant prostate cancer. 24 patients with castrate-resistant ones were given, and 2-weekly regime versus 3-weekly regime. And these were the demographics. 2-weekly versus 3-weekly again. And this is the response of PSA to the therapy. PSA declining more than 50% was seen in 77% of the cases in the 2-weekly arm versus 60% cases in the 3-weekly arm. Safety profile, again, very, very important, grade 3, grade 4 side effects, hardly any seen, 2 patients. That 2 was neutropenia and diarrhea, which yes, we sometimes tend to see with docetaxel. So to conclude on this drug, serious adverse reactions like hypersensitivity are common with docetaxel, though around 5%. To avoid this, we use corticosteroids as a pre-medication. Steroid can worsen hyperglycemia and increase infections. For this, there is a solution to use non-alcoholic docetaxel, which is free from solvents and can be administered without steroids. No grade 3, grade 4 hypersensitivity reaction observed despite no pre-medication. Thank you. Thank you all.
Thank you, Dr. Preetham Kalaskar. Are we ready with the... are we? Okay. So we now have a case-based discussion, and I invite Dr. Tejinder Singh as moderator. And I request as panelists Dr. Akshay Shivchand, Dr. Shivam Shingla, Dr. Udip Maheshwari, Dr. Amit Joshi, and Dr. Preetham Kalaskar. I've already introduced, but for those who were not present in the hall, Dr. Akshay Shivchand is a consultant medical oncologist at MOC Kolhapur. Dr. Shivam Shingla is a medical oncologist at SL Raheja Hospital, Mumbai. Dr. Udip Maheshwari is a consultant medical oncologist at MOC at Kemp's Corner. Dr. Amit Joshi is a consultant medical oncologist at MOC Borivali. Dr. Preetham Kalaskar, consultant medical oncologist, MOC Thane. I hand over to you, sir.
Thank you. Thank you to the organizers. Preetham has given a very nice description about how do we use, where we use this particular drug called Ɂagship. So we'll just do one small case-based discussion, then we'll take the topic for further discussion. I think we have one more. Devendra is there. So a 65-year-old male, untreated diabetic, presented with severe back pain in August 2020, evaluated and diagnosed with CA prostate. Gleason was 8, 4+4, and the PSA was 400. And he had at that time done only FDG PET, which showed multiple bony mets. So this is a case of hormone-sensitive prostate cancer. High Gleason, PSA of 400. We'll start with Preetham. No. So I'll just give you only bony mets, no lymph nodes, only bony mets with a high PSA. Multiple bony mets, not in the critical sites.
Yes, if it's multiple bony mets, 65 high Gleason probably seems to be in the high risk criteria.
Okay.
Here, I would definitely like to offer him androgen deprivation plus chemotherapy arm in the form of docetaxel for 6 cycles.
Okay, we'll take up that question later on. Now, Shivam, ADT, how to choose? This guy, you are more willing to go ahead with the orchidectomy? No, sir. I don't prefer orchidectomy. So you're the odd one out or the common one?
I think, how do we fight from urologist?
Okay.
I think ADT is our way forward.
So urologists are nowadays writing more ADT than you.
I know. I hope they stop doing orchidectomy. Sir, I think I would use antagonist in this case, for an immediate response, and also look at giving RT because he has severe back pain to this patient at the time of initiation of ADT. Also, oral tablets, either Enza or abiraterone.
Udip, what is your take on this role of radiation here?
So if the patient has severe back pain and MRI is suggestive of nerve compression, then definitely yes, a radiation, parallel radiation to that. An MRI would be essential. That is what I think. And based on the ADT, I think yes, obviously an antagonist is the way to go. But still, with the finances being an issue, an orchidectomy is the simple way forward in patients who do not want a lot of hassle and a lot of follow-ups. So I usually go with an antagonist first, initially for at least first 3 months. And then if cost is an issue, then I go to agonist.
Cost will become an issue after 3 months.
Yeah, yes, absolutely.
Dr. Pal?
Hello.
there are some group of patients in which I specifically opt for antagonist, like those patients with elderly patients.
Yeah, because there are some specific criteria for putting the antagonist.
Cardiovascular risks are there, then obviously. And when we don't want any hormonal effect,
So
enhancement
this
of
patient doesn't have any impending fracture.
Yeah.
So there's no impending spinal cord compression. I'm going on giving masala to you that no spinal cord impending fracture.
Yes.
Diabetic patient, pain in the back, normal situation. Will you go for RT or you will wait for it?
RT, if for pain relief, obviously RT will be required. But if it is like if pain is not there and there's no impending vertebral collapse, then RT will not be giving. We'll be giving obviously ADT will be starting on day 1. Radiation is just a part of it, like a part of the treatment. So if you are asking about the type of ADT which I will use, so options for ADT are antagonist and GNH agonist. And antagonists I specifically prefer for those patients who are at high cardiovascular risk. So otherwise, we can use GNH analogs also, along with bicalutamide to begin with. And they are costly and patient need not visit the hospital frequently. And the subcutaneous injection of antagonist, so that is also having a lot of local adverse effects. So, and GNH analog is like, does not have those adverse effects. So if patient is having definitely cardiovascular high risk, then obviously the first choice will be antagonist. Otherwise, GNH analogs is also good enough. Radiation only if painful site is there. And chemotherapy depending, because it's high risk, so chemotherapy will have to be added.
Fine. So, anyone else? No, I have forgotten your name.
I'm Dr. Akshay from Kolhapur.
Akshay, just tell me.
Yeah, actually, can I just get the
I'll just
idea
give you,
about the case?
yeah, 65-year-old, untreated diabetic, recently diagnosed severe back pain, PET scan showing only bony mets, no other mets anywhere else. Gleason is high and PSA is on the higher side.
So actually, where
no signs of spinal cord compression, no cardiovascular issues, EF is normal.
Okay. So actually, where I practice is the area where the sequencing of ADT can be a different issue. Like I'll prefer bilateral orchidectomy, followed by LHRH agonist 3 monthly injections, followed by LHRH antagonist. As per the literature, data antagonist is preferred, as Dr. Pal has rightly mentioned regarding cardiovascular risk factors. Also, there is an issue with the Degarelix, the subcutaneous reaction, and patient has to take every month the injection. Sometimes patient himself prefer over all these for the orchidectomy. As far as RT is considered, as patient is not having any impending cord compression, and over a period of time when we start the therapy, at least after ADT also, some patient they might get relieved of the pain factor that patient is having with the bony metastasis. It's a hormone dependent disease, so they do have a very good response. And after adding chemotherapy or a hormonal therapy, a patient they do respond very well, and we might get away without radiation to the bony disease.
I think that's very valid point. We normally go for antagonist only in certain situation where we are looking at impending spinal cord compression. One area I felt the ADT has worked very well, especially is urinary symptoms. Those who are having obstructive symptoms, the ADT works very well. I do not know, only one thing I know is that when you start on an ADT, within 3 to 4 days, the pain subsides. So many times we don't ultimately go for radiation. Right, Amit, Vasisht, your experience? Really patient have gone for radiation, or you feel they are, with ADT things improve a lot? And and the antagonist, you keep it for a reserved group of people, or you give it?
I believe prostate almost melts like pure lymphoma with good hormonal manipulation. So rarely used radiation as a salve.
Yeah, I think that is what I just wanted to just talk about the ADT. Antagonists, I normally reserve it with what Dr. Pal said was cardiovascular risk. Basically, how to define that cardiovascular risk is a very tricky topic. And flare is something we should be more aware when you are going for agonist. Flare, normally we tend to not see it, but yes, it can happen.
When you are starting bicalutamide along with your analogs, starting bicalutamide first and then adding.
Ideally you have to start
the flare
before.
is usually not there.
So flare, I do not know how many of you have seen flare, but in an impending cord, no, the advantage of giving antagonists is that you don't require to worry about the flare.
Yeah, that's true.
Absolutely.
So that's the only, but that is basically, if you see the initial indication for degarelix came only for impending cord compression, not for everyone.
Absolutely.
Yeah.
So now, I'll just also need to point out that, cardiovascular events, the hypothesis of the, how leuprolide causes more cardiovascular events as opposed to degarelix is that it can cause plaque destabilization.
Right.
Agonist, and that is the hypothesis that is there. And suppose if a patient who has no cardiovascular events in the past, he may have a plaque or there may be something that may be precipitated. And the data also says that there are 30% prostate cancer deaths are not related to prostate cancer.
Right.
They are because of this. So we should prefer, wherever possible, we should prefer antagonist, but I think rest all points hold.
Like I said, the initial indication for antagonist was only two things. One is to avoid the flare because you don't have time for the impending cord compression.
Absolutely.
And second was basically for the...
Also rapidity of response. So
no, it's very rapid. The only problem which lies is that the monthly dose. Now, Pritam, 3 monthly agonist.
I prefer...
If you see the literature, they will prefer going for monthly, not 3 monthly classically.
I prefer in metastatic setting orchidectomy. So what I usually do is, in the consultation, I offer them a first dose of degarelix, most of the patient, so that they buy time on taking a decision on orchidectomy. If at all there is some impending issue or some symptoms like this, they improve over ADT. And if they don't opt for a monthly degarelix later on or don't go for orchidectomy, then I shift them later on to leuprolide, 3 monthly.
Right. So any preference for any particular GnRH agonist, or you feel almost all of them are same?
I think the data is almost all are same.
Yeah, almost all are same. Only thing is that there is a data for shifting from the antagonist to agonist also. There is a data also because, but the robust data is always to continue with the antagonist, not to change from antagonist to agonist. Like that.
The shift is only for the matter of convenience.
It's basically, so I will just say that one reason why we have data from antagonist to agonist is for our own convenience, just to say that the safety is same, it doesn't change. But flare is important thing to understand when we are discussing with such kind of severe pain, highly symptomatic patient, impending fracture. That's the reason why in order to avoid the flare, the antagonists have come in place. Now, Pritam will start with this HRR. Do you do in this patient HRR testing? I'm not talking about BRCA1, only I'm talking about HRR.
From
65, recently diagnosed, hormone sensitive.
From a germline point of view,
yeah,
I nowadays offer germline counseling to all the patients, irrespective of the age, whether it is prostate, breast, ovary.
No, I'm talking about
from this point, yes, I would offer
so
the patient.
Urologists will start treating the breast also. I think we'll stick to uro only.
Yes, so I would definitely offer the patient genetic counseling part and a germline mutation for BRCA part, and also I'll do a HRR on the tissue. For this
Good
patient.
question. Now, Shivam, 2 questions here. One is the HRR tissue or liquid, or whether you will, in a hormone sensitive, you will avoid or you will do it.
HRR tissue immediately because the tissue is fresh and the chances of it coming positive are higher. Experience, most of them are negative. Okay. I'm yet to receive a positive.
Udip?
I have done BRCA1, BRCA2 in young prostate cancers, like less than 60 years, but not done HRR. Recently, last 2 days, we've been reading a lot on this.
It's free of cost right now. That's the reason I'm doing a lot.
That's in ovary, right?
No, prostate it is free of cost.
Okay. Okay. So I will probably now counsel my patients for HR because it offers a different avenue for treatment. I would definitely love to explore it.
Devendra?
Till now advising only BRCA1, BRCA2 testing.
Okay. Why I'm telling, because HRR nowadays companies are providing free of cost. I have my own experience, that's why I'll share it to you.
For the same reason as you have mentioned, I have done it in 2 patients, HRR testing, but it did not yield to the treatment part. But yes, nowadays HRR testing, it's a lot of coming in HRR. We can offer for the later lines of the therapy. So yes, we can go for HRR on the tissue, but for my experience, 2 patients, it's negative.
Yeah. So I think the initial thinking was to do germline testing only for people who are CRPC. But I think if you see the NCCN guideline, they have gone up to the very high risk also. That's a different thing. Practically, in our clinical practice, we do normally for a metastatic setting, we don't do it for the CRPC. Utilization in a hormone-sensitive prostate cancer, doing a HRR testing it is only for our own convenience because the tissue sample is there. That's the reason. Otherwise, how much it is going to impact on the treatment, nobody knows. Because if you see the role of PARP inhibitors, they are not very strong. Now, there is a data that Profound has given a very nice data about looking at the tissue. Best tissue is always the lymph node, if suppose you get it. But those were all CRPC patients. But prostatic tissue is the one which is most common. Any tissue which is more than 3 years, probability of finding a mutation is less. Remember one thing, ctDNA has done remarkably well in HRR, in prostate. You talk to the lab, good lab, MedGenome and Core, they have excellent data. Nowadays, the companies are doing tissue and liquid together for every patient. I have 10 patients of mine in the last 6 months, 2 have come positive. One BRCA1 positive, another is CHEK2 positive. And both were amenable for PARP inhibitor, and both of are young, less than 60. Around 1 month back, I saw one more patient, 55-year-old, lymphangitis carcinomatosis with prostate enlarged, multiple bony mets, adenocarcinoma, Gleason 8, PSA 850, HRR has come positive there. So I feel that, this is an experience from my side. If you till the company is giving us free, I think like the HRD, I will talk to you. In an ovary, I never used to rely so much on HRD, but I have now 5 patients who are BRCA germline negative and HRD positive.
That is true, but for HRR in prostate, are there treatment implications?
Are there?
Are there treatment implications for prostate?
Mainly for the CRPC.
Yes.
In CRPC.
Mainly for the CRPC. That's the reason I've been telling going on HSPC. This is a HSPC. It is for our own convenience we do, but yes, if you see the literature NCCN, they talk about even a very high risk to do it, the germline test.
So the HRD positivity in ovary is somewhere around 10. So anybody can help me with the number in prostate?
So prostate, my own experience has been around, out of 10, 2 has come positive, which is very high, but overall they are telling around 5 to 10%.
Same, I would
say. Yeah,
Same.
but HRR, not the BRCA 1 and 2.
So the foreign data, the data outside, where they presented in magnitude trial was around 30% of HRR positivity.
Profound basically had given a very high data.
Yeah. So
Profound basically has given a very high data. So I think another question which I think everyone wants. In this HSPC patient, do you add chemo or you add novel hormonal agents? Udip?
I would have gone with enzalutamide.
Enzalutamide.
Yeah.
Why?
So one is he's diabetic. We don't need to add Visalon in that. And the responses that I have had with enzalutamide are fantastic. And I feel the multiple mechanism of actions do help there. And the data with Enza plus ADT is very good. So I usually add Enza and then leave docetaxel for the next line.
Yeah.
It's more convenient.
Yeah, Akshay.
So still I have not changed my practice to Enza yet. Still in high volume, high risk, very high volume, high risk, I still prefer docetaxel because of quick response.
No, this is not a high risk. This is not high volume. That's the reason I have put up the definition of high volume is totally different. So why I had told you this is more of a low volume disease. So it is, so question about his chartered trial basically had given us some basic indication where you have to use chemotherapy or not. That's a different thing, The problem happens in a high risk, you try to use docetaxel, you are left with very less agents in the second line. So I think most of us do add NHA, like what Udip said, enzalutamide is quite safe in a diabetic, untreated, uncontrolled patient along with the ADT. That's a different thing, what kind of ADT we choose. We already had a discussion about ADT in this patient. So this patient was treated with LHRH agonist and bicalutamide, and PSA after 3 months was quite remarkable. Around it came down from 400 to 9. A reassessment after 1 year, because he started complaining of back pain. So PSMA was done, which showed that there was an increase in the bony lesion. You can see bony lesion all over the body. This is a common scenario we see in our clinical practice. And now question came has that the PSA has gone up from 400 to 900. He has achieved, basically, he's now CRPC. So Pritam, what is the thing? He has been already treated with enzalutamide for 1 year.
Yeah, obviously, docetaxel would be my first choice of therapy. And whether his HR was HRR has been negative. Docetaxel, 2 weekly, I would be comfortable.
Okay, fine. Shivam?
Docetaxel 2 weekly, very well tolerated.
Very well tolerated. So this patient was given docetaxel, 3 weekly dose along with denosumab and daycare, which was previously given over there, and continued on that. And then he developed a very bad anaphylactic reaction. Remember, this case is made up for this discussion only, so don't go here and there.
So if I may ask in between, if this was HRD positive, HRR positive, sorry.
HRD, we don't do it in prostate.
Yeah, it is. So HRR positive, then would somebody add platin to it?
That's a question you do not have any answer right now because there's no data, strong data about it. But I think giving justification here, I will say right now there is one trial which is going on trying to add the platinum, but the volume is numbers are very less to really give an answer. But guidelines do not recommend giving platinum to it. So proper discussion here, anaphylactic reaction secondary to docetaxel, very bad bronchospasm, hypotension, skin reaction. So Dr. Pal, what is the thing? What you will do?
Dosi-Aqualip.
You will give Dosi-Aqualip. So that is what I was asking. Whether you will change to cabazitaxel, whether you will change to NHA, or you will go for Aqualip.
Because anaphylactic reaction to Dosi-Aqualip are...
I am just asking one simple question. You know, Pacali is fine. With Dosi, have you seen this kind of very bad reaction?
No.
I have seen,
sir. I have seen.
I have seen a mortality with docetaxel.
Mortality
with hypersensitivity.
There are definitely, sir, patients which have docetaxel-induced severe hypersensitivity, severe back pain, and anaphylactic.
Pacali you will get extremely worse than this.
Yes. Pacali will get, yes. So if 10 patients in Pacali, 2 patients in Dosi, for sure. Pacali is obviously more. But we have definitely seen docetaxel reactions. And the question of cabazitaxel, I think cabazitaxel is, when docetaxel is resistant, that is when it works. Probably the mechanism of PGP where it is not.
So you have no other choice.
But then the data of cabazitaxel, if you see the data in first line.
Remember one thing, cabazitaxel is very poor drug. Why poor drug? For one simple reason, because same company made docetaxel, same company made cabazitaxel. So they have, it's like axitinib, always comes in the second line. Axitinib never came in the first line.
No, so the data was done for cabazitaxel in the first line. It did not show a survival advantage. That is why they then put a hypothesis that there is a resistance mechanism to docetaxel. If that happens, then only cabazitaxel works. That is what we conventionally learned.
So here the scenario is because of the reaction. That's the reason I'm asking.
I think Dosi-Aqualip, I have used it in fair amount of patients. It does not cause a lot of side effects. Even there was recently I had used it in breast where docetaxel, severe reaction where docetaxel could not breathe, had to be shifted to ICU. Next line, Dosi-Aqualip patient was happy, finished three more sessions of that and had no reaction whatsoever with that. So very comfortable.
So I think Aqualips do have a proper role. Akshay, 2 weekly, 3 weekly, you feel any difference or it is just
actually
going from 50 to 75 and whatever?
So actually I prefer to use in 3 weekly regimen if patient is fit enough to tolerate 3 weekly docetaxel. If patient's PS is borderline, I'll rather prefer weekly docetaxel rather than 2 weekly.
Yeah, Dr. Pal, weekly. Big question he's asking.
For patients with
honestly, there is no data for weekly. But in our practice, many of us have done weekly also, but in an unfit patient. But that's
patient with good performance status, obviously I prefer 3 weekly. Borderline 2 weekly. I have never used once weekly.
2 weekly you have never used. There's a strong data for 2 weekly. If you see the
I use 2 weekly in most
I think
of the patients.
prostate trial was there, which is giving Okay, now
50 milligrams.
almost same equal importance to 2 weekly as compared to 3 weekly. But I think almost many of us are using 2 weekly. So that's something. Preetham, most troublesome problems when you use conventional, leave the anaphylactic reaction.
Body ache and neutropenia.
Neutropenia. Diarrhea, GI symptoms?
Yes, diarrhea sometimes. Body ache is something first I rate. Second is neutropenia, which is
So
manageable.
body pain is more of fatigue, I'll call it. It's not classically body pain, it's more of fatigue.
Fatigue, diarrhea, and neutropenia. These are the 3 things I face.
Okay. I feel neutropenia is slightly less, but still, anyway.
So
Uncommon toxicity.
So many a times we miss, skin toxicity in docetaxel. So there is
very good.
A lot of patients who have dry skins, absolutely dry, scaly skins. That is what I see a lot commonly, and I've now, as routinely, I've started to prescribe an intense moisturizing cream along with docetaxel, which really helps them, and that keeps the skin.
So I have a patient with onycholysis with docetaxel. So there's a peeling of nails.
But that is a known common toxicity. If you ask me about that, the part about the skin, not the skin, nail changes, is very common with the patients who have been on long-term docetaxel.
The paronychia
and even with paclitaxel also it can happen, especially with a weekly dose. It is very. I had to stop one patient's chemotherapy only because on the 8th cycle CA breast patient because there was severe nail coming out. Almost all the nails had come out like that.
The paronychia is sometimes very painful.
Very painful also.
And one of the very rare toxicity of docetaxel is chronic lung disease. So I lost 2 patients of on docetaxel who developed chronic lung disease, and it didn't reverse.
Yeah, but I think one more thing which we should not forget: diarrhea is also very common. Huh? Yeah. Especially when you're using a TPF regimen for a head and neck diarrhea, you try to see it is related to 5-FU. It is not classically 5-FU induced. It is docetaxel induced. And this is Shivam, right? Diarrhea you're feeling is it's a very troublesome, different kind of diarrhea, which is
3 weekly diarrhea. Water retention also I feel some patients
very
have.
common, fluid retention.
Fluid retention, so diarrhea and fluid retention.
So do you commonly give steroid pre-post classical 3 days, all of you,
post,
or avoid
post
it?
for 2 days.
Pre-post both.
Pre-post.
3 days, 4 mg twice a day.
Devinder, so much you have to counsel when you have to give.
I don't give actually. I don't give because I have not seen troublesome edemas with docetaxel. Especially those patients who are diabetic, I will not use steroids.
For edema, I usually don't prescribe. Yes, if the patient is developing, then I prescribe.
Even I do the same thing. Amit, you feel, I think we are mostly overusing. My student is now doing a trial on Pacli, on a Pacli, whether to really pre-medicate with so much of steroid, 12 grams, 16 grams. So we are doing a trial on 8 milligram. Vanita has also done a trial. But giving so much of, if you see clinical practice, I feel what Preetham and Devinder is, I feel somehow it's an experience which I also have, that we trying to avoid it only when it is, retention happens to do it.
In prostate cancer, when you're using docetaxel with prednisolone, so I don't use steroids at all.
Yeah, that's what. Most of the time, I think it is really not required. At least in this. But even in general, like in breast or something?
So if in breast, if we are using conventional docetaxel, then I use 4 mg BD of dexamethasone 1 day prior and on the day of chemo. I don't use post.
Okay, right.
So then I reduce
Counseling 1 day prior is something which is a big headache many times, Half the time our things are all done by the phone only, WhatsApp. So how many really Preetham will require for this? Because do you give equally for everyone or you pre-select or some reaction happens then you go for it?
See, I counsel all patients about the reaction possibility. I tell them it is not very high. I would say less than 5%.
Because the cost is something which is an issue overall, whatever said and done.
Yeah, I tell them that this is what conventionally we do for all 95 to 97% of the patient. 3% patient might have a reaction and sometimes it can be serious. And the cost is almost 3 times. So if you're okay with that, go for it. Avoid the reaction altogether.
Right.
I would say most of the patients go with the conventional one. There are few handful of patients who opt for कि नहीं कुछ भी reaction नहीं चाहिए. That is how I counsel them.
Right.
But most of them, I think they go ahead with the conventional one only.
Conventional one. So fraction, Udip is from the prime area, so at least you will have more.
No, so I think
fractions
it's good to have an option wherein a patient who has docetaxel toxicity, it's obviously very, it's good to have that dosi-aqualib option. It's very easy for us to tell them that, the reaction is there, and I counsel all my patients for both. And initially, most of them will choose, as Dr. Preetham said, docetaxel, but there are certain few who would definitely not want anything to happen. In fact, IVB नहीं लगना चाहिए उतना चाहिए मतलब that is how particular certain patients could be, and probably those patients are very fit for this.
Akshay, your experience with Ecolib?
I have used in quite a few patients where the patient, as now everyone is said that they are not prescribing dexamethasone, but for the diabetic patients where the sugars are uncontrolled, where we can have these options of nanosomal docetaxel, dosi-aqualib, where we will get away with the pre-medication.
Somehow, and somehow whatever you said, and then Ecolib, whoever is used it, still they'll add 4 milligram dexa as a pre-medication. You're the only one who is not. I am adding still 4 milligram. It's not ideally part of it, but somehow I add. Yeah, but I think
last 1 minute.
Yeah, I think somewhere down the line, I feel Ecolibs have changed the way we look into it. Only thing is the cost is an issue which is making us use it. I think the dosi-aqualib is also a good formulation. I have seen less amount of fluid retention with it. And diarrhea part, which I used to have a lot of trouble, has come down a lot with the dosi-aqualib.
Fluid retention was obviously because of 2-in-80. So I think...
Yeah, PEG is a culprit there. It's a PEG which is a culprit. Anyway, this patient responded very well to dosi-aqualib. This is the scenario of this patient. And I will not go too much into data which Preetham has already presented. This was paper which was presented by Preetham looking at the safety, even though the data is very small. Remember, the company people have formulated that we need not change the dose of whatever formulation. It is the solvent preparation only we are changing. So ideally the dose doesn't change like we see in the taxane areas, especially that. So I think this Preetham has already presented. There was one more paper where they have used bi-weekly dosimetry for beyond 20 cycles and with not too much of safety concerns, a well-tolerated drug. And I think we are more happy with the 2-weekly for it. So thank you everyone.
Thank you, Dr. Tejinder Singh, and all the panelists for this excellent case-based discussion.
Dr. Tejinder, Basade sir wants to have some inputs.
Yes, after your photo. Okay, after your smile. Tejinder, I just want to add, there was a comment that cabazitaxel first line versus docetaxel. If you look at the First-ANA trial, what the First-ANA trial did, that they compared 2 doses of the cabazitaxel, 20 and 25 versus 75 of the docetaxel. It was, people thought cabazitaxel will be better than the docetaxel, but it was equivalent. So you can't say that cabazitaxel should be used in second line.
Yeah, so I think it is, that's why I'm telling you.
OS is good. Yeah, let me. OS is equivalent, but those patients who cannot receive docetaxel can be given cabazitaxel in first line. It is least toxic compared to docetaxel. Same somebody has neuropathy, like your patient has.
But somewhere cabazitaxel neuropathy is more severe, I feel.
But the dose 20 milligram per meter square has shown less toxicity as compared to, even in the first-ANA trial, the toxicity is less. You have an equivalent survival. So there is cabazitaxel, we unfortunately don't use much because it has not been promoted properly, but it is equivalent to the docetaxel in first line.
Agreed. Even I feel that it has never been promoted quite in an extensive way because of the same company which is making both the drugs, nothing else. Thank you, sir.
Thank you very much. We now move on to the last session of the day, which has been sponsored by Roche, and it is the role of immuno-oncotherapy in the management of urothelial cancers. It's a discussion, and I would like to call upon Dr. B.K. Smriti ma'am, who's a senior medical oncologist at Leelavati Hospital, to moderate this session. I also invite Dr. Mahbub Basade, who's a senior consultant medical oncologist at Jaslok Hospital, as a chairperson. And I invite as panelist Dr. Ashish Joshi, who is a Senior Consultant Medical Oncologist at MOC Borivali, Dr. Mangesh Mekha, Consultant Medical Oncologist, MOC Pune, Akshay Shivchand, who is a Consultant Medical Oncologist at MOC Kolhapur, Dr. Indu Ambulkar, Consultant Medical Oncologist at HCG Mumbai, Dr. Shivam Shingla, who is a Medical Oncologist at SL Raheja Hospital, Mumbai. I hand over the session to you, ma'am.
I'd like to thank Roche and the organizers, MOC, for inviting me to moderate this session. So you know that over the last few years, the landscape of treatment of metastatic urothelial carcinoma has undergone a revolutionary change, just as the renal cell carcinoma. And today we are going to, of course, first introductory with the chemotherapy and then move on to how you would use the immune checkpoint inhibitors in the metastatic urothelial carcinomas. So let's start with actually the slide. How do I move this? Can you? How can I move the slide? Yeah. Okay. Yeah. Yeah. So we come to the first case. He is a 74-year-old man who is an ex-smoker with no comorbidities, with a performance status 1, and with multiple growths in the urinary bladder on various walls of the urinary bladder. And the TURBT showed a high-grade invasive urothelial carcinoma, and it's involving the muscularis propria. And the PET scan shows the pelvic nodes, mediastinal, and multiple lung mets. The hemoglobin is 13, creatinine is 0.7, the creatinine clearance is 75, and the ejection fraction is 66%. So you have a high-grade metastatic urothelial carcinoma with a performance status 1 and normal renal function and normal cardiac function, no comorbidities. So coming to the first question, and that is, what are the first-line therapeutic options for this patient? So can we begin with Ashish Joshi and then?
Yeah, so I think from all the trappings that you presented, madam, looks like cisplatin eligibility is there because you got good creat clearance with a fairly good ejection fraction. Maybe the audiometry is something that maybe one would like to perform. And if it's cisplatin eligible, then one would wish to go for cisplatin plus gemcitabine combination. But one may split the dose. Cisplatin maybe for an elderly patient, I tend to give it on day 1, day 8 schedule. Yeah. So that the toxicity is better and we can monitor, and then probably cisplatin plus gemcitabine combination would still remain the first line therapeutic option for this patient.
So just coming to Dr. Akshay, that what are your criteria for cisplatinum ineligible? So can you tell us?
And those patients whose creatinine clearance is less than 50 ml per hour, and also in audiometry they have a conductive hearing loss, plus the ejection fraction is something less than 50% or having any cardiac comorbidity. So these are the set of patients who make them cisplatin ineligible for the, as far as bladder cancer is concerned, or any malignancy is considered.
Yeah. So what about the KPS score? Because in the trials, both the trials, they did also ineligible was based on KPS score. So do you really consider that in your eligibility criteria or ineligibility criteria? Because sometimes it can be very subjective, and sometimes it may be cancer related, and patients may improve after you treat them. So what would be your approach if everything else was okay, but the KPS score was below 80?
So I think what I clinically do is the fall risk, which will indirectly assess some amount of neuropathy which the patient would have. And the cognitive dysfunction. These are the two parameters on which eventually KPS can linger. But clinically, I don't usually use KPS in my practice. It's the performance status and all the 4 parameters which just mentioned would dictate the decision.
Dr. Shivam?
I agree with Dr. Ashish. KPS in Indian population is very subjective, very difficult to identify. Especially most of these patients need motivation that also leads to an improvement in a KPS score. Starting treatment
So it's a very subjective thing. I'm reserving cisplatin only to performance status 0 and 1 in my practice, ma'am. I am not giving it to performance status 2 and above. And this is an army man. I think the first line of option will be gemcitabine cisplatin.
Yeah. So, and what about peripheral neuropathy? Because that's the other, so that's again very subjective. So how do you approach that factor?
So I do assess patients for peripheral neuropathy upfront, and in a metastatic setting, if they have severe peripheral neuropathy, then avoid platinums. I tell them the events which are likely to happen.
So now you think that is cisplatinum eligible. So now what are the options, therapeutic chemotherapy options that you have, and then
for an ineligible patient, ma'am.
For eligible patient.
For eligible, gemcitabine cisplatin is my first option.
Yeah.
That's what I'm using.
So do you ever use MVAC now? I mean,
no, ma'am. I haven't used.
What about? I mean, this is a metastatic setting. So, and this is a 74-year-old. So you're very right. You're going to use a gemcis. Or so, what is your idea? Where do you at all use MVAC today?
I've used only in one patient, ma'am. He was a fit young patient in a neoadjuvant setting, but patient could not tolerate well. So I really don't have a good experience with an MVAC.
So, we have, because we didn't have the trial when we started medical oncology, we didn't have the trial of gemcis versus MVAC. But I know it was very toxic. Of course, in the neoadjuvant setting, MVAC is supposed to have more pathologic complete responses as opposed to gemcis, but then the toxicity is very high.
It's very difficult post bladder removal. Even they don't tolerate gemcitabine cisplatin.
Correct.
I'm rarely able to complete my regimen.
No, I'm talking neoadjuvant.
So you have to continue that post surgery. It's impossible for us.
And second is
especially the second day of the day 2 of MVAC, which has adrimycin. That post that it becomes tough.
Yeah.
For a weak patient, it's completely knocked.
Right. And what about addition of paclitaxel? So what about the PCB regimen?
So the triple drug regimen, there was a trial and it did show, I think, slight improvement in a clinically non-significant survival benefit. So, no, for my clinical practice, no.
Any of you?
No, madam. No. It added toxicity more than a survival.
Yeah. So, although the response rates of PCB and MVAC are better than gemcite and cisplatinum, but the toxicity would, eventually cancel that out. So your choice would be, of course, gemcis. Now, what is your idea about using carboplatin? Because definitely inferior results to cisplatinum. So what is your take on that?
So I think for the neoadjuvant setting, there is no carboplatin at all. So if you're not eligible, then might as well explore other options or go for surgery. For a cisplatin ineligible patient, carbogemcitabine continues to remain one of the options. That's where I think the discussion about ICI will come.
Yes. So I want to know, like, you've seen this patient, you know what you're going to go for, but just to enumerate, before we come to the slides which enumerate the therapeutic options, so what are all the therapeutic options that go through your mind? Forget the eligibility. I'm just talking of, then you do the selection. So what are the all the therapeutic options that go through your mind?
Carboplatin, gemcitabine. If cisplatin eligible, cisplatin, gemcitabine. In stage 4, if it is ineligible, carboplatin, gemcitabine. Single agent gemcitabine can be option. Single agent taxane. Then we have ICA coming like pembrolizumab, atezolizumab.
Yeah. What about you, doctor?
Ma'am, same thing. MVAC, gemcitabine, paclitaxel. These are the standard options. Nothing much is there in urothelial cancer.
So now we come to the question that how do you select? So you have mentioned the ICIs also and the chemotherapy options. So how do you go about selecting between these two? So where do you use the ICIs as opposed to chemotherapy in these patients?
So, ma'am, in a single agent, platinum ineligible patients, we can offer them a single agent IO. That is atezolizumab. After I do an IC score on them, I'm doing SP142 for majority of these patients and offering them to IC 2 and 3. In a second line setting, pembrolizumab can be offered as a single agent to these patients. I have not yet combined both regimens, chemo and IO combination. I don't think there's any good data behind it. So single agents based upon the setting that they are being offered.
How about you?
So there are 3 sets of patients which will emerge. One is platinum eligible. Second one is cisplatin ineligible but carboplatin eligible. And third will be completely platinum ineligible. And so platinum ineligible patients, obviously, there is 2 drugs which are approved. One is pembrolizumab and second one is atezolizumab. For a second group, which is cisplatin ineligible but carboplatin eligible, that's where you have an option of atezolizumab versus carboplatin gemcitabine. And the approval is for atezolizumab with a CPS score of more than 5%. So that is where we stand. But in my clinical practice, I tend to use carboplatin gemcitabine for a cisplatin ineligible but platinum eligible patient. And if both of them are ineligible, then straight away go for ICI.
Yeah. So that is the right way. So I think we have elucidated all the options and then when to use which option, which is very important. Now, so we have already addressed this question. So all of you have gone for gemcite cisplatinum in this patient and a very valid option considering that his performance status, his renal functions, ejection fraction and no comorbidities. Then, of course, which is the preferred regime. So that also we have gone over. And as you mentioned that you would still go for GemCis, you may divide the cisplatinum between day 1 and day 8. And definitely MVAC and PCG, although better response rates would be out considering the toxicities, added toxicities. And you have clearly mentioned what is the role of carboplatin. So I think all this thing about the chemo regimes is covered, and this is just a slide to summarize that. As you can see, the overall survival is almost the same when you look at MVAC, GemCis, and PCB. So hardly 1 or 2 months difference. Of course, you can't do cross-trial comparisons, but just to get a hang of what is happening. So the second case is a patient, same patient, but if he had diabetes and diabetic nephropathy with a creatinine of 1.9 and a creatinine clearance of 35 ml, then we have already answered the question of ineligibility. So where would you put this patient now with these particular parameters that you have as shown in this slide? So what would you call this patient?
He is cisplatin ineligible, man.
Ineligible.
Ineligible.
Yeah, yeah. So then if he is cisplatinum ineligible, so what is the preferred regimen and why?
So madam, carboplatin gemcitabine still continues to remain as one of the options.
In this patient? Cisplatinum?
No, carboplatin.
Carbo, yeah.
Cisplatin, he is cisplatin ineligible. So
Yes.
gemcitabine, carboplatin continues to remain as one of the options. But here is the place for atezolizumab.
Yeah. What about you, Dr. Shivam?
I would use in my practice gemcitabine carboplatin, but would also discuss the role of atezolizumab with my patient because now we have some data that single agent atezo can be used in such patients.
So, you have the Imvigor 210 and then you have the Keynote 052. So you have 2 drugs now approved in this patient population, ineligible. So would you directly go for one of these 2 or you do some test prior to that?
So, ma'am, as far as Pembro is concerned, we can use in both the settings. Atezo, I am doing SP142 because patients are asking for a biomarker. So I am using that as of now or any other.
What about you?
So for a completely platinum ineligible patient, there is no PDL1. We can use either.
That's chemotherapy ineligible.
That is chemotherapy ineligible.
Because I'll tell you, after the introduction of PCB, they have also advocated that if is platinum totally ineligible, you could use gemcite and paclitaxel as one of the options. So, which is a non-platinum. But now we are talking of chemotherapy totally ineligible.
So then, madam, atezolizumab, pembrolizumab both remains an option and they do not require PDL1.
Yes. So when do you do the PDL1 testing?
Typically nowadays with these newer guidelines and approvals which have come, my concept of doing PDL1 in bladder cancer in first line, who's anyways not a chemotherapy candidate, I don't do it.
But what about those where you have an option of chemotherapy but is cisplatinum ineligible? Because we have to address the guidelines. So, Dr. Shivam, would you do PDL1 testing in metastatic urothelial cancer and in which setting?
Ma'am, only if I am not thinking about chemotherapy at all, I would,
Yeah, no, I mean, it's like this. If they're cisplatinum ineligible, but they can receive chemotherapy.
So
there
yeah.
may be carboplatin.
So in that
then
case,
you would do it.
It will, help me making a decision whether there are probability of the drug being effective. And this is what patients are asking, most of us.
See, I'll tell you the reason why. Because when both these studies came out, it did show that overall there was a benefit. So they said they didn't insist on the PD-L1 testing. But further analysis of both these studies clearly showed that those who had, for example, IC less than 5% as far as atezolizumab is concerned, or the CPS less than 10% as far as pembrolizumab is concerned, in those patients, the chemotherapy was actually better than the immunotherapy. So it was actually detrimental. So that is why later on, the approval was actually, modified. And what you need to do is, suppose a patient can receive chemo, but you want is cisplatinum ineligible, then you should do the PD-L1 testing, because if you find that it does not reach those marks, then that is 5% for IC, atezolizumab, and 10% for CPS, that is pembrolizumab, then you would offer the patient gem-carb rather than give the immune checkpoint. So it is still, if the patient can still receive chemo but not cisplatinum, then you should still be doing the PD-L1 testing. So I think that is very important to remember. However, if the patient is not eligible for any chemotherapy, you are left with no option. So then you would not be doing, so whatever small benefit that patient would receive from immune checkpoint, you would give it. We have already answered this question of how frequently you do the PD-L1 expression and what are the methods and antibodies. So just coming to the methods and antibody. So can you tell me, like in your experience, let's begin with Dr. Shivam and Dr. Akshay, which are the antibodies available in India? There are a whole lot mentioned over here, but out of them...
Ma'am, I'm frequently using SP142 as one of the options because it is a complementary test in other cancers also. 263 is also is what is available. I'm using it. So these are the two which frequently using it. Some labs are offering DACO, but 142 and 263 is what I am commonly using.
Yeah, and of course you use the 22C3 also if you're going to use
DACO 223. That's the only thing which is available.
Yeah. So anyone else wants to differ from this?
No, madam. Actually, these three tests are available. That is DACO 22C3 platform, SP142 Ventan, and Ventan SP263. So nowadays for atezolizumab we prefer SP142 for the IC values. And now DACO also there, we are using it less oftenly, as SP263 is there, which can predict the response to pembro and duro also, as far as lung cancer.
Yeah. So then, you come to the, these are the two studies which I've already mentioned, and you already know the data, you're already using it, so I think we can just skip this slide. So this was the IMvigor 210. The eligibility criteria was for all comers. But then, as I mentioned, further analysis showed that you do need the cutoff points of PD-L1. So this was the study, and this is the 5-year clinical update. Now, Dr. Ashish, can you just look at the median overall survival? Like, you have a median duration of response which is according to expectations. Just look at the median overall survival in the cohorts, all comers, PD-L1 and PD-L1C23. What do you find?
So the PD-L1 19.1 is what hovers in the with the N of 87.
Yeah, so little bit of contradictory results there. Like, the overall survival events are much less in the high PD-L1 expressors. But if you look at the median overall survival, then it's shorter by almost 7 months in those as compared to those with low PD-L1 expression. But I think this may be because, the last group is very small numbers. So it may be explained on the basis of numbers. However, if you look at the 60-month overall survival, then you can see that it's better in the high expressors rather than the low expressors. So little bit of contradictory results, and the only explanation is that small numbers in the last group. Okay, so now, this is the treatment options. I think I can skip these slides, we have already covered. And this is a metastatic bladder cancer, third patient, 84-year-old, diabetes and hypertension. He's just not fit for chemotherapy. So here, would you do a PD-L1 testing? No. So you would straight away go for, whatever the option, that is the immunotherapy option. So now you have two studies. You can't do cross-trial comparisons. Is there anything to, make you select one over the other?
Somebody who has got better PAP, I will go for it.
Yeah, so it's mainly the PAP.
The side effect profile
as
also.
you know, that
we are more comfortable using atezo as compared to pembro in terms of side effects.
Okay, and second thing is at the moment for first line pembro, you don't have the PAP. So that is, otherwise, they're almost equivalent. So there's nothing to choose between the two except the PAP program. So what we know in first line is chemotherapy is active in this space. Cisplatinum eligible patients should get cisplatin, not carbo. And FDA and EMA warn about decreased survival with first line atezo and pembro in cisplatinum ineligible patients with low PD-L1. So that was the point I wanted to drive home, that if you can use carbo here, that would still be a better option than offering them immune checkpoint inhibitors if they had a low PD-L1 expression. And as with the appropriate companion diagnostic test. So that is the thing. And again, this is the regulatory status. As you know that atezo, you do have the program, a PAP program, whereas you don't have it with pembro. So I think this is just a repetition of the previous slide. And this is the change, as I mentioned, that first it was all comers and now, you have to qualify by the PD-L1 status. And then these are all the approved indications. Is there one indication which we have not covered in the metastatic setting?
So the maintenance therapy.
Right. So how do you use maintenance therapy?
So those patients who have received platinum-based chemotherapy in the frontline setting and after 4 to 6 cycles, those who have got a stable disease or a partial response, then the Javelin is showing avelumab, there is a data of using maintenance therapy in the metastatic setting. Avelumab.
Yeah.
And nivolumab, you have got a data for maintenance post-radical cystectomy.
Yeah.
So these are the two setups where atezolizumab and pembrolizumab, there is no conspicuous data.
So Dr. Shivam?
Ma'am, I think, avelumab in a maintenance setting, although I have not used it, patients keep asking about the cost of treatment. And once they are in remission, they want to be off treatment, most of them, because I don't know whether they will respond to platinum again. A lot of these patients, they come back after a year, 2 years, and we re-challenge them with platinum. So these patients are not opting for avelumab, but this is one domain which we want to use.
As far as this re-challenge with platinum is concerned, you're going to use only 4 cycles of chemo, 4 to 6. And then you're putting the patient on avelumab maintenance. So even if they relapse after a year, you can still use platinum. Yeah. So now my question is, keep cost aside, okay? But if you have a patient who is cisplatinum ineligible, so then you're talking of single agent immune checkpoint inhibitor, but you can still use GemCarb. So would you go for GemCarb and avelumab maintenance, or you would go for one of these 2 agents?
That's where probably PD-L1 would help.
Right. That's the important point, that here the PD-L1 would definitely help. For avelumab maintenance, you don't need PD-L1 testing, so any comer would be eligible. But if the PD-L1 was high, then you have the option of using, but then you don't know that whether that chemotherapy would add anything even there. You don't have the data. So I think these 2 options are still open, so that is important. So this is now the future that we are looking at. This hasn't got approval. And just like lung cancer, I think we are going the same way here, that you have the IMvigor 130, where all comers, irrespective of PD-L1 status, receive chemotherapy or alone or you use atezolizumab alone, or you use a combination of the two. You only have the initial results, and that shows that at least in the PD-L1 C2, 3, those patients are getting a benefit for the combination versus the single agent chemotherapy. So we don't know what is going to be the FDA approval, and what it seems the results are going to be out this December or Jan, and then we would know that what sort of approval one would get for this combination of chemotherapy with immune checkpoint inhibitor. So, once you get, suppose you get an approval, then again you have a dilemma in front of you that are you going to use switch maintenance, or you want to use combination from before? And I think we can't do any crystal gazing here, so we just have to wait for the data. So I think this question becomes redundant. Then, of course, this is the Javelin study based on which you have the switch maintenance. Now, I just want to know, I mean, this is just a summary of what we have discussed. Do you do mutation analysis on urothelial carcinoma? So I want to know, yes.
FGFR?
Yeah.
So that's what we look for.
Yes.
The best part is that, ma'am, when we use atezolizumab in any setting, they would support foundation 1 on progression. So I think that it becomes easier for us to look for a mutation.
So you can
analysis.
do the foundation 1
Yes,
and look for FGFR.
FGFR mutation.
Yeah.
FGFR, NTRK, and some HER2 also.
Yeah, NTRK is not expressed here, but FGFR is what, you have, it's a tongue twister if any of you can.
Adrafitinib.
Yes, so that is the drug. And that has been used, it's mentioned here. And then, any of you had a chance to use that drug? No. So it's approved post-immune checkpoint inhibitors. And what about the ADC, that's showing a lot of promise. And I think that is showing promise in almost every malignancy. So I think that is also a very important drug to keep in mind for the future, though out of the reach at present. So I think with this we come to the end of our discussion. If there are questions from the audience.
Thank you, ma'am. It's always a learning pleasure.
Thank you, ma'am. Thank you so much, ma'am. Thank you so much.
Thank you, ma'am.
Welcome.
Thank you, Doctor. Sir, ye le lijiye.
Thank you, Dr. Smriti. I will also to join for the photo with you. Thank you for that. Was a nice discussion, and Dr. Smriti had made very elaborate explanation regarding when to do the PD-L1 and which IO to be used in whichever settings. Thank you very much, Roche, for inviting all of us.
Thank you, Dr. Smriti and Dr. Mahbub Asare, for this excellent session. And I thank the panelists as well. We come to the end of an exhaustive and enriching day, and we shall continue the academic feast tomorrow. I wish you all a pleasant evening, and I take your leave with the promise of an early start of the day tomorrow. Goodbye, good night.